Reit, bore da, a chroeso cynnes iawn i bawb i gyfarfod o bwrdd iechyd Brifysgol Betsi Cadwaladr y mis Medi yma. Croeso cynnes iawn i bawb sydd wedi ymuno â ni yma yn Fenyw Cymru. Croeso hefyd i chi os ydych chi ymuno ni ar-lein. Mae gennym ni gyfarfod pwrpasol heddiw, agenda go hir, fel mae pob cyfarfod o'r Bwrdd Iechyd, ond dyn ni'n edrych ymlaen at gyfraniadau a sgyrsiau diddorol, dwi'n siŵr. Felly, croeso cynnes iawn i bawb. Dyn ni wedi derbyn nifer o ymddiheuriadau oherwydd salwch, oherwydd galwadau eraill yn ogystal. Mae gennym ni restr o'r ymddiheuriadau yna. Dyn ni'n falch o groesawu George yma sy'n dirprwyo ar ran Jason, felly diolch fawr iawn George am ddod i'r cyfarfod yn lle Jason sy'n methu bod efo ni. Oes na rhywun arall sy'n ymddiheurio dwi ddim yn ymwybodol ohono fo? Neu hi? Na, dwi'n bosib Vaughan, ie, ni'n gweld Vaughan Roberts falle fod Vaughan yn cyrraedd yn hwyrach falle. Cyfarfod cyngor heddiw yn Ynys Môn, wrth gwrs, ie. Ac mae yna eraill, Chris Lockbot, wrth gwrs, yn sawl ac yn absennol. Felly byddwn ni'n sicrhau bod yna eraill yn cyfarch y papur mae o'n gyfrifol amdano nhw. Iawn, popeth yn iawn o ran ymddiheuriadau. Yr eitem nesaf sydd gennym ni ydy datgan buddiant. Unrhyw buddiant yn wneud ar agenda dyn ni trafod heddiw, sgwelwch yn dda, unrhyw un eisiau datgan. Na, felly symudwn ni ymlaen. Mae'n ddrwg iawn gen i, Claire?
Mae'n ddrwg gen i, it's too slow putting my hand up, Chair. The item on CHC fees, I'll leave the room for that item.
OK, fine. Diolch yn iawn, Claire. Rhywun arall? Na, o'r gorau. Diolch yn iawn. Symudwn ni ymlaen i'r eitem nesaf, felly cofnodion o'n cyfarfod blaenorol Gorffennaf 25. Di pawb yn hapus i ni gymeradwyo'r cofnodion i sgwelwch yn dda? Iep, diolch yn iawn. Materion yn codi ar camau gweithredu. Unrhyw sylwadau gen unrhyw un i sgwelwch yn dda? Unrhyw beth i ddweud am y camau gweithredu, neu pawb yn hapus i'w derbyn nhw?
Sorry.
Yeah.
Just i ategu be ddidodd Diane gynne, bod y sain ddim just achos mae o tu fewn i'r stafell.
Ydy.
Just i fel bod o ar gofnod.
Diolch. Unrhyw un eisiau dweud rhywbeth arall? Na. Gorau, symudwn ni ymlaen at yr eitem nesaf. Eitem ymwneud ar adroddiad profiad dinasyddion, ac wrth gwrs mae'r eitem yma yn un sy'n dod i ni yn chwarterol, dwi'n credu, rwan fel bwrdd. Mae'n eitem sydd yn cael ei werthfawrogi. Mae'n cynnwys fawr iawn yn dal profiadau pobl sy'n defnyddio'n gwasanaethau, teuluoedd, ac yn werthfawr iawn i ni fel bwrdd. Fel gydag adroddiadau blaenorol, dwi'n meddwl mae'n wir i ddeud bod yr profiadau ma pawb yn cael o ddefnyddio'n gwasanaethau o'r hyn dyn ni'n darllen yn amrywiol. Ac dyna un o'r heriau. Ma' 'na themau yn datblygu yn does o gwmpas yr adroddiad yma bellach. Un ydy bod pobl yn cael gwasanaeth da iawn unwaith maen nhw'n derbyn y gwasanaeth, fel dyn ni'n gwybod, ond anhawster pobl i gael mynediad at y gwasanaeth yn y lle cyntaf, boed ar rhestr aros neu weithiau pan maen nhw'n aros yn yr ysbyty i gael ei gweld. Profiadau yna yn rhai negyddol at ei gilydd. Felly mae'r themau yna yn datblygu ac dwi'n awyddus i ni weld be dyn ni am wneud wrth ymateb i rhai o'r pethau sydd wedi cael eu codi yn yr adroddiad. Ond dwi am droi at Helen, os ydy Helen eisiau manylu ar rhai o'r pethau, a diolch fawr iawn am y holl waith sydd wedi mynd i'r adroddiad, sy'n un cynnwysfawr iawn ac yn ddefnyddiol iawn i ni. Helen, drosodd at y ti.
Diolch yn fawr iawn, Cadeirydd. This report, as we progress throughout the months and evolve it, we're learning and adding more. So this time you'll see that there's a little bit more detail on some of the work to address the issues that we have. It, of course, combines a range of information from across different teams and departments in the Health Board, not least the patient experience team. We also have the community engagement team that are out and about, the correspondence that we receive from our politicians, and digitally we have lots of conversations. As you can imagine, that is a growing area where people are keen to engage, and also through our colleagues at Llais, who are the ears and eyes of our public. The themes are pretty consistent with earlier reports, particularly around access, waiting times, poor experience. There's some examples there of the emergency department. In our correspondence with politicians, we're seeing themes emerge around mental health access, dentistry, of course, ophthalmology and neurodevelopment assessment weights as well. So these are some of the key themes. We're joined this morning by both the patient experience team. We've got Leon and Rachel, who are able to go into a bit more detail if colleagues want to ask questions, and also Jeff from Llais is here as well this morning. So happy to take questions.
Diolch yn iawn, Helen, and yeah, warm welcome to the team who do a lot of work with the patient experience. I know, and I was glad to have had conversations over the last few months, and Jeff, of course, from Llais. I'm going to ask someone to address an issue in a minute, but I'll bring others in. Unrhyw un eisiau cwestiwn yn rhyw sylw, a wedyn mae gen i rhywbeth benodol i godi. Mae gen i Rhian yn gyntaf.
Just a very, very small thing. I very much welcome the report. Obviously, there's a lot of really interesting stuff in there, but very clear themes as well. Just being picky, when you say, you said, we did, like that, but following it, you've got we will share, we will do. No, we share. I think by using will, it suggests that's something in the future, but no, I'd like us to be emphasising that we are doing it now. So that's just me being picky, sorry.
Okay, diolch yn iawn. Unrhyw un arall, Claire?
Diolch. Lots of the themes that come out in here actually are addressed. Can you hear me?
Just.
Okay. Lots of the themes that come out are addressed in other items on today's agenda, so I won't pick any of those out. One of the ones that interests me is the Small Business Research Initiative,
Yes.
which seems to have been really well welcomed by families of patients.
Yeah.
But it looks like it falls into a black hole now, which is, we did this initiative, it was great, it's all being analysed. So my question is, so what next? Is it something that we could mainstream ourselves? We don't need to wait for the Small Business Research Initiative or Welsh Government or somebody to, if that's been so valuable, that doesn't sound like an expensive new service, which could really help staff as well as patients once the whole thing settled in from the evidence in the paper. So,
and we went along to an event, didn't we, and heard about that. do you want to come in and share?
I saw you moving forward.
Share the experience and what the next potential steps are.
Yeah, of course. So I'm Rachel Wright. I'm the Patient Carer Experience Lead. So I was involved in the SBRI Patient Communication Project. And we involve patients in the development of the system and engagement throughout. So the project ended. We had Welsh Government funding, you see, to run the project.
Yes.
So the funding has ended,
So
but we're currently reviewing the benefits. So we've had independent staff analysis. Staff are telling us it was a great concept. Patients are telling us actually, and relatives. Patients felt more assured that their relatives were up to date with how they were. And in particular for people that worked or lived far away, they really benefited from receiving that message. It prevented them from having to ring in. So we know it worked well, the concept. So we know we need to improve communication, but how do we do it? There's obviously a financial cost associated to this pilot, but there are going to be some developments in our telephony service and how we can contact patients through SMS and other routes. So this may be one consideration we could use in the development of communicating with patients.
Good.
But yes, we know it works, but the next step is now to agree, what do we do really in terms of investment?
And I think that the challenge is clearly the social return on investment in terms of what patients benefit from is clearly there, you know, in terms of the cost versus the benefits. And I suppose that's something that we need to consider as a health board planning forward, because obviously the better we communicate, the less complaints we have, the less concerns we have. So it not only improves communication in general, but it has wider range of benefits across the organisation as well.
And the system can do a bit more. So one of the developers in Ysbyty Gwynedd was voice notes, so a bit like a voice message.
Yeah.
And his concept can also be recorded for clinic appointments, you know, whether it's oncology and other appointments. So actually the patient can go back and listen and then think about questions.
And I think that is the point, that what the pilot has done, Claire, it's raised possibilities across all services really. And I think we need to take some time to think, how can we use technology better and further to engage with patients and families? And that pilot has shown that simple things like texting people just to keep them informed is a really great way of supporting people whilst they're with us in hospital. So I think that there's more work to do there and possibilities to explore.
It's also worth noting, Chair, as well, it's been shortlisted for the finalist as a Patient National Experience Award in Birmingham on the 3rd of October, that initiative. So it's been recognised as best practice on a UK basis. So fingers crossed.
Proud,
And report next time that we're the winners.
We'll look out to see any good news on that. Great. Gareth, gynta, wedyn Dyfed, wedyn Dylan.
Well, first of all, just to say, you like colleagues, I think it's a really good report, and I think it seems to me, from what I know, to be really balanced in terms of both the good and the bad. 2 points I want to make. One is a small sort of one, hopefully not too picky, but we should be careful where there's small samples. You recognise with the ED stuff, it's a very small sample. But so saying, you know, there's a significant improvement, we need to be careful about that because it's we don't know how representative it is. As I said, generally, I think we've got good data, but that's one area, and I know you work on improving it. But you know, we get all these things about our significant charts, don't we? So. But the other thing, more importantly, is the section on mental health, and I know it's only like a number of quotes, and I know that's a few individuals, but you know, I just to reiterate this, I think speaks to the concern that I've voiced on a number of occasions about the fact that although we look to be doing well in terms of our, you know, the performance indicators on mental health, that they're carrying a huge amount of risk. And the question about the case where somebody had not been seen by a person for 12 months, even though, so they'd have been called, as you know, they ticked the box, but they haven't got a care coordinator, you know, so they've not got somebody who's actually looking after them. And, you know, what I want to be clear is this is, insofar as it's a failing because of the imbalance between staff resources and the number of referrals, but it is a really serious situation, and it comes back to the point which I'm sorry I keep on banging on about, but I will continue to bang on about making sure that we're making accessible more services in primary care, particularly at early stages of intervention. So, you know, But as I said, it's really good to bring this sort of qualitative information as well as the quantitative, because it makes us think, even if they're not wholly representative, that's one person, and I'm absolutely sure those are real cases. So
Am I okay to comment on the emergency department data?
Could you just pause for a minute, please, because we're going to have other questions, and then I'll ask other people to bring in, if you don't mind, Rachel. Thank you. Dywed wedyn Dylan.
Diolch. Gadeirydd, pwynt bychan, fel Gareth a mae rhian wedi dweud, mae'r adroddiad i'w chroesawu. Ella beth swn i'n licio weld ydy patrwm, fatha, neu trend, pan da ni'n cymharu canrannau o ran adborth. So bod ni'n gallu gweld wedyn lle da ni'n mynd, be di'r patrwm, ydyn ni'n wella ac ella gallu perthnasu hynny wedyn i y pethau da sy'n digwydd i wella, so bod ni'n gallu gweld mae hyn wedi digwydd a mae o wedi cael effaith, just rhywbeth bach ydi o mewn ffordd, ond fysa fo'n rhywbeth defnyddiol, dwi'n meddwl.
Diolch yn iawn, Dylan.
Diolch. No, I was just going to say I'm responsible for SPRI in the health board, but just to explain that SPRI is part of the Innovate UK group,
Yes.
And that is primarily to run pilots and research pieces. And sometimes some of the businesses, might not decide to take that product forward.
Yeah.
So we have got to be, careful about those things. Totally appreciate the situation, but it's as much up to the business as well as us to develop a business case for moving forward.
Yeah.
Just so people were aware of as what the purpose of SPRI.
Okay, diolch yn iawn. Cwestiynau? Unrhyw un efo cwestiwn? Cwestiwn?
Mine's very straightforward. The new telephony system, you've got a number of routes which can are now called as to access. Would it be possible to add the sort of to the vaccine and immunisation service? Because we get a lot of patients calling that. So if that was part of that, that would just be helpful, so that we sort of support people getting through as easily as possible.
Okay, if we can take that back and consider how we can do that then. Mike, question?
Thanks for the report. Minor point really. A number of us were at the mould engagement event a few weeks ago, and on our table we did come across a couple of people who'd had difficulties. Full of praise for PALS, pleased to hear. But one of them hadn't quite realised that once PALS have initiated the process, it's up to the rest of the staff to deal with it. So they've been calling back PALS. So I just wonder if you need to flag that, once the job is done and the information is passed on, it's up to the responsible people there to respond rather than keep bringing you back, because you don't get a closure is what this patient was telling us. You don't have the information. You're busy dealing with the front end. So
okay, we'll ask you to come back on that in a second. So rhywun arall efo cwestiwn? Os nad oes, dwi just isio anybody who can pick up some of the matters that raised, and I want in particular to talk about experience of people in ED and what I can call ED plus, people on corridors, and that's a matter that people raise on a frequent basis. It puts our staff under huge pressure, as well as not a great experience for patients and their families, and I'm just wondering what we are doing in that space to try and improve things. It's really tricky because of the huge pressure coming into ED. We try to deal with that, and one way of dealing with it is trying to get people into every nook and cranny we've got. But I'm just wondering what we are doing to try and improve, because there are people on corridors for hours and hours and waiting for beds, and they are really ill. And if we can do anything in everything we do, it seems to me that's one of the things we should be trying to improve. Really, really difficult to understand that. But it's something in terms of the patient experience that we should be trying to improve with all our efforts. So I'm raising that in particular because it's a theme that's cropped up. So if you can take that and all all the other matters, I'll give you an opportunity to come back at the end on the general matter of the work you do and where it goes afterwards. So maybe, I know Angela wants to say something, and then Carol, and I don't know if Helen wants to come in as well, the opportunity for you to do afterwards.
Thank you. So obviously ED and the overflow of patients, if you like, is something that we're really, really concerned about as clinical teams and operational teams. And Imran and I are working together with the IHCs currently to look at a period of a programme of work where we are identifying some of the areas of hold up. So obviously delayed transfers of care of patients who are waiting to go home or into care, into the community for packages, etc., is something we're working on. But we're also looking at that patient experience in the waiting room. So it's great that we've got metrics now that we can say we've got improvements, that we're capturing some views. When we get more views, then we'll be able to do some targeted work as David identifies on that. I think we're trying to make sure that that safety element is very, very keen at the front door and on those corridors. So we're reviewing the staffing models in ED, identifying how we can make sure that there's the oversight and support if we do have to have somebody without a traditional clinical area. And we're looking at how we can identify patients moving through the system out of ED into the ward areas in a safe way. So we were talking only yesterday around experience we've had around fit to sit. So if somebody is fit to sit out waiting for then we then potentially can use that clinical space to support somebody moving through the ED system. So there are a number of initiatives as part of the 6 goals work, but a programme which Gareth Evans in the Central IHC is leading on either emergency and urgent care, but it's very, very exec-led and clinically led. So just to give a little assurance, that is the work we're undertaking over the next couple of months. I'm expecting to see outputs before winter hits.
Okay, great. Carol, did you want to come in on some of that?
Yeah, and I think we'll probably get into a little bit more of the detail when we look at the urgent emergency care item. I think there's a couple of things for me. We've had some great study undertaken in our EDs during the summer by GIRFT, Getting It Right First Time. And what they're saying about our EDs is for 2 out of the 3, actually our demand and our capacity is generally in balance. The problem is people aren't flowing through the hospital. And so half of the ED footprint has got people who are waiting for a bed. And that pushes everyone else into a corridor, etc. So if we can start to unblock or flow the hospital system, that will immediately improve. So our big focus, and we'll come on to it later, but 4 points of focus, but the back door, if you like, helping people believe. It's as if people can't get in and people can't get out of healthcare. On an environmental note, we will look at the environment in which people wait. I was in Ysbyty Gwynedd the other week. Imran was there that week as well, chatting to people in the waiting room. And the chairs are very functional, if you like, but if you're there for a while, they're very uncomfortable. And so how we might have a range of different sort of seating options. And I know that sounds very simple and pragmatic, we also, it could make a difference. It needs to be infection control and all of that. But we'll have a look at those environmental aspects. But the root of making the experience better is to enable the system to flow through. If we can nail that, people will get a much better experience.
And that's absolutely clear in everything. That all the evidence we get is the pressures in the system then push people into circumstances that we don't want and they don't want. I think it's wider than ED.
Much wider.
I think it's across the system, the whole system under pressure. So the response has to be system-wide too.
Well, and if I may say, again, I'm trying not to run that paper now, but, I think there'll be some discussions and decisions for us to take as a board around how far we go in terms of really expanding community care support. Because we're concerned that people are getting poor outcomes as a result
Yes.
of being in hospital for way too long.
Yes,
And we can do some work in preventing people to come in where it's appropriate to do so, and we are. But ultimately,
Yeah.
people are deteriorating while they're in hospital with us whilst trying to get out. So how could we, and to what extent should we really shift a resource from
Yes.
hospital into community
Yeah.
to sort that through?
and I'm emphasising that not to offer difficult challenges, but because I know it affects everybody in the system.
Yeah.
It affects patients, their families, and our staff. You know, it's massive for us. So anything we can do there to improve, and as you say, it's the system-wide approach that is going to bring forward solutions. So yeah, I didn't want to preempt the discussion, but it's really, really important. It is a constant theme, isn't it? So to round up, I'll bring Helen, then Rachel and Leon, if you want to talk in particular about that matter, about all the inquiries you get, where do they go? I also want to consider this work is really quite comprehensive. How is it informing us? Is it going elsewhere rather than just staying just in this report? Is it help informing other work for committees and so on? So we can pick that up, then we round up the conversation. Diolch yn iawn. Helen.
Diolch, Dyfed. Ever so briefly, because I think it will come up in a later report, but I just would like to put the voice of the third sector and local authorities in the room, because I think if they were here, they would want to join
Yes.
in on that conversation, and they're very keen to be
Yes.
involved in that system-wide approach. The point I wanted to make was that that Leon and Rachel's team are putting a lot of focus and effort into ensuring that we are really getting some good feedback
Yes.
from
yes.
ED. If you follow us on any of our social media channels, you will see that we are really promoting that.
Yes.
And Jeff may want to say that Llais are about to do some work
Yes.
in EDs across Wales.
Yes.
So I think what this will give us is some very rich data
Yes,
that will inform what
absolutely.
that change might look like.
Great. Thanks so much. That's really helpful. Right, Rachel, Leon.
To answer the question, Chair, of where it goes to, which I think is the so what and ever so important, isn't it? So we've got extensive data sets, as Helen alluded to, which is triangulated against patient safety, patient incidents, complaints, and that work goes on extensively on a daily and a weekly basis. Once that theme analysis is undertaken, that feeds into the wider tentacles, really, of the organisation, through things like the Organisation Learning Forum, our Integrated Concerns, Mortality and Complaints Hub, which is a new development, the Patient Care Experience Strategic Group, and obviously in a number of different reports that we provide to the board. I think beyond that, because that's at board level or strategic level, we then meet regular through patient experience meetings, complaints meetings, operationally with the teams responsible for transformational change around patient experience on the shop floor. And we're making great strides, really, in improvement, which Rachel will fill you in.
Yeah, thank you. I just really wanted to, first of all, about the emergency department data. Yes, we acknowledge 316 responses is low. However, 316 patients or carers took their time to share their feedback. I want to provide assurance that we are currently working through setting up SMS feedback surveys for the emergency department, and work is in progress. So 48 hours after a patient's discharged, they will receive a survey. So returns should significantly increase. However, we've got to learn from those 360 feedback responses. So, on a monthly basis, matrons ward managers review their data. On a quarterly basis, through the corporate patient and care experience groups, IHCs are required to report on their Civica data. They're required to tell us their learning and good practice. And our ED data is fed into the 6 goals, urgent and emergency care. So even those 360 responses, they're actually fed in and they're listened to. And overall, you'll see that every month we capture a significant amount of feedback returns from Civica, our standard survey, 14,000, which is immense, isn't it?
Yes.
And really those structures are similar to what I said.
Yes.
On a local basis, they're looked at, their learning is identified, promoted to patients on wards and services, and then we do that drilling down. So it's really important that we do look at all of our data.
Yeah. Okay.
And just one quick closing remark, sorry, Chair. Carol mentioned it before about the hard plastic chairs, and you'll be surprised how frequent that is a theme in complaints. And I think the public are accepting of the challenges that the NHS has got in ED, and that's not really the theme of their concerns.
No.
What they want to do is, while we're waiting, and we accept that we need to wait longer than perhaps we'd want, can we wait well, you know, and wait in an environment that's suitable? Absolutely. So I think it is a really critical point that what we can do to improve that experience, comfort, privacy, dignity, is a critical step for us.
Yeah, thank you.
No, that's a really good point, and thanks very much for all your work. Really good work. The thing about all of this is it's a resource to help us improve. That's the thing we wish to emphasise. I also wish to emphasise that I'm keen that some of the discussion we've had today actually can happen in one of our committees, the Quality, Safety, Patient Experience Committee, that can drill down into some of this stuff and have more detailed conversations. So if we can give that some consideration, particularly when there are reports that Jeff and Llais are doing in detail about emergency departments, you know, that will be a rich opportunity for us to look at how things are going, maybe. So I can ask Pam maybe to look at how that can work. But thank you very much for the work. It really is appreciated, and it gives us that insight, which is all important. Diolch yn iawn I chi, a diolch I bawb am y gwaith ar hynny. Symudwn ni mlaen i'r adroddiad nesa, ond gofyn I ni gyd nodi yr adroddiad yna gyda'n diolchiadau pawb yn hapus yn neud. Diolch fawr iawn. Ymlaen i'r eitem nesa ydi adroddiad y cadeirydd, ac dwi ddim am aros yn rhy hir ar adroddiad tro hwn, oherwydd mae mis yr haf wedi bod yn dywelach ar un wedd, ond yn prysurach ar wir arall, wrth gwrs, oherwydd mae yna nifer o newidiadau gwleidyddol wedi bod. Fe gawson ni gyfarfod gyda Mark Drakeford, oedd yn weinidog iechyd ar y pryd, a rwan wrth gwrs dyn ni wedi croesawu Jeremy Miles i'r swydd, a dyn ni fel cadeiryddion byrddau iechyd, dyn ni eisoes wedi cael y cyfarfod efo fo, cyfarfod adeiladol iawn, ac yn gyfle iddo fo rannu eu syniadau, a ni'n fel cadeiryddion hefyd rannu ein meddyliau ni. Dwi'n meddwl bod yn wir I ddeud bod ffocws Llywodraeth a'r ysgrifennydd cabinet yn ymwneud ar hyn dyn ni newydd drafod mewn gwirionedd. Mae dal o gwmpas gofal wedi gynllunio rhestru aros. Dyna fydd ffocws y Llywodraeth dros y flwyddyn nesaf, ac dyna fyddwn ni'n gorfod ymateb iddo fo yn y cyfarfodydd misol dwi'n cael efo'r ysgrifennydd cabinet, ac yn y cyfarfodydd dyn ni'n cael o dan mesurau arbennig, wrth gwrs. Felly dwi am beidio ymelaethu mwy, ond yn hapus os ys rhywun eisiau codi rhywbeth neu ateb unrhyw gwestiynau. Diolch fawr iawn. Unrhyw un eisiau codi rhywbeth? Na, ga I ofyn I chi felly dderbyn y adroddiad yna, a symudwn ni ymlaen I adroddiad Carol, adroddiad y prif weithredwr. Carol.
Thanks very much. Hope the report was helpful to members. I'll just pull out a couple of key headlines really. One is that the Welsh Government have published the latest quarterly report on our progress as an organisation against level 5 special measures escalation. We've shared in a short video with the organisation an update on that, and I think it's pleasing to see the recognition that improvements are being made, but still a long way to go. So that's really the headline on that. These reports are regular, so I think the next one is scheduled for later in the autumn. so the public are able to see the progress that we're making on that. Really pleased to say that Imran is with us as Interim Chief Operating Officer. We're delighted to welcome Imran. This is a key role, and particularly ahead of winter. We're going to be discussing urgent emergency care as a key theme today, I feel. So that's great. The recruitment processes to the executive team continue, and Stephen Powell will be with us at our next meeting as the new Director of Performance and Commissioning, and we're working through other appointments as we speak. So that's great, great news. There's an item a bit later on the COVID inquiry, but just to say that the Thirlwall inquiry that I have reported here before has now commenced taking evidence. So we haven't been invited to give evidence yet, but we have submitted information to the inquiry. So we'll keep members updated as that progresses as well. The other one or two things just to draw out. I think Mike mentioned the engagement session at Mould. These started to get you know, a bit of a head of steam. I very much enjoyed the session, and I think we'll be in Pwllheli in November. I look at Mike because Mike's obviously the mayor of Pwllheli, so all round to Mike's place. Yeah. So and I think, you know, bit like the item that we've just discussed, you know, maintaining this open door, and transparent approaches is key. I won't touch on culture, leadership and engagement, but I do just want to say tomorrow is the Staff Awards. Very much looking forward to that as well. And then just finally, I'm sure we'll get a chance later on, but is to recognise that Healthcare Inspectorate Wales have de-escalated Ysbyty Glan Clwyd Emergency Department from a service requiring significant improvements. The reason I draw that out is we know that the experience of very many people who come to our EDs is not great. We just talked about that. But those improvements are coming through now, and I think having an external body review us in that way is helpful, and I hope gives confidence to people when there's such a dialogue in the public domain about the NHS, but gives confidence to people that we are improving services. It is tough, and it is going to be tough through winter, I've no doubt, but it's important to stress that. And that's it from me. Happy to obviously take any questions on any part of the report.
Diolch yn iawn, Carol. Unrhyw gwestiwn neu sylw? Dwi'n gweld felly, Gareth.
I just want to say very briefly that how great it is that, Carol, you're taking the time to meet families of people who've been affected by, you know, untoward incidents. And I don't think that's always been the case. Well, I know it's not always been the case in the past. I know, A, you're busy, and B, it must be emotionally draining, although not as emotionally draining as it is for the families, but it's absolutely the right thing. And I do really just want to say thank you for doing it. I think it's really setting a very positive example.
Yeah.
May I just say, you know, it's been a great experience. I know Angela and David have joined me in some of those, and the commitment that has been made to those families, and Angela and the team are supporting this work, is that we will go back to each and every family and say what action we've taken, and to demonstrate the evidence of that action being embedded. And actually long-lasting changes happened as a result. And I've been amazed at the kind contributions to learning that family members have made. And I think I pulled out in my report that Mr. and Mrs. Munslow, who sadly lost their son Lucas, and they're working with us to promote meningitis awareness. So I think we've all been aware of the red rash in the glass, but this was not that presentation, and so even in such sad circumstances, they want to work with us.
Diolch yn iawn. Rhywun arall eisiau codi cwestiwn? Os na gai ategu fy hyn mae Gareth wedi dweud, a diolch i Carol am yr holl waith mae hi'n cyflawni yn ddyddiol y wythnosol ac yn sicr yn wyneb gyhoeddus i'r bwr iechyd ac yn amgysylltu gyda phobl sydd yn cael ei werthfawrogi. Felly diolch fawr iawn Carol am yr holl waith yn ystod y mis neu ddau dwytha. Pawb yn hapus i dderbyn yr adroddiad yna. Diolch fawr iawn. Ac yr eitem nesaf ydy adroddiad yr is-cadeirydd, Gareth, that's a team.
Diolch yn fawr, Cadeirydd. Yes, just to say, you know, there are a number of themes in this which I think colleagues will be familiar with because they're things that I bring up in other meetings. So I don't need to belabor them, but I'm very happy to take any questions or indeed talk to colleagues outside the meeting if they want to raise issues with me. But hopefully it's of at least some use to get an insight into what is driving some of my concerns.
Diolch yn iawn, Gareth. Unrhyw un efo cwestiwn, unrhyw sylw i Gareth? Na, os nad oes gai diolch yn fawr iawn i Gareth am yr adroddiad a'r gwaith sylweddol mae o'n wneud. Mae Gareth yn teithio gwmpas y gogledd Gryndychin yn ymweld ac yn cael sgyrsiau ac y ffordd yna mae o'n dysgu ac yn gallu rhannu wedyn o'r profiadau yna efo ni ac gyda staff ac dyn ni bach iawn o'r gefnogaeth mae'n rhoi i'r gwasanaethau. Felly diolch Gael am yr holl waith Gareth yn ystod y misoedd dwytha. Pawb yn hapus i dderbyn y adroddiad yna. Diolch yn fawr iawn. Ymlaen at yr eitem nesaf sef siarter y plant ac dwi'n falch iawn o groesawu unwaith eto Alex a Scarlett at ni, croeso cynnes, a dwi'n meddwl bod Liz yn mynd i helpu cyflwyno a Jane hefyd, ac i egluro wrth rai oedd ddim efo ni ddoe yn ein cyfarfod ddoe, gawson ni gyfle i gael sgwrs anffurfiol gyda chyfeillion o gwmpas siarter y plant ag be di'n uchelgais ni o ran gwaith gyda plant a phobl ifanc. A dwi'n falch iawn o gael y cyfle i groesawu chi'n ffurfiol i'r cyfarfod heddiw. Ac roi cyfle i chi, felly drosodd at chi Jane a Liz yn gyntaf. Diolch yn iawn.
So I think I'm just going to introduce the young people. So this is a piece of work that's been going on for some time, has involved young people from across.
Can you speak up a little if you don't mind? Thank you.
So this is a piece of work that's been going on for some time. It has involved young people from across North Wales and is really about how do we engage effectively with young people and how do we ensure that young people have a voice in terms of how the health board is developing. So what I now want to do is hand over to Alex and Scarlett, who are just going to very briefly introduce the charter.
Great. Thank you very much. Over to you.
Thank you. So I'm Scarlett, and before we start our presentation, we just wanted to thank you for the opportunity to talk to you today and to be the first young people invited to present to the board. We hope this is the beginning of the board's direct discussion with and learning from children and young people.
So did you know in North Wales there is a population of around 182,317 children and young people living here? Over 300,000 appointments have been made to children and young people between January to March this year alone. Children and young people don't just use children's services, they use a range of services such as safeguarding, physiotherapy, vaccinations in schools, mental health services and emergency departments, to name a few. So why does this work matter? It matters to me because through my own personal experiences, I know what the Children's Charter will help professionals to give children and young people the confidence to have a voice on what happens to them whilst under the care of hospitals and doctors in an age-appropriate way.
At a time when children and young people still have many decisions made for them in the field of health, I believe that creating an environment that allows them greater autonomy and a sense of trust is vital for a safe, accessible and reliable healthcare system that upholds its duty of supporting and respecting children's rights. I believe that the Children's Charter will enable the voices and opinions of children and young people to be integrated directly into the Health Board, representing their views at all levels of service. The hope I have felt whilst working on the Charter and recipe book and the engagement of children and young people during the formation of the Charter is a testament to the positive contribution young voices have and demonstrates our eagerness to influence the development of services to better nurture our physical, emotional and mental well-being, both presently and for future generations. As well as the Health Board, I know the impact of the Children's Charter will reverberate across Wales, influencing communities to develop with the direct inclusion and input of children and young people. I hope that the Children's Charter is only the beginning of the inclusion of young voices in health services and cannot wait to engage with the board further in potential future discussions. So considering your role as duty bearers and thus having the responsibility to ensure children's rights are upheld and championed, do you endorse the Children's Charter and commit to its integration across the Health Board? And will you consider working with us to further develop and support the voices of children and young people in North Wales?
Thank you for listening. And now we hand back over to Jane Moore to formalise Children's Charter, and we're happy to take any questions. Thank you.
So I don't really think there's many more for me to say, but if you have any questions.
Diolch yn iawn. Thank you very much for that, and thank you for your words. Unrhyw gwestiwn neu sylw? Right, lot o gwestiynau. Mike yn gynta.
Thank you very much for your presentation. I heard it yesterday as well. It was very articulate. I noticed on some of the paperwork somewhere that young people's favourite place or safest place is my room. So my question is, what do you think is the preferred mode of communication and contact with young people? You know, is it text? Is it face to face? What would work best for us? I know we've got representatives, but that interaction with the Health Board, how do you think that would best work?
Any thoughts about that? That's a good question in terms of how do you and maybe young people, you can't speak on behalf of every young person, but in general, what guidance can you give us in terms of communicating? Any ideas on that?
I think young people and children and young people are very complex, and they got their own different ways. And then
yes.
You also encounter, you have a range of people with different, how they communicate with people is very, very different in terms of they might have a medical need or additional learning needs. So there is not just one point, not one answer to cover a range of it I can tell you of. But I know young people, they use a range of ways to communicate, like how they communicate with their friends. I know WhatsApp is what they use to talk to professionals, but there is no one answer I can say at this moment in time.
I think that's a really good point. Yes. Any thoughts, Scarlett?
I suppose I was just going to add to what Alex said. I think it's hard to. So I certainly can't speak on behalf of all children and young people, and I think it's hard to talk about communicating with them generally, because every child and young person has their individual preference for communicating. So sometimes it will be face-to-face engagement, whether that is with the health professional they're consulting, or perhaps at higher levels. Sometimes it is through emails or text messages. So I think it varies, but one thing that is important to children and young people, I believe, is a constant stream of communication. Even if there isn't a kind of general one method of communication, that constant engagement with a child and young person, that reassurance, the presence of health professionals in a dialogue with children and young people, I think it's not a general mode of communication, not a general mode of communication, but consistency in communication that's important, if that answers your question.
Yeah, good point. Yeah. Right, on the public, David, Gareth, Rhian, Chris.
Diolch. Thank you. This is again, one of the most, since I joined the board, this is a really key moment in us hearing you both yesterday and today, and how important that is. We're thinking about it from using the service but for me, it's about young people at the future of this health board in so many different ways. I chair people and culture, so you know, getting people into this organisation, people who want to be part of this organisation. This is all a key part of that. Is for young people to understand what this health board is, what it can be for them and their families and their friends. So again, I just want to thank you for this morning and for yesterday. Diolch.
Nessa, Gareth wedyn Rhian.
Just very briefly say, yeah, I think it's excellent, really excellent piece of work. You can all be really proud of it. I particularly like the poster, which I think is so effective, and I hope that we will have that very widely displayed. I also want to say it's a slightly possibly more controversial, but why it's such a good piece of work is it accepts without giving in to the fact that there's an imbalance in power between, you know, the expertise of clinicians and young people, but it sort of takes that as a given, because often and then says, what can we do to work within that to make the experience create, you know, positive for children? Because all too often there's a lot of glib talk about, you know, co-design or co-decision, but obviously the relationship with people who've got specific expertise, you know, you need to know that, and what you want is to harness that in a good way for young people. And I think you've recognised that. So I think that's a real tribute to the maturity of this piece of work, and genuinely very impressed with it. Thank you for being there. And I think, I'm sure we all can sign up to it, but you know, it's not us that need to operationalise it. It's out there, and we will have to, sure Carol will be making sure it's cascading through the organisation, and having one piece of paper that shows the main points is so important.
Yeah, thank you. When I saw the poster and heard you speak, I just, building on this charter should apply not just to children and young people, it should apply to all the people with whom the health board comes in contact, shouldn't it? You know, older people who need their voice heard, people with different needs. So I think it's got a wider application, really, and we need to think about how we communicate the same messages to all the people who come in contact with us. And for that reason, I found the little bit that said prioritising children's rights a bit problematic, because we've got so many priorities that we constantly need to juggle, and I think what we want is for everybody to be treated fairly and equally, and the voices of everybody heard. So I think your message is great, and I think it goes to a higher level as well, a broader level. So thank you for that.
Chris, wedyn Claire.
Thanks, Chair. This is wonderful, really is wonderful, and holds a very special place in my heart insofar as I've benefited immensely from very similar projects when I was quite a few years ago now in your position. What I really want
as the youngest board member.
Yes.
Thanks for that.
A comment more than anything, and I think, and to add on to what Dr. Jones has said, I really hope that this isn't the full stop. This is a pause in the work, and hopefully we can see, just by the contribution you've made today, the real effort and real contributions you have to make. As David said, you are the future of the service users, and perhaps the future of the health board as well. And I think your contributions and those of each be incredibly important, and perhaps there could be in the future a piece of work that looks at drawing together, and it's certainly done in other organisations where we have a children and young persons board, and the contribution that can put into the health board is almost without measure. So really well done, and great to see. Massive fan of your work.
Claire.
Diolch. this is a question for Carol, really. So taking, and I wholly support everything everybody said. Great piece of work. I really want to, you know, agree to it and support it today. So it's a question really about, I guess I'm seeking assurance from Carol that there is a plan in place to operationalise this inside the organisation, to communicate it, to make sure that at every point of our 20,000 employees, people know what this is, they know what it means. And then I guess thinking back to the first item around looking at sometimes where things go wrong or complaints, what is the route for young people when they don't feel we've lived to these values and to these ways of working that we're all signing up to, really. So I'm not asking you to tell me the process for doing it, but I guess for the board to have some assurance that we've thought through how we might do those things. And I guess in terms of the future then, when we're looking at our performance around quality and customer services, we ought to start to see some indicators of feedback from young people about service delivery, service transformation, services being, you know, adjusted to suit the needs of children, young people, as well as to work well for adults. So
I'll give Carol an opportunity to address that important point, and in particular, also how are we going to involve children and young people going forward, not just taking this work now, but a general involvement. And I think there's a really good point about you helping us inform us about services that are needed today, but actually also telling us how maybe services should be for the future as well, not just for today, but when young people move up into the next generation, what should services look like then? You can help us shape the future of services, not just tackle issues of today. Before bringing Carol in and anyone else, just ask you if you want to add anything to emphasize or anything further you'd like to share with us. Yes, please do, Liz.
Just a short few words, picking up the.
If you can speak up as loudly as possible, I'd be grateful.
Quick cough. Picking up the point that Leanne made, which I totally support, because I'm a great believer that actually we could improve our listening and our interactions with all of our patients. I've always believed that. I've been around a long time, as I say, and for all ages. I totally agree. I think the key message that we want to impart with this, which is important at the moment because I don't think it is clear, but hopefully as we get better at it, it will become much more even, is that a lot of people that work here or that children, young people have to engage with don't understand that children have rights and actually have to be understood and dealt with in a little bit of a different way. It's fine for some, but it does depend on circumstance and background and opportunities and life experiences as to how that fits with this scary world of adulthood. I will never forget the moment when one of my two girls, who I will say, you may imagine are pretty able, but I remember it very clearly the moment she said, "Oh, this adult world's a bit scary." And she was about 23 at the time. Actually, the message there is very much around the fact that children are a bit different and we manage them differently to an adult, especially an elderly person. So I totally agree with you, because I hope when I'm much older that I get spoken to in an open way with all of these attributes on our charter. However, there's some learning, I think, for a lot of our colleagues to actually do.
Diolch yn iawn. A pwynt yna. Helen, and then Carol to wrap up.
Very, very quickly. I just want to thank Liz and Scarlett and Alex and Jane. I've been on this journey with you on the periphery, and I think it's amazing. So I just wanted to put that down on record as well, because, you know, you've done amazing things. Thank you so much for getting us to this point.
Diolch yn iawn. Carol, i gloi.
Great, thanks very much. So there's loads in there, and I'm just going to invite Andrew to say a quick something, if I may, on operationalisation. But for me, this sort of work is a sign of leadership and commitment at the board level. It's about what we stand for and how we will take things forward in a very genuine way. I've had the pleasure in my career of working with children and young people. They're a tough gig, you know, in a very straightforward way. You know, you bring the reality of life for you. We were all children and young people once, but we're not children and young people now. And that's the thing, is that you bring today's world and hopefully tomorrow and the future, you know. Because that point about we're here as custodians of the NHS, we're trying to create a better future. We need people to help us to do that. So I think that it's a strong sign of leadership and commitment. I think just to pick up Mike's point around how, in my experience, is broad routes of engaging. The last thing we want to do is to ask children and young people to come to our committee meetings, and you know, I've heard feedback that it can be a bit dull. Sorry, guys, but actually we go where children and young people want us to go, and we engage in the way that they want us to engage, and that requires a flexibility on our part as well. In terms of a couple of points of implementation. So I think there's so under the Children's Act 2006, and there is different legislation that's coming afterwards, but we should at least once a year take a review of how we work with children and young people in developing our services, and how well we're operating. And Alex made the great point of it's not just about children's services, it's about wherever children are in the organisation. So at least once a year we have that report come through, and we're able to then demonstrate where children have been able to influence our work and the impact that that's had. So I think we should hold ourselves to that test. But if I could bring Angela in briefly on operationalising.
Yes. And what do we mean by operationalising? Because that's a heck of a word, isn't it? But what does it mean? Tell us what it means.
So I think it's about making it happen. It's making it live, making it real, and making everybody aware of it.
Yeah.
So I had a bit of a delegation come and see me probably not long after I started from the team, and we had a really, really good couple of hours in the boardroom. And one of my team from the Office of the Nurse Director has been supporting Jane and the team around the operationalisation. So looking at how we can bring it in. We were talking about, ED department, that first contact, how we'd make sure that was happening. We talked about youth councils and things like that. So a resource to support really and to navigate. So for me, this is amazing that we're now at board when we were talking about it in a boardroom a couple of years ago. So yeah, so we are trying to make sure we've got an implementation plan. We're identifying the areas that are the key spots. We have children's departments and EDs, but we want the whole of the EDs to understand it. We've got children's wards, but we want the surgical pathways, the medical pathways, radiology, and it's about mapping it. So Sam Watson, my team, has been working with the team to try and support that.
Great, diolch yn iawn. So, just to confirm then, the request is that we endorse the Children's Charter and we agree to commit to implement it across all service areas in the Health Board. Are we all happy to do that? Oh,
yes, we are. Wow.
So can we thank you for all the work you've done and coming along today, which is quite a commitment, and we want to see you again. Not necessarily here in this room, but we want to see you. We want to be able to learn from you further, and we want you to help guide us for the future. So hopefully we'll have the opportunity to do that. But can I also wish you well with everything you're involved in? I think you're both studying at the moment, I think, if I'm right. Really wish you well, and always remember the Health Board will be here in the future there's always an opportunity to engage with us whenever you feel, even if it's, you know, you had a bright idea one weekend, share it with us. We'll be really grateful, because what we need is inspiration, and you can provide that to us. So many thanks for all your work, and we wish you well for the future. Diolch fawr iawn I chi, a diolch yn fawr iawn I Liz a Jane hefyd am gefnogaeth. Diolch fawr iawn.
Thank you.
Reit, symudwn ni mlaen i'r eitem nesa, os gwelwch yn dda, gofal brys ac argyfwng. Ac wrth gwrs mae'r eitem yma yn un o'r eitem yma byddwn ni wedi adnabod sydd angen sylw gan y bwrdd, sylw arbennig gan y bwrdd. Gafon ni sesiwn ar ofal wedi gynllunio, dwi'n meddwl yn ein cyfarfod diwetha. Heddiw mae gen ni sesiwn ar ofal brys ac argyfwng, a dwi'n meddwl Carol ac Imran sy'n mynd i arwain y gwaith yma os dwi'n iawn, felly dwi'n droi at Carol yn gyntaf.
Yeah, I'm just going to say a couple of things. It does feel like it's urgent emergency care themed board today. And I mentioned earlier in my report the focus really on urgent emergency care as a major programme. So this is the first key step for us as a board. There's a bit more to come at a subsequent board, but I'm going to just hand over to Imran, if I may, at this stage. Thanks, Imran.
So I'll take the paper as read, and in particular, really important as we approach winter, and winter is upon us, to really drill down and have a deep dive around each of our areas, from the front end all the way through to the back end, in terms of following the patient pathway and looking at some of the challenges. So the realities at the moment, as things stand, is that on a daily basis, looking at September, we've got 65 patients per day that get delayed at the moment in relation to the 1 hour ambulance wait. Now, that's not great in terms of patient experience. Again, Carol, Angela and other colleagues have already mentioned some of the challenges around that, in particular, that not being acceptable from a service provision point of view. The second element as well to note is that for our ambulance delays, and our Welsh Ambulance Service colleagues work very closely with us, and there's obviously more work to be done around that, and concerns raised, particularly around our waits. And that basically, as things stand at the moment, is 23 patients a day that wait for 4 hours. But one thing just to say as well is I've had the privilege of going around and meeting colleagues across all our areas in the front end, really engaging with colleagues. There's a lot of hard work and effort that's put in every day with patients first. So that's a really good thing to feel, and certainly being new in the board after returning back after 5 years. Again, that feels really good in terms of that commitment and focus. So there's more to be done from a patient perspective, but as well as supporting colleagues in the front line. And I just need to emphasize that, but also to thank WAST colleagues for their support on a day-to-day basis, particularly balancing the community demand as well as what happens within the emergency department. So again, there's work to be done collectively there. In relation to 12 hours or more patients staying in the department currently, that's 116 patients per day. Now, that's where we are at the moment. When I've looked at some of the data, and it does show within the deep dive, is that there is that variability where some days it's improving, some weeks it's improving, but it's not consistent. So we do need to look at that. So that's the bit that I'm going to be focusing on later in terms of how do we have a more consistent approach in managing that. The other bit that I would say, just drawing from some of the conversations that colleagues have had, is around the packages of care delay. So these are delayed transfers of care within the hospital. So in August, just looking at some of the data, in totality, we had 10,952 bed days that were consumed by patients that were not in the right place, not in the right environment, not receiving the care that they needed at that time because their acute care was over. And a number of these patients are elderly patients, and we wouldn't want them to decompensate. And a lot of us have probably had that personal experience. And it's not really a great place to be. So we need to do something about that. And that translates into 353 beds. And that's equivalent to a district general hospital. And that's what the teams have to manage across our 3 hospitals as an aggregated position. We also need to look at things like time to triage, the senior decision making. And what's happening at the moment is because of the delays, particularly in the back end, and the consumption of the bed days that are probably not appropriate, but probably the safest at that point in time for the patients, whilst waiting for discharge packages of care. That creates a backlog all the way through. And what that also means is that our discharge times over a 24-hour period, again, that's in the deep dive, is that there is a real peak at the end in the evening, which is after 5 o'clock. And what we need to do is to shift that more towards the left. So we have earlier discharges, earlier release of beds, and then we manage that more productively. And Angela and I were talking about, as Angela said, around how do we manage that with patients who are ready for discharge for the here and now? And how do we manage them safely and consistently so that they're able to be managed outside of the beds in readiness for the discharge whilst we get the discharges earlier? Because obviously, all the while that there's delays, there are patients waiting from ED and other areas to be admitted into wards that they can't access because of the backlog of delays. So it's a complicated picture, but there is a solution around that and things that we need to be working on. We've also touched on, as the chair said, around the corridor care and all the other areas where patients should normally be managed and cared for. But to manage care safely, we've also got to manage the risk in a broader sense, because whatever the space issue, patients need care there and then we've got to provide it in the best possible way. So corridor care, unfortunately, at the moment is a reality, but the key is how do you manage that safely, consistently in the time that we have to manage that, but also more importantly, for it to be time-based as opposed to long duration of corridor care. So these are all the things, just to highlight, that we're working on currently. So in the report, in terms of the solution, we are looking at an overall 4 work stream approach that encapsulates the 6 urgent and emergency care goals. And the urgent emergency care goals are exactly that. They're the goals that we need to achieve in terms of best practice. What's really important is how we get there. And the way we've achieved to get there in terms of process, and hopefully that assurance by the board will be critical, is moving the front door. So this is around, and again, Gareth Vice Chair's point around primary care and getting that really into a substantive position, substantial, and it's really key as a service, is moving the front door closer to patients' homes, having our community services reaching out, having what we call a step-up capacity. So when patients do need that care, it's available for them to step up to rather than emergency department. Welsh Ambulance Service colleagues, very important to work with them in partnership to get the care pathways right and to get that resolved. So moving the front door is going to be critical, and there's a lot of work that we've started off around managing falls, patients who've had a fall, patients who have breathing problems and chest pain. Again, that's in the deep dive as well, so we need to work collectively together. Jane, from her perspective as Director of Public Health, and myself working with local authority colleagues, and I'm pleased to say that I've been asked to take on the Senior Responsible Officer role for North Wales around Care Action Committee, which basically looks at all the local authority elements and how we could improve services in the community in particular. So that's good, and I'm actually meeting them tomorrow to go through what I'm presenting today. So we've got a team approach. The second bit in particular is around our emergency department and emergency coordinate, and really focusing on that and the processes, handover processes, and looking at a provision of care, particularly around how we manage corridor care for the here and now. But neither of those will work if we don't have the third component sorted, and that's the hospital flow. So the day-to-day discharges, the day-to-day discipline of having that focus around patient care, ensuring that we plan ahead. So if I'm a patient and I'm being discharged tomorrow, getting all that ready today. So first thing in the morning at 8 o'clock, I'm ready to be discharged. And that means that there is an early bed available for patients who are waiting in emergency care, and shifting that earlier and earlier. So we then start reducing the backlog within the emergency department, the assessment areas. So that's going to be key, and we're going to be focusing on that. And finally, the discharge into the community bit is really important as well. And that's the 353 beds that I referred to for August as an example. So in summary, what we're going to be doing is having a 12-week urgent and emergency care focus. We're going to look at all the 4 work streams that I identified. We've got 2 leads per work stream, so we've got consistency in leadership. And it's a whole mixture of about 15 colleagues across the board at the moment that are a mixture of senior clinicians as well as operational leads that are going to be looking at health board-wide leadership to really improve this and standardize our practice across the board. And the 12-week urgent emergency care process starts next week, glad to say, where we'll be looking at 2 weeks of resetting, checking all our standard operating procedures, looking at our professional standards, sense checking those, are they working, if not, why not? And the daily improvement focus by improvement teams with an improvement lens to say, if things haven't worked today, what could be different? How could we manage that differently going forward? So that's essentially the work that we're going to be doing, and we'll be presenting that, the progress around that at our committee meeting, ensuring that that obviously is looked at in terms of assurance, and the committee meeting is performance, finance, information and governance committee, where we'll look at the details. I'll stop then. I'll open up for questions.
Great. Diolch yn iawn, Imran, and just adding to what Carol said about the welcome, you have been thrown in under the deep end, but you are swimming and you've taken it to it really well. So we're really grateful for the commitment you've given right from the start. So we can have loads of questions, I'm sure, on this topic. So Gareth, wedyn Rhian, wedyn Teresa, wedyn Mike. I gychwyn.
So first of all, Imran, yeah, you have been thrown in at the deep end, and thank you for this work. I mean, so if anything I say is sort of critical, which some of it will be, it's not about the quality of your work, and it's certainly not either about the quality of what the staff are doing in emergency departments. I think, and I'm looking forward with my chair of PFIC hat on to getting my teeth into this. I think, I mean, I think the paper is really strong on the analysis, and if I could draw the parallel a bit with our planned care, I think it took quite a long time to move beyond knowing what the problems were and even what the solutions were to actually implementing them. So I like, I think I'm really interested to see how the 12-week cycle goes, because obviously we've got. It's away even less time with this to make real improvements than we've had with planned care. I did feel that we perhaps, by emphasising that it is an all Wales problem, we sort of slightly underplay how much we are an outlier, and a particular discussion we had yesterday, an outlier from a bad point of view. I know, sort of anecdotes are not evidence, but, the evidence is that we are 7th out of 7, aren't we, in terms of the 12-hour waits. But I was really struck, as part of our meeting of vice chairs, I was at the Wales Ambulance Services Trust headquarters in South Wales, but where they are responsible and they coordinate the ambulance movements for the whole of Wales. And I said, I know that other parts of Wales do have problems, but on the day I happened to be there, the only place there were problems with ambulances being stacked up outside without being able to discharge was in North Wales, and all 3 of our hospitals had them. So it brought home to me that, and they weren't being, I think they're realistic, they know what the problems are, but from them that they were clear that that wasn't a one-off incident, although there are problems at places like the Grange and Lauriston, that consistently there are problems in North Wales in a way that there aren't elsewhere. So we're at the sharp end, as Carol always says. I think I probably don't know, I'm misquoting you, that because we've got a lot of scope for improvement, it's perhaps easier to improve than places that have tried everything and still have got problems. But we've got a big mountain to climb. One thing I thought, I guess, was not missing, but particularly in your actions, the 4 work streams, and perhaps it's just because we can't move quickly enough, but I do think that, our minor injuries units have got much greater capacity in both senses to deal with. So when you look that, the top reason people are turning up is, and it says minor, I don't know if they are all minor, but minor head injuries and then sprains and ankle injuries, those sorts of things are what MIUs are there for. And we do have this problem, which is not, again, it's not their problem, but one of the things that WAST have said is that I think about 4 of the health boards in Wales, they have places where they can convey patients other than ED, but 3 of them, including, I might have got the numbers wrong, but 3 of them definitely including Betsy's one where they don't have anywhere else that they are sort of directing their staff to take people to, and that's to do with their lack of certainty about what is provided where. Now, I don't know how flexible and up to the minute, if you like, their directory of services is, but I presume it's online. So I presume there must be some way of saying, you know, that the one at as Betty Pringrose Stanley is open these hours, you know, but we've got to get that right, because these MIUs are actually probably underutilized. So that's my big point, really. And I will just say the other thing. So you're absolutely quite right. Of course, you know far more about it than I do, about the problem being, you know, the back door. But unless I've misunderstood it, I think all the evidence I've seen since I've been on the board, and I don't think this has changed particularly, is that, you know, there is still a substantial proportion of the waits that are due to our things that we are in control of, particularly medicines, and obviously the EPMA system, if that's the right term, should eventually help with that. It's probably slightly longer term, but medicines and also assessments of patients. And the then minister, when we met him, Mark Drakeford, did raise the point about trusted assessors. And I think there was a little bit of looking around the table as it's sort of knowing it's not really working. I don't know what the reason is, but you know, there are things there that, again, probably not quick wins, but definitely we need to be, you know, as well as sorting out what we can do to compensate for the problems with social services, because we can't, you know, we just need to make sure that we've done everything we can to reduce that proportion of overstays, if I can put it that are waiting for stuff within the health board's gift. Sorry, I've said more than enough, but no, thanks for the paper, really interesting.
Great, diolch yn iawn. And what we'll do, Imran, is get questions from quite a range of questions, which will give you and Carol and anybody else an opportunity to come back on some of the themes that will develop, I'm sure, through the questioning. Right, Nessa, Marian, wedyn Teresa, wedyn.
I think it was just picking up really the same sort of things that Gareth was talking about. You talked quite a lot about the back door, the discharge end, but I think I'm not 100% convinced that our front door arrangements are right. There is a lack of clarity about who can do what, and therefore the default position is take somebody to A&E, be it in an ambulance or be it with a carer or a family member, because we don't know what all other services are that can divert people into maybe a more appropriate setting. So I think getting the front door right is pretty important. You know, I've spent time in ambulance car parks of hospitals and asking ambulance drivers and the paramedics how long they've been there and why they're there. Couldn't they have gone somewhere else? And there's all sorts of logistic reasons why it's a default position to go to one of our 3 A&Es. But I think there must be a way of being able to direct people better and use the great facilities we've got in our MIUs, in our same-day emergency care, in our out-of-hours services. They're there, but I'm not sure people know how to get to them at the right time.
Diolch yn iawn. Teresa, nesa.
Diolch, yn siarad yn Gymraeg. Dau sylw os gael David. Yn gyntaf, edrych ymlaen I weithio hefo Imran yn y swydd newydd. Gweld gymaint o gyfleoedd i'r gweithwyr proffesiynol sydd yn berthynol iechyd a hefyd y crif diagnostig I fod yn rhan o'r gwaith yma. Dyna yn yr gwaith argyfwng. Pan da ni edrych ar y 4 maes mae Imran di rhoi yn y bapur o ran y gwaith. Mae yna gyfleoedd o fanna I ni wneud gymaint mwy a dwi ddim yn teimlo bod ni o reidrwydd yn wneud digon. Dwi'n yn gwybod os y gaea yma fydda ni'n gallu troi'r olwyn yn llwyr a optimeiddio'r system, ond dwi'n gweld gymaint o cyfleoedd ac yn edrych ymlaen I weithio hefo Imran yn y maes yna ac isio rhoi hynny a bapur mewn ffordd heddiw. Yr ail sylw os gai ydy pwysigrwydd wrth gwrs bod yr adran argyfwng brys yn gallu ymdopi wrth gwrs efo cleifion iechyd meddwl hefyd. Maen nhw'n defnyddio'r gwasanaethau. Ac yn aml mae pobl yn dŵad i'r unedau. Nid yn unig wrach efo problem meddygol. Mae gynnon nhw weithiau problemau meddyliol, lles yn y cefndir. Mae bywydau ni gyd mor gymleth. Wedyn, unwaith gyntaf dwi'n gwybod mae yna waith da yn digwydd yn barod rhwng y timau iechyd meddwl a timau'r IHCs ar draws Gogledd Cymru i wneud yn siŵr bod ni yn diogelu'n cleifion ni tra ma' nhw yn yr adrannau brys. Ond mae hynny'n waith pwysig ac fel mae cadeirydd wedi deud, o is-gadeirydd wedi deud yn barod, y gwaith ymyrraeth na mor bwysig, mae rhaid ni fod yn y maes fataliol neu yn yr maes ymyrraeth cynnar. Ond wrth gwrs mae yna adegau pan mae cleifion angen dod trwy'r system a maen nhw'n dŵad i'r unedau a gyfwn wedyn yn ystod y gaea ac oherwydd mae yna gymaint yn dod trwy'r system, edrych ymlaen i weithio gyda Imran, ond dwi yn teimlo bod o'n gwaith system ar draws mynd yn ôl i thema wrach bora. Mae'n rhaid i ni weithio fel system.
Ie, pwynt da iawn. Nesa dwi'n meddwl, Mike?
Yeah, I think the point I want to make is partly covered by what Gareth was saying as regards, in particular, the flow of patients through the hospital or not. I recently been looking at the pharmacy side of things, and in practical terms, on a day-to-day basis, what seems to happen, certainly from what I kind of witnessed, is that you get somebody doing a ward round. They wouldn't have a pharmacist with them, even though they were saying, right, we're going to send you home, Mrs. Jones, we prescribe such and such. And then that person, in practical terms, could be sitting there all day on that bed until eventually pharmacy gets a prescription late afternoon, and by which time, yes, she'll eventually get to go home, but we've passed the watershed of being able to change that bed ready for somebody else. So if we front loaded this, I don't know how practical it is in terms of staffing, but if we could front load that as regards pharmacy, we could get the bed empty quicker. So just a commentary.
Ie, diolch yn iawn. A dwi'n meddwl nesa, Mike, wedyn Claire, wedyn Jane.
Thanks, Chair. I was looking at figure 4, the ambulance conveyance locations and hospital attended, and two things struck me. One is the size of the patch in IHC West and the Welsh ambulance area. It goes northwest, southwest, south, quite a long way.
Yes.
Which hadn't really struck me before. But the other thing that struck me was there's overlap between the 3 acute units. Now I appreciate some of that might be people coming to Glencloyd for specialist services, but there's obviously, there's obviously overlaps between the sort of the east, west and the middle. Given that the performance of YGC seems to be the most under pressure, do we have any mechanism when we know that there are more ambulances in one site than another where we can notify Welsh Ambulance to divert patients if they're on the fringe?
Good point. And some of our patients, just in passing, some of our patients are from our region also go to Hywel to Aberystwyth, as happens as well. Claire, with Jane.
Diolch, Cadeirydd. Not going to cover things people have already said. So just to pick up on 2 key areas, one around health inequality. So what struck me was the whole real situation on Glencloyd, and surely there are some shorter term solutions about how we can make better use of that minor injury unit there. So that's the poorest neighbourhood in Wales.
Yes.
And that's having the biggest pressure on Glencloyd, and I'm sure it's been a factor in the quality of service delivered there. The other one actually direct to Imran is about risk and risk management. So I know this is going to sit in the PFIG domain, so I guess I'm asking the Vice Chair, we need to really think about our risk appetite in this area.
Yes.
I've sensed in my work with the board on this over the years that we tend to, understandably, take a very risk-averse approach to things. But actually sometimes in taking a risk-averse approach, we are causing more harm by keeping people waiting to get into ED or stopping people going home. So I guess it's just a request around some of the solutions may not be perfect, but they will help to move things along. So when PFIG is looking in detail at the plans for transformation around here,
Assessment.
I think we really just need to consider our risk appetite and make sure that we properly risk assess. Yeah.
Yeah.
Because I've been involved in many discussions about some possible solutions, and it often gets
Yes.
but it's not quite perfect.
Yeah.
But it could still be
Yeah.
a big step from where we are right now. And we, you know, my involvement with the board now over a few years, this problem's not improved at all.
No.
So we just need to approach it with I think a different set of.
So is it acceptable for something to be 95%, not 100%? Just
Well, currently it might be 40, so.
You know, in terms of the way we discharge and so on. So
Yes.
Good point. Jane.
So 2 points. One, I think just to add to Claire's, I think some more work around the demographics of this and why people are attending ED departments would be really helpful. We know from other evidence and evaluation that people who are in insecure work tend to use emergency services more than, so looking at some of that might help us. The other thing is, I know because of the immediate pressures, the focus is very much on close to the front door and right through to the back door. But looking at the data again, I think we need to not lose the focus on moving that front door a lot further back. There was a lot more we could do about keeping people out of urgent care altogether. Looking at this around falls, around urinary tract, some of the major reasons why. And also we know that anybody over 70, more than 4 days in hospital, the start of deterioration means that the outcomes are likely to be worse, whatever you went in for. So the more we can do that actually says there are a whole group of patients that we should be just trying to keep out of hospital, and we should look at what those services in the community need to be to do that. I think it's a really important one, not just in terms of about what our urgent care targets look like, but also we're going to get better outcomes for that group of people.
Absolutely. Diolch yn iawn. Llaisol wedi pellach dyn nhw Helen gynta wedyn Dyfed. Then we'll come to Imran and Carol to provide us with all the answers.
Diolch, Derek. I just wanted to make the point that we have quite a comprehensive approach to signposting our population, and we do that through all of our channels, and we do that particularly when we know that there is a heightened need in an ED, and we do that through alerting people to what's available to them rather than telling them not to do something. But all the feedback that we get in this field tells us that the landscape for where to go, what do I do, is very, very muddled and confusing, even though we sort of know what is available. So in the urgent and emergency care recent workshop, people were listing what we've got. It was the comment. I've just gone back to my notes. My comment says this is far more cluttered and confusing than even I thought it was. So there is something about what is our offer and the clarity of that. And the reality is, when people need an emergency, they believe they're in an emergency, they'll go to the one place that they know, irrespective. And all our opportunities to get the message across to go somewhere else are missed in that moment because people aren't on Facebook when they need to go. So there is a big opportunity here. And the other point I want to make, it's the one I made earlier, is the third sector are very keen to support us in this area, and we must involve them in the conversation.
Some really good points there, Helen. Diolch yn iawn. Dyfed, dwi'n nesaf.
Diolch yn fawr am mae pwynt Helen a'r pwynt o Jane wedi wneud ynghynt yn yr un pwynt o'n i'n wneud ydy, mae rhaid i ni, dim jyst rhannu gwybodaeth, mae rhaid ni addysgu pobl i newid i arferion, a mae hynny'n anodd, achos arferion pobl ydy arferion pobl, a mae, nas Helen wneud y pwynt yn union y fanna ydy, pan mae rhywbeth yn digwydd i rywun, mae o'n argyfwng iddyn nhw ar y bryd yna. Ac wedyn maen nhw'n meddwl argyfwng, reis, lle dwi'n mynd, reis, dwi'n mynd i hi. A maen nhw'n neud hwnna, a da ni angen addysgu pobl, ac falla mae yna bwynt yn mynd i ddod, lle da ni'n mynd i orfod dim troi pobl i ffwrdd, ond arall gyfeirio pobl pan maen nhw'n cyrraedd yr ED a deud dim fan hyn ydy'r lle gorau i chi ac i bawb arall. Mae hwnna'n anodd, a mae'n anodd i newid arferion pobl, ond dwi'n mynd i orffan hefo'r ffaith bod gynnon ni'r bobl ifanc yma heddiw. A dwi'n mynd yn ôl i'r pwynt yna ydy, mae pobl ifanc yn dod i arferion ac mae'r arferion yn dod dyna beth yw'r norm wedyn. Dwi'n meddwl bod yna, dim pobl hen fel fi efo'n arferion yn ffasiwn allan.
Diolch yn iawn, a na i ddod ag unfan y Carol, jyst i adeiladu ar y pwynt mae Helen a Dyfed ac eraill wedi codi ynglyn â'r amrediad y wasanaethau sydd gennym ni, sydd weithiau, fel mae Helen dweud, yn gymlaeth i ni ddeall, sut ydyn ni'n hysbysu y cyhoedd am y gwasanaethau yna. Mae tuedd gan bobl i ffeindio allan bethau pan maen nhw angen o. Dyna beth dwi'n neud. Dwi ddim yn gwybod, doeddwn ni ddim yn gwybod dim byd am bwy oedd y gorau i roi gwydr newydd yn yr ffenest oedd wedi malu nes wythnos yma pan malwyd ffenest yn y tŷ, allan bod ni angen rhywun i drwsio y gwydr. Ac dwi'n gwybod mae hwnna'n swnio'n dramatig, ond dwi'n meddwl dyna di'r ffordd mae pobl yn cael mynediad at gwasanaethau iechyd hefyd, yr un modd yn gyffredinol, mae yna eithriadau, mae yna ddefnyddwyr cyson wrth gwrs. Felly mae yna waith i wneud fan'na, dwi ddim yn siŵr beth yw'r ateb. Weithiau dwi'n teimlo dros y mod i'n sefyll yn y maes parcio yn ysbyty Glan Clwyd efo arwydd yn dweud, dwi'm yn gwybod beth yw'r ateb, ond mae'n amlwg bod yna waith i wneud yn fan'na i ni geisio cael yr drafodaeth barhaol yma, nid yn unig efo'r defnyddwyr gwasanaeth, ond hefyd os gael fe'n dweud y sawl sydd yn cyfeirio pobl ein doctoriad a phobl eraill. Ti eisiau just deud rhywbeth ychwanegol, Helen, cyn mi ddod â Imran a Carol mewn?
Diolch. Just to briefly make the point that the reason ED, I've been doing this for 20 odd years, the reason ED is the place that people go is it's consistently there, it's open, there are people who see them.
Absolutely.
The other offers, when I'm not saying this in Wales, where I've worked elsewhere, we promote the other offers and then they don't work or they don't do what you want. People then revert back to the place that they know will be open.
And the whole image of the health service is, promoted by all those TV dramas. It's about ED, it's about ED, so. Right, just Gareth, Chris, a wedyn.
Just very quickly to say, that's why ambulance conveyance is so important. Because it will be difficult to change people who are getting in their own car. But if we can't change where the ambulance is taking, then we
good point.
Really,
and that's to do with where can we influence and who can we influence, Chris, and then definitely right.
So I'd save everyone the tedium of this voice, but I need to be treated more like
it's
seizing on Claire's example of real, and I hear exactly what David said about making sure that people perhaps even turn them away, that once they're not going to the right services. The difficulty with real, for example, is there's simply nothing else there.
No.
I'm on the Pets website now. I put in my real postcode and I get sent to Denby. It's not open all the time.
No.
There's nothing of particular use at the Alex.
So
really, the only place people can go is to Clwyd. Because if it falls out, so yes, messaging is really important. Service provision has to be a double track as well, and we can't be saying to people, well, you can't go there. There's nowhere else for them to go. It's fundamentally unfair.
And I was just reflecting. I was sort of playing in my mind this weekend. If there's an instance with my family, what would I do? I would very likely end up in Ysbyty Gwynedd ED. That's the reality. But not that I would want to, but that would probably be where the path I would follow. Right. Lots of stuff there. lots of things to consider. This is a really, really important piece of work. We're not stopping today. We're grabbing hold of this with both hands, and we're going to do something. So Imran and Carol, over to you.
Absolutely, Deal. So the director of services definitely is convoluted. I've already gathered that, and it's not unusual. We just need to streamline it. And if we could, what would be really good is to have that single point of access on a 24/7 basis, so we can have navigation. That is, it's out there, the numbers are out there, and the population know, but that's some way. But at the moment, the reality is, as we've already said, ED is the default place. We know that. So then that comes back to the risk appetite, and particularly working with clinical colleagues in the front end, ensuring that it's informed risk appetite. Could we therefore have that triage and directing to services based on the director of services in a more confident way, but knowing that once patients are referred, they will be looked after. The other thing that I'm floating at the moment, just talking to colleagues, and every colleague I've spoken to has a solution. It's supporting them to make it happen, and that's the bit where the 12-week becomes important. And so, for example, looking at potentially having that triage process in place, and so the colleagues have described what that could potentially look like, and we could definitely work on that as a test area. But that's something that we'll definitely need to be doing with a considered approach, given the risks associated with that, and also returning back on appointments scheme rather than unscheduled approach for a lower clinical needs cohort. MIUs agree completely with the issue there. Again, the pathways to something we're going to be strengthening where they are in existence. So, for example, with YGC, gland fluid, we're going to be looking at pathways into MIUs. Virtual ward community setup. Caroline and colleagues have spoken about this. We are spending quite a bit of money around escalation capacity. Actually, could we not repurpose some of that in a much more considered way? And looking at community capacity and looking at the step-up capacity potentially. So patients are in the right environment, right care. But we need to explore that to make sure that it is indeed a right, safe alternative. And again, that's something that we'll be exploring as well. The mutual aid conversation between our sites, that is very much a reality, and we are discussing it. But we also need to bear in mind that all sites are currently pressured. So today it might be that the front end ambulance handle is fine because YG could be accommodating a lot more in the corridor, but we are looking at the weights and we think, oh, actually, they're much better. But in reality, it's pressured, but managing differently at that point in time. So again, there needs to be that considered approach, and maybe going back to looking at patients who are delayed. If there are patients that are waiting to go to repatriating into east or west, could we accommodate them differently and therefore creating capacity at that point in time? And the other thing that I also want to pick up on is the health and equality element, and really in particular, because what we're also finding generally, the picture is that patients from the most deprived areas tend to access emergency care out of hours. And out of hours, when everything's mounting up, the delays become more, so we're actually reinforcing that quality of access. So we do need to look at that, and I think Jane, you and I touched on this briefly a couple of weeks ago. So yeah, those are the things that we'll be picking up on population well-being in particular, but I'll obviously pass over to Carol if there's anything else that needs to.
Carol.
Great, really good discussion. I was trying to think of how to get into this, and I thought, God, I've been 30 odd years in the NHS. I've probably spent quite a lot of those years focusing on this issue. And I think if we climb on top of the mountain just for a moment, this is the stuff that really reminds us that the NHS needs to change because the public need is changing. So if I think back to the 80s when I trained as a nurse, the A&E department, as it was called then, really was about accidents and emergencies. It was about a lot of people having heart attacks, and the health and safety legislation wasn't as good. We were quite a safety conscious country, and so there were lots of accidents. The needs of our population have completely changed over that time. Our demographic has changed, and I don't think the NHS and other sectors have changed as quickly to keep up with it. So what we've got in front of us is some focused work for the here and now. in terms of the 4 key areas where in the immediate to short term, we think we can get some benefit. And those even marginal gains across those 4 areas will add up to improvement. And I'll just touch on what improvement looks like. But when we're really getting into strategy and long-term planning, we've got to design solutions for the longer term here, because it feels a bit like sticking plasters at the moment. So just a couple of comments to add to what people have said. So in terms of moving the front door, I think somebody talked about, I think it was Rian mentioned, we talk about the back door, and I will come back to that, the front door. So supporting people who fall in the community is key. That is the highest number of attendances. And actually the people who fall end up with the longest delays through the whole system, and they have a worse outcome because of those delays. So just a simple thing, I met with the ambulance service earlier this week. We're both committed working together on this, is there's been a practice for people who fall to leave them there till the ambulance comes. Actually, the balance of risk here, talking to Claire's point, is it's better to pick people up, because actually long waits on a floor starts the decay of deconditioning and illness. So that there are very tangible things that we can do, but in the longer term, we need to offer different alternatives to only pitching up at ED. We can start some of that work now.
And can I just mention there's something even before there is adaptation in people's houses with care and repair, for example, and housing associations to assist in the work, so that people have the appropriate environment at home so they don't fall in the first place.
Yeah. And I was going to come to that. And actually, you're absolutely right in terms of so Helen referenced the number of different services that there are since the 80s/90s, maybe a bit. Since the Wanless report, some colleagues will remember Wanless. There were Wanless monies. I remember this so well. And then this team popped up. There's a huge fragmentation in primary and community care. The thinking now is around simplifying, standardizing and streamlining that, really about place-based. And that's our big, I look at Gareth for a moment, in terms of our primary and community care strategy for the long term. The fundamental aspects is place-based, bringing teams together rather than fragmentation, because it is with that, David, that our teams will know their local population. They'll know, Mrs. Jones, she's getting a bit, frail on her feet, and the local voluntary sector organisation will be able to pick up the phone. Can we get her a rail? And those sorts of things happening proactively rather than, afterwards. So I was going to mention that in terms of the ED and EQ, I think there's a couple of things in there. We talked about safety earlier, and I think over winter we need to keep that environment safe. We need to speed up the time to assessment. That is a bigger picture around job planning and how we enable that to happen. But that is the place where all the eyes go, and we'll need to have some break glass type arrangements in place. Mike picked up the pharmacy. We do have discharge lounges where people will go and wait for their pharmacy, but we know there's more to do on pharmacy there as well. And then Mike, there is diversions, pizzas working across, so that's really important. On risk appetite, I think there's a risk appetite issue about individual patients and the assessments and discharging sooner with a safety net is what I would probably say. This dreaded unsafe discharge that was drilled into us when we trained, and so we've got to build some safety nets around that. But I think the bigger point on that is almost what's our organizational appetite to do different services, and how far will we step into this issue and problem. People have covered the Royal Alex, that's exactly it. And I think this matters to people. David and I were in a meeting with some retired clinicians, people who are still interested in these matters.
Yes.
So I think
Yes.
going back to what does improvement look like, it will be access, it will be safety, and it will be people's experience. So
Absolutely.
we'll be tracking those things, triangulating those things over this next 6 months to show. And then on planned care, because you mentioned it, and I want to jump in on that. There's a big risk to the planned care work if we don't do that.
Absolutely.
So Imran is delighted that we're going to have a weekly check-in on UEC, a bit like we've had on planned care, starting tomorrow. Thank
Great.
you.
Well, that's
Sorry, it was
good
a lot.
news. No, thank you very much. There were lots of issues raised, really important. This work goes to the heart of many people's experience when they come in contact with help. It's a really, really important work. And the good news that Gareth, in your role as chair of committee looking at performance, we really need to be cited on progress and any issues around this work, as well as the planned care work. So we look forward to seeing that happen in committee as well. Ond diolch yn fawr iawn i chi gyd am y gwaith. Diolch Imran am ymgymryd ar y gwaith yma mewn ffordd mor wybredig ac mor ofalus. Gwych iawn, diolch yn fawr iawn. Ymlaen i'r eitem nesa, ond dim ond i nodi cyn i ni symud ymlaen, mae'n rhywg iawn gen i bod wrth gwrs bod bwrdd mis Tachwedd hefyd yn gyfle i ni edrych ar cynllun y geia a'r manylion bydd o gwmpas sut ydyn ni'n ceisio ymdopi gyda pwysau ychwanegol bryd hynny. Pawb yn hapus i ni symud ymlaen i'r eitem nesaf, felly adroddiad Gogledd Cymru Iach a'r gwaith sydd wedi digwydd fan'na, a dwi am droi, dwi'n meddwl, at Jane i gyflwyno'r gyntaf cyn groesawu Brian a Terry i roi unrhyw fanylion pellach. Diolch yn fawr iawn.
So I'm going to take it that people have read the report. This North Wales is almost a framework about how do we start to move that agenda really to how do we keep people healthy, with a focus about what as individual organisations we should be doing around that agenda, and how do we work with partners, recognising that that agenda about keeping people healthy is not in the power of one organisation. So the report sets out some of the key areas that as a health board we've been concentrating on, particularly, and it's very relevant from the last discussion, how do we start to move the models around primary care to a much more holistic model, which brings in communities, the voluntary sector as well as statutory bodies. How do we move from a very medical model to one that is a much more social, psychological, behavioural model, recognising, again, from the discussion, that a lot of what people are facing in terms of need is very different than it was 40 years ago. People living for very long periods of time with chronic disorders, which require us to work much more in partnership between the individual and the family who've got those conditions and services. And finally, starting to think about more broadly what enables people to live fulfilling lives, and what are the things that the interventions that may be more effective, whether that's social prescribing or the social interventions that Terry's been leading the work on in Hearts and Health. We are also, because we're really keen, because always the challenge on this is, but what impact is that we are evaluating all of these as we go along. What we have been able to show, even from the sort of 3 pilot on the inverse care law work on primary care, the impact of that and the potential of that, which is why we now want to expand that more sustainably across the health board. What we've been able to show from the arts and health is you can have a real impact on some very challenging communities. Some of the work we've done around the forensic mental health services, for example, all demonstrate the ability using these types of models. We're now starting this discussion across our partners, task and finish group really to start to think about how do we really move this agenda to keep people healthy, to be something that's at the forefront of all our organisations, not just health. Our police colleagues, for example, say we've got to get into this prevention space in a very different way. So really, that's what the report is. It's a stop taking time, but a real sort of desire for you as a board to understand this and to sort of have this discussion about how we can maximise our ability to change how we interact with people.
Diolch yn iawn. Jane, unrhyw sylw o gwbl Brian, Terry, unrhyw beth ydych chi eisiau deud? Cyfle i chi ddeud hynny rwan. Any thoughts you wish to add, and I'll open up for questions. Diolch yn iawn. Thanks for joining us this morning too.
Yeah, really the report, thank you for having us on the agenda. Really appreciate the opportunity. It was to bring to you the progress that we've done to date, as Jane said, but to really outline how and why that's going to shape the discussions that we'd really like to have today, to say how do we move forward, not only as a health board, but really with our partners, to say the whole North Wales wants to move to this wellness, this prevention agenda, and how do we do it? So as Jane says, there's some work still going on for the remainder of this financial year, which we really hope will shape that going forward. So around the implementation science of how we do it, but also we've got some work with Bevan where we're looking at how do we put communities at the heart of that discussion around how they want and expect us to transform services. So it's a step away from that paternalistic model where we come in and do to communities. As we've heard from young people today, it's fantastic. How do we actually go and meet the communities on their terms and understand what it is they expect from us? So really just a provoke discussion. Thank you.
Diolch yn iawn. Terry, do you wish to add anything?
Again, thank you very much for asking us and for inviting us for today. And from my perspective, from Arts, Health and Wellbeing, I was really excited to hear some of the discussion already this morning and have been frantically scribbling notes. I think there's lots of ways that creativity can support us and provide creative solutions to health and wellbeing. In terms of environmental work, hearing about the design of chairs, you know, the look and feel of those can be really important for well-being. Hearing about education and hearing the lovely poster being really well appreciated from our young people in terms of educating and informing and being able to deliver messages. And some of the other items that I know have been really key for the board in terms of compassionate leadership. So I think the ways that we can support our staff in terms of creativity and some of the other programmes of work within Well North Wales that can have the ripple effects, because staff are also potentially patients, their families and their loved ones, their relatives, their friends are also patients. So I think there's a real advantage to how we work with our staff on some of this as well, and how it can help us with some of the things we've talked about, care closer to home. We engage a lot with our partnership and community, and the strategic framework has very much been designed through engaging with communities and partners, and they're really keen to work with us. So the falls prevention that was mentioned earlier, you know, we were just having a quick discussion there saying, you know, wouldn't it be great if people in their 40s and 50s could have, you know, recommended socially prescribed activities so that we try to stop them ending up in the system later on. So I think there's lots of possibilities for this work, and just really, really excited to be here to share some of it with you.
Diolch yn iawn. Reit, unrhyw sylwadau, unrhyw gwestiynau gan aelodau? I'll turn to Claire first. Claire's been involved in quite a lot of this type of work, I know, so I'm sure you've got a contribution to make, Claire.
Thanks, Jane. Thanks, Brian. But did I read your name? Terry. Sorry, Jill, Terry. Really good to see this here today. And I think it starts to mark the step change we've all talked about at board a lot, about the need to invest in prevention work to enable us to deal with the pressures on demand for services. But it's a really long-term change. So really look forward to the business case coming forward that's going to make the case for how we start to make more investment in this area, because we know we need to do it, and it will involve brave steps initially, because it will perhaps put pressures on other areas of spend while we free up resources to do more around prevention. In terms of the paper itself, it felt like we'd done quite a lot in terms of starting to talk at the RPB level. We've done some work in communities around the inverse care law work, but it just feels like there is a lot more to do to start to really build up from what communities want and need in terms of their own health and well-being. So I guess there's a question for me around what you see as the role of the PPHP committee in helping to support this work, and indeed the stakeholder reference group. So how can we, through our governance structures, really help to shape this? And then just a very specific question. I was really interested in the focus around the arts work, but it struck me this week that I was listening to something around education and the great work that's going on in some schools now across the region around local culture and local history. And so we often revert to arts as being one of the routes for helping people to manage their health and their well-being. But I just felt that there are other things we could be doing too in terms of, you know, encouraging people to understand their local history, geography and culture as well. So is arts just step one, I suppose, in simple terms, is what I'm asking. And then one final specific question. So the document identifies a vision. Is that the Well North Wales vision, or is that the BCU vision? And how will that align, if we agree that today, with the work we know we're going to be doing over the next year around our 10-year strategy? So I'm just conscious of, for all the right reasons, us kind of setting off siloed, maybe visions that may or may not fully align with where we might end up with the work we're doing on the 10-year plan. So but thank you, great to have this paper here today.
Great, thanks. And we get some further questions before giving an opportunity to respond to some of them. Karen?
I wanted to build on Claire's point, really. As Claire said, it feels very high level, RPD level, whereas we know we've got a lot of potential for partners physically on the ground to support us, and we could stretch our activities a lot further in partnership with people who are actually working at a grassroots level. What tends to happen though is there's an assumption that people working in the third sector have got the money to do that. And so if we want to partner, we need to be able to match fund projects that they're delivering, or indeed invest in third sector to help us meet some of these preventative targets that we need. So it was just to build on Claire's point, really.
Good. Thank you very much. Gareth?
Just to say, you know, welcome the work. I take both Claire and Karen's point, but I am very encouraged to see the RPB setting up this task finish group, and if it's appropriate, I make this offer separately. I'd be quite keen to be involved with that, because I'm keen to be involved with the RPB generally, and this fits in very well with you know, my role with primary community care. So.
Great. And just to add to some of the challenges of this really important work, and if we think in particular the context for arts at the moment is particularly difficult from the finances and other aspects in general. One of the things we've talked quite a lot about as a health board is our ambition and our understanding of the need to invest more in preventative work and in work supporting people where they are and helping people along their health journey. So there's a big question about what's our commitment to that, not just in terms of the saying, but actually the doing, and what does that mean? Now, together with that then is, how can we evidence it? That's quite difficult, actually. I understand that. How can we evidence effect and results and so on? So just an extra bit of consideration there for us. I think as a health board, we are committed to this 100%. And we want to commit more. We want to achieve more. And I think we need some guidance in terms of how can we do that and what does it mean. So yeah, I offer an opportunity to Brian and Terry first, and some of those big questions we'll turn to Carol and Jane, I'm not asking you to start committing £10 million on the health board, but thanks for the offer. But any thoughts, to help us get to that place we want to?
Yeah, so to come on Claire's point first, then we're very keen that we use the existing governance groups that we've got. So let's not reinvent the wheel. Let's use those governance channels that we've got, not only internally with the health board, but we're also reaching outside of this space as well. So the ask is for people to review their terms of reference and their membership to make sure that the right people are there making those decisions in an informed way. I think the key to it really comes back to Angela's earlier point around operationalization. It's around the delivery of how we actually make this happen rather than the government that sits around it. But I get that we have to start with the governance because we need to seek the approval to do something so radically different. So yes, noted, we will certainly bear that in mind. In terms of the vision, I would come back to Carol and Jane to comment on that, but the vision that we've set out there is nothing really contentious. It's to say, we should be aiming to reduce avoidable inequalities. We should be aiming to improve longer term population health and well-being. And I don't think there's anybody in North Wales that would disagree with that. No. But whether that's our vision or whether that's the vision of the health board, I'd leave that to Jane and Carol to come back on. Karen's point around partners at the grassroots level, we've done a lot of work over the last sort of 12 to 18 months around engaging with voluntary service councils, because they're the people who've got those established relationships. So it's very much piggybacking on what's already there, standing on the shoulders of giants. It's not us going out to create those relationships from scratch. We're working with the organisations that have already got them. We're doing a lot of work as well to improve the resilience and the sustainability of the third sector. So we're trying to shift that and influence that shift towards longer term contracts. So we stop this and break this cycle of annual year on year funding. We're all in this together. So I think we as a health board, we've got a role to play in this, but we're also influencing our partners to do similar. And then just finally, to come on Gareth's point, absolutely welcome your volunteering to join that task and finish group, and we'll be in touch very, very soon. Terry, have you got anything to add?
Yeah, I would agree with what Ryan said. Claire, if I can just say a little bit about your points about schools and local culture and history. Absolutely. I think the language in the past has been about arts in health, arts and health. I think it's shifting now. It's being used a lot in England, creative health as a term, and very much about considering culture, heritage, creativity under that. So, I mean, I take quite an expansive approach to this, that anything from gardening, woodwork, photography, design, it should all come under that. But as a very small capacity team, I think we need to think then very carefully about our involvement with that. But then working to connect with Karen's point, the partners becomes really crucial. We know our partners are really keen to work with us on this. And actually for some of them where funding is a challenge, we can support them because it will help them to access some of that funding. But certainly I think that would be an important aspect to this work. And if I could just say one last thing is that connecting with the schools, absolutely, the Arts Council of Wales do an awful lot for their creative programme with schools. I think the key thing for me is that about creativity is not just for young people. I think that's one of the biggest challenges, is trying to make shifts for all of us, and some of it might feel a bit strange or unnatural initially, but I think by introducing some of this into all our lives there are real benefits, and the more we can try to model that, I think it's to the benefit of our populations.
A great example, by the way, this week of the link between history and music and the arts is the opera to commemorate the Gresford disaster in 90 years. And if you haven't heard that, take an opportunity, and that was a good way of linking everything. Right, a couple of comments then, Carol and Jane. Karen first, and then I'll bring Pam in.
Yeah, and just to come back on the CVCs, and I know if Ursula was here, she would probably be saying this as well, but we had a really good conversation, Ursula and I, last week, and the thing with the CVCs is whilst they're the overarching body, they don't actually always know exactly what's going on the ground, because they can't possibly know what every third sector partner's doing. So I just don't know how we get that intelligence as to, the real stuff that's happening with an overarching body, but I just part of that as a thought for you.
Yeah, no, good point, and the potential to tap into all that community activity and energy. I often say in the county I live, there's almost 40 groups active on a regular basis, so there's a great opportunity. Pam, did you want to say anything?
I suppose it's just, I'm sure Karen might cover some of this, just go back to Claire's point about the committee. I
Yes.
would suggest that the vehicle in which the sort of progress and next steps oversight definitely needs to be through the PP
Yes. Yeah.
Committee, so I think we just need to build that into the programme.
Yeah.
I think also go back to Claire's point around the connections with all the other strands of work, so I just really wanted, just maybe that's an action from the board.
Yeah.
To look
Great.
at that.
Diolch yn iawn, Pam. Carol, Jane, over to you.
Great, great stuff. So I'm going to just cover off a couple of things. Originally, Claire, we were going to have the arts and health framework and felt that it was such an opportunity to really have a slightly more strategic sense that, you know, we asked the guys to bring forward this work. So thanks very much to the team. A lot of conversations happening. So I see this work as our warm up to our long-term strategy. Not, you know, the last thing was that over there. So it's the warm up to it. I think with this stuff, there's no sort of magic switch to flick. We start to build a momentum and a common sort of understanding. I think it's great that we've got this here because the purpose of the health board is to improve health and well-being as well as provide and secure excellent services. And when we look at the balance of our agenda, it may well be that we often operate in that second purpose. A couple of key things for me, you know, and really taking a look at what it is to live well through the whole life course. So what is health and well-being? What is it to people? And we start to get into things, you know, about well, what does community mean? What does social connection and happiness and the link between those things and general rating of well-being? And we have the happiness surveys and things like that, don't we? These are sort of the things that someone might look and say, what's the health board talking about that for? But these are the things that help people to feel well.
Yeah.
Even if they have a physical or even a mental health issue, it's about their life. So when we talk about biopsychosocial models, it's about how you live your life. And we're not always about trying to fix people because some things we can't fix, but we can contribute to people living their best lives, really. I think we start to then think about, well, Darcy last week or the week before talked about prevention. This isn't necessarily a new thing, but I think we're becoming much more aware about the impacts of different types of health and well-being interventions. And I was thinking about green health and blue health and all of that sort of thing, the environment basically, and our focus on that. And while we talk about the RPB, we should also talk about the PSB, Natural Resources Wales, the police, you know, feeling safe in your community helps your well-being. So that much broader sort of perspective. And then just when we want to think about the third sector, but also community partners and communities as equal partners in planning. And that's what we'll need to do. It's not just, as Brian was saying, you know, about the commissioning them as a provider. They are equal partners in planning for the future. We need to know when to get out of the way. So as a statutory sector, we're not the best place to do certain things, but be clear about where we can help and be available for that. And then the big picture on, well, what about the resources is, I'm looking forward to the time we start to talk about allocative efficiency. Sorry, it's a bit of a funny term, but out of our £2.2 billion that we have, where should we spend that best to get the best outcomes for the population? And I'm sure it's not in hospitals. I'm pretty sure there's quite a big proportion of that. If we spent it differently, we could get a better outcome. So it's not necessarily about more resources, just to reassure us, but thinking about where we put our resource for the best outcome. So I think it's great, and so thanks to Brian and to Terry.
Anything to add, Jane?
Yes, so three things. The first of all is that this is not intended to be a top-down, it's bottom, it's but intended to be both. So it's starting from both ends. We need to do the top down to get the framework and the buy-in and to get the partners. And we want to use the structures, which is why the RPB. But one of the things when we took it to the RPB and did the workshop was the agreement that actually the task and finish group needs to be a much wider constituency, because actually it's all organisations in North Wales. And this is how do we come together to address this. At the same time, and in things like the social prescribing and the inverse care law work, we are very clearly starting at the community basis, and how do we bring together the groups. Partly your question, how do we bring together groups, but also recognising doing the top down allows us to work very differently at the community groups, because some of our partner organisations have much better links into those communities, and it means we don't duplicate, we don't over intensify gaze on some communities who really are not comfortable in that space, but actually work with communities. So I think that top down, bottom up is really important. The second on the strategic is I would get to Carol. This is not about a different thing to the 10. This is about how do we bring together not just the health board, but that real conversation about what does health and well-being look like, and how do we work together to maximise health and well-being, which should inform the 10-year strategy and start to think about it. And my third point is, there is also a question, we're always asked, how do you show the benefit of this? Increasingly, I'm getting to my question is, if we don't do this, we do not have a sustainable health and care system. We are going to have outcomes for our population. That means this will not just be a health issue, this will be a social, economic, social impact issue. Health is now the biggest limiter on people being out of work.
Yeah.
It is having a huge impact in the viability of some of our communities.
Yeah.
We need to look at different models, and we need to have that braveness that says, actually, we cannot do what we did for the last 50 years for the next 50 years, because that will not solve the issues that we're now facing. I would also say it also means we are going to need to look differently at what we measure and value in terms of the outcomes.
Yeah.
So increasingly, we've been working again with the voluntary sector a lot about things like social return on investment, being able to demonstrate a wider set of impacts that if you intervene in a different way are going to have on people and their communities. So we have built-in evaluation into this, because we know we're always going to get the question, does this have impact?
Of course.
And we think that actually we are probably getting better evidence for the value of our intervention than is actually often provided for more traditional interventions. But we will keep that as a key part, because actually the end of all of this is all about how do we have impact and how do we improve outcomes for our communities, and particularly some of our communities and individuals who at the moment feel often furthest from getting good outcomes.
Diolch yn iawn. And just those who are unsure, RPB is Regional Partnership Board and PSB is Public Service Board. Those acronyms sort of crop up quite a lot, so just in case that needed clarifying. Diolch yn iawn am y gwaith ardderchog, a dyn ni'n edrych ymlaen at weld cynnydd ac at weld ddatblygiadau yn y maes yma. A dyn ni gyd yn hapus i gefnogi'r gwaith, i gefnogi'r fframwaith dyn ni wedi gweld, a nodi fydd na achos busnes pellach yn dod o ran adnoddau yn y tymor hir, a bod ni'n barod i gefnogi yr egwyddor yna o symud i'r maes ymyrraeth a'r maes yma lle dyn ni'n ymgysylltu gyda pobl yn y gymuned mwyn ceisio gwella cyfleoedd i fyw bywyd iachach. Ydy pawb yn hapus i gefnogi hynny, sgwrs yna. Diolch yn iawn, a diolch am y gwaith arbennig ac yn edrych mlaen at rhagor o drafodaethau yn y pwyllgor fel oedd Claire yn nodi a pam. Diolch yn fawr iawn. Reit, nawn ni gymryd egwyl rwan. Mae bron yn 10 munud i hanner. Dyn ni'n ail-ddechrau am hanner dydd ar y dot. So come back a little before 12. We will be restarting on the dot. Diolch yn fawr iawn. We now go to adverts if you want.
Oh.
Thank you.
Yes, I can hear you. I shall do a load of things to get the message. All right. Yeah. Philippa's literally just sent me a message saying that she's added him again. So will he hear me? Yeah, I mean, I'm happy to speak. Aled, if you can hear me, could you speak? I'm not aware he can hear me, that's all. No. Aled, you need to let me, I can't hear you. Ah, I've got you on the Portuguese. That's fine, as long as you're not going to change channel. I can hear you now. I'm assuming you're Aled. Wonderful. Okay, that.
A dyma ni yn ail gynnill yn y rhan nesa o'n cyfarfod croeso nôl i chi gyd, ac symudwn ni ymlaen gyda'r eitem nesa sydd y polisi ac adroddiad blynyddol ar iechyd a diogelwch. Mae dan un o'r prifwythredwr, ond dwi'n meddwl dwi am ofyn i George ddod fewn i gyflwyno'r eitem. Diolch yn iawn, George.
Diolch, David. We're presenting the revised health and safety policy, which is a statutory requirement, and the annual health and safety report 23-24. The revised policy takes account of changes in the leadership, reporting and executive accountability for health and safety. It also reflects the new risk management framework for the Health Board, revisions in the reporting structure for RIDDOR, and the introduction of KPIs for the health and safety team, and also responsibilities for each IHC and divisions in terms of reporting health and safety on a quarterly basis. We have recently appointed a new health and safety, and once the Director of Estates and Environment is appointed, that person will be the lead executive. Currently, that accountability is sat with the Chief Exec. The policy is an annual plan priority, and it's been written for the here and now, but we'll be laying the foundations for the future, and will be reviewed once the strategic framework is in place. The Health and Safety Report for 23-24 provides an update on the work undertaken by the Corporate Health and Safety team during the period 1st of April 23 to the 31st of March 24. The report highlights changes, including an increase in RIDDOR reportable incidents, ongoing issues with manual handling training compliance, and the need for improved governance and reporting structures. We recognise that there is significant work to do in this area, and the Health Board has initiated several actions to address these issues, including policy reviews, enhancing executive leadership in health and safety matters, developing a more robust risk assessment and management frameworks. The ongoing gap analysis and development of a new strategic plan for addressing the improvements in health and safety will be crucial in guiding improvements going forward. The ongoing gap analysis will be taken through the People and Culture Committee. Members are asked to approve the health and safety policy and to note the health and safety annual report. I'll hand over to Carol.
Carol?
Yeah, not an awful lot. I know we've had discussions at the People and Culture Committee, and David is eagerly awaiting further items on this. Really important for us to get a really comprehensive risk assessment / gap analysis so that we know what we need to focus most of our efforts on. And that's why this item ended up being prioritised in the annual plan. So it is under the building an effective organisation objective. So lots to do. This is almost a staging post on the way to having a more comprehensive strategic approach, but taking the opportunity of bringing the annual report here. There wasn't one for the year before, so important to bring that. And then we will have a more comprehensive annual report each year, and reports in between to the People and Culture Committee.
Diolch yn fawr. Cwestiynau sylwadau, drwy at Rhian gynta, wedyn Gareth, wedyn Claire.
Right, the report, I'm quite happy to accept and note that it shows what it is, what it is. The policy document I found a bit difficult. Well, no, going back to the report, I think I would have liked a definition of RIDDOR up front. It took me about 50 pages to work out what a RIDDOR was. So just a little point there. When we get to the policy, I felt that it was doing more than one thing. For me, it should just be a policy, a high-level document, whereas in fact it was a whole list of things that everybody had to do, and it was horrifying. The thought of managers having to follow all of that, I found it was trying to get my head round. If I was a manager there, how would I do all of these things practically and have a day job? And I wonder, is there any way of simplifying or theming or grouping rather than having, I don't think a policy should be a list of tasks. basically. I
Yes,
think it should
yeah.
be at a certain level, and then desk instructions which are relevant to each patch of work. I think that was my initial thought on it.
Diolch yn fawr iawn.
Gareth? Well, on that, I'll take the latter point first. I completely agree with Rhiannon. I mean, it's actually really well drafted. It's really well put together.
Yeah.
But I don't think that a 45-page document can be internalised by anybody who's actually, you know, I know you could say, well, they've just got to read one bit, they don't, you know. And it made me think that one of the things that I have banged on about in the board is what seems to me, as a still a relative outsider, sort of low level of commitment to fulfilling important administrative tasks that are seen by the staff as bureaucratic. We've talked a bit about this in things called the complaints and so forth. But then when I see some of these the policies and the way we put them over, I understand why people switch off. So the risk is, by being so comprehensive, people do nothing. And so I think I'm quite happy to accept this as actually a very sort of complex explanation of what our intentions are. But I do think that when we move beyond this, we need something, as Rhiannon says, much simpler that captures the absolute core of what people need to do. But I do want to say, I think it's incredibly well drafted and brought together document, which is not always true, but it's sort of elegant. But this is the point, I think. The thing. On the report, perhaps by contrast, I think the report is also very good. Just a couple of things I wanted to pick up, actual questions rather than just pontificating. One is that there's an implication. On page 7, I think it says that we're going to develop a strategic framework which will ensure a more robust approach to health and safety risk assessment and management. And I just wondered, does that mean we aren't confident we've got an oversight of whether risk assessments are in place that should be? I mean, I know it's a very big organisation, but you know, I would have imagined that what we would have is some sort of database or record of the fact that assessments are in place. I know, you know, I mean, there are things in the health board generally, we have a lot of issues to cope with. So I'm not trying to sort of, make people feel guilty. I just would like to know whether that I'm right in reading that into it. And the other thing was, you know, there's lots of useful detail on what we've done and are doing in respect to falls and ligatures. And ligatures are obviously really important. I think there's a very good account of that. But I noticed that 30% of the riddles were about violence and aggression, which is really actually quite shocking to me. It shows how naive I am. But there wasn't so much narrative about what we are doing or think we're able to do. And I appreciate there's a limit to what we can do on that area. So any more information either now or later about that, I'd really appreciate. So thank you.
Guys, Claire.
So thank you for the report. It feels to me like it's another of those topics where we're kind of unearthing where we are, and we have some way to go to really be confident about how well we're meeting our statutory duties around health and safety. So I welcome the report, but it's difficult reading, I think, in parts. What would be useful for the board, I think, for the future is that because we're the first appendix is the annual report, and it's only up to the end of March. I don't get a sense of. So I get a sense of worry, and what I don't get a sense of is, well, has anything changed in the last 5 months that can start to give me some assurance that we're on the right track now, or things are improving in the areas where we want to and need to make improvement. So for the future, that would just be helpful, that even where we have a cut-off date, we provide some updated context where we can. And then I noticed that, and it's a theme through all the reports, the quality report and everything else, slip, strips and falls is still a big issue. This report identifies we've got delays in rolling out the procedures, and the making it safe reviews need to be embedded. And then we've got a lack of no coordinated support responses for clinical interventions like we have in mental health and learning disability. So all of that led me to think, is this a resourcing issue or a cultural issue or both? And I wasn't meaning. I suppose it kind of plays a bit to Gareth's point around the policy itself. A general point on the policy, the very first thing it says in the introduction is, this policy embraces the concept of a sensible approach to health and safety. I just thought, really? Is that our ambition? But then when you move into the policy, it does start to talk, when you talk about the aims, it starts to talk a lot more positively about developing a continual positive safety culture. I'd feel so much better if that was what we said we were heading out to do, not to have a sensible approach to health and safety. And then again, same question I asked earlier in terms of board assurance. How do we roll these things out? And how do we know that at every touch point in the organisation, whether the policy is too long, whether the responsibilities are very onerous for people, how can we be assured that it's been disseminated and understood? And I don't know whether we have a learning system where we can record people's training, or where we can record that it was team briefed. And because I think for a board, that's the kind of assurance that we need to know that we're moving forward positively with these things for the future. So thank you, probably mainly to Carol with those points.
Great. Diolch yn iawn. So I'll turn to Carol and George if you want to respond to some of the points, please.
Brilliant. That's really, really helpful. So there's a couple of things to say. I'm going to pick up Gareth's point first about, well, where are we really? Gareth, when I first came to the organisation and I started having conversations about health and safety, clearly we had a prosecution coming and all of that. So I really wanted to know what should be keeping me awake at night. Especially because I've got a personal accountability on this as well as a professional one. And I'm not convinced that our systems of risk assessment, I don't mean in the detailed in the departments, but our overall risk assessment on the very many areas of health and safety legislation is sophisticated enough to give us that. So should I be worried about hand-arm vibration? Should I be worried about control of contractors? Should I be worried about asbestos or about stress? You know, so that we can see it all in the round. I think the guys have been a bit limited over that last year to do very much detailed work. But as George said, we've got a new head of health and safety, and I'm confident that she's got a programme of work planned, and in you know, she's done this before, that gives us that comprehensive overview. So that's the stuff that will then get into the strategic plan. On things like violence and aggression, there will be some things that are almost always reported because we train people to report. So slips, trips and falls. I don't know what Angela thinks about this, but when I trained as a nurse, it was like, oh, you've got to report that. So there will be some things that are reported more, which is why balancing with risk assessment is really, proactive risk assessment is really important. On violence and aggression, some of that will be the behaviour of people. Some of that will be the effects of an illness. And the aggression that comes from that. So they need different mechanisms, but I think that is an area for us to get underneath a lot more. On the policy, Pam was smiling at me because we've had lots of discussions about how many policies we've got, whether people shoehorn every single procedure into a policy, and whether we can strip them back a bit. So this is a great candidate for that. And I think that helps because one of the challenges is seeing the wood from the trees. So that's what we really need to do, is to strip out some of this. And Claire, just in the last 5 months, I think I've been chairing this health and safety group for the last 6 months or so, getting a good sense of actually people are quite committed to this agenda. So, you know, that gives me a sense of confidence. Each service does their report, does their escalation, shows where they've been sharing the incidents and the learning. So I think there is a base to work from. My sense is how we enable people to work on the right things, the things that are the most important things. And hence it comes to that sensible approach to health and safety. That wasn't my term, but I thought there was nothing wrong with a sensible approach. That would be quite a good thing. But I think they really mean being a bit proportionate to the risk. And we can only be proportionate to the risk when we really know what the risks are. Yeah. So I think that's really what is meant by that. Yeah. But yeah, this is definitely work in progress.
And there's a tremendous amount of work in here covers a lot of the things, and it's quite far-reaching. And just one thing that struck me was I'm sure people in the health board would want to know what they are accountable for.
Yeah.
That's one of the difficulties. You can't be accountable for everything, but we're all accountable for something, actually. So, you know, getting that right and the balance is important. Karen, and then we will finish on this item.
Just two things, just from the report, and it might be that this is something that we're got more in development, but we're not looking at near misses in the report, and obviously from a risk management perspective, understanding near misses and what they might lead to. So hopefully we'll be able to build on that for next year. And then just to sort of come in from the audit committee's perspective, obviously,
yeah,
you know, this has been under scrutiny for some time following the limited assurance report that we received. And obviously the recommendations that haven't yet been concluded will continue to come to the audit committee. So alongside the people committee, we'll have another avenue running to make sure that those recommendations are embedded and you know, delivered in the next 12 months. So it's just to give back.
Thanks very much for that.
Could I just say to thank the internal audit team, because I'd asked for them to have a look at this, to give us that fresh eyes perspective, so they shoehorned it into their programme.
Great.
So great.
Diolch yn iawn. Pam yn hapus I gymeradwyo y polisi a derbyn yr adroddiad blynyddol, os gwelwch yn dda. Diolch yn iawn. Diolch am y gwaith, diolch yn George yn arbennig am ddod I gyflwyno hynny heddiw I ni, diolch yn Carol hefyd. Ymlaen i'r eitem nesa, ac dyn ni dros yn allan yr eitem nesa, diolch I Pam am I arweiniad. Mae gen I adrannau sy'n cyplysu adroddiad cadeirydd pwyllgor gyd ag adroddiad y pwnc fel petai. A'r un gyntaf sydd gennym ni ydy adroddiad sicrwydd y cadeirydd pwyllgor pobl a diwylliant, a wedyn mae'n yr eitem ddilynol yn wneud â diwylliant ag ymgysylltu ag arweinyddiaeth. Felly, dyn ni wedi derbyn copi o adroddiad cadeirydd pwyllgor yna. Dyfed, os gen ti unrhyw beth I danlinellu ni, neu unrhyw beth ti isio tynnu sylw ato fo o'r adroddiad?
Diolch. Dwi'n siŵr bod pawb wedi cael cyfle I ddarllen drwy'r adroddiad, ond dwi'n meddwl bod o'n bwysig nodi sut mae'r pwyllgor yma'n datblygu. Mae o'n pwyllgor newydd. Mae yna bwynt dwi'n mynd I orfod stopio deud mae o'n newydd, ond mae o'n newydd a mae o'n datblygu, a dwi'n meddwl bod yr eitem ar iechyd a diogelwch yn fan'na'n dangos mae yna waith I wneud, ond da ni'n neud cynnydd da fel pwyllgor. Mae gennym ni sesiwn, mae'n cyfarfod nesaf ni mewn chydig wythnosa, mae gennym ni sesiwn ddatblygu hefyd wedi rhoi at ei gilydd. A dwi'n meddwl bod y gwaith yn enwedig y gwaith ar y diwylliant ac ar y values and behaviours yn bwysig, achos mae o yn cyffwrdd â phawb o fewn y bwrdd iechyd. Dim ots be di rôl nhw yn y bwrdd iechyd, os dyn nhw yn un o'r uwch dîm neu lle bynnag maen nhw'n dod o fewn hynny, mae o'n bwysig a mae o'n waith sy'n bwysig I gael yn iawn, a dwi'n gobeithio bod ni ar y trywydd yna wedyn yn falch o weld. Dwi'n gwybod bod yna eitema'n dod I fyny rwan wedyn mae adael I hynny a geith pobl ofyn cwestiynau a wneud sylwadau fel sy'n addas. Diolch.
Diolch mor iawn. Ydyn ni hapus I nodi adroddiad yna gan cadeirydd y pwyllgor? Os gwelwch yn dda, bob yn hapus. Symudwn ymlaen felly yr eitem gysylltiedig sy'n wneud a diwylliant arweinydd ac ymgysylltu yna I droi Carol ar gyfer yr eitem yma, please.
Great, thank you. I'll make a start and then I'll just pass over to George for additional comments. So this is a progress report following the 9 areas of intent that the board approved back in a year ago now, September 23. That year's gone quickly. And really is trying to demonstrate the range of work that's been taking place. Of course, board members will know because you participated in much of that, you know, the work with Michael West, for example, and your presence at some of the leadership conferences that we've had, and more latterly our focus on the work around values and behaviours, which at this stage we're midway through that, a little bit more than midway, and intend to look to do a second stage of engagement on that. I think that's a very serious piece of work for us as a board, because we can talk about strategy all day long, but unless we've set the right culture, we may well struggle to deliver what we need to for the people of North Wales. So really very important indeed. There is an ask of the board around the endorsement of the NHS Wales Compassionate Leadership Pledge. That was very much controversial within that. We've done a lot of work on what compassionate leadership is. But happy to take any questions on that. And then you see a range of the different types of activities, and particularly just picking up on people who are managers, the important role managers have, and how the development of our managers is a really critical part of how people feel engaged in the organisation. So I'll just see if George wants to add anything else.
No, just to say that the aim is to present the final version of the values and behaviours to the November board.
Yeah, thank you very much for that. Yeah, so it's work in progress. Our role today is very much to support the work and to endorse that compassionate leadership pledge as Carol has outlined. Unrhyw gwestiwn gan rywun gan gofio mai gwaith ar y gweill ydy hwn heb bod yn offenedig. Rhian, wedyn Claire.
I was just looking at the pledge. Who's pledging to whom? I just wondered, is it an individual? Is it the board? Is it who's exactly making the pledge?
I think the intention is us as a board making the pledge. And there's probably a bit of a story, if I may, Chair, behind this, because quite clearly NHS Wales, which you can decide whether it's an entity or not, but NHS Wales has set out a very clear position in terms of compassionate leadership, and has asked HEIW to develop the pledge that we sign up to. So we're really signing up as a board, with our role being to set culture, to lead, etc. So that's what it is, really.
And that's on behalf of the whole organisation.
Yeah.
Claire.
Really welcome the report. Really good to see the progress that we're making with this, and really good for the board to have sight on it today, as it's still in its developmental stage before final approval. At the People and Cultures Committee, and this is a personal thing, but I think in terms of developing a compassionate culture, it's important. And I can't find which document it is now, George, but the one that's got on a page what living the values look like, and it's got that column at the right that says we do not want behaviours like this. I think it's obvious that you don't want those behaviours if you're behaving in this way. And I just think in terms of staff engagement, having something that's all about endorsing the positive behaviours is an important sea change, and we shouldn't need to be listing what poor looks like, because it's the opposite of what good looks like. So I did raise that in the committee, and I'm just using the opportunity to raise it with the whole board to say, I just think in terms of where we want to head, in terms of how we work with each other, how we behave with each other, having really kind of positive messaging all the time. I would much prefer than lists of not to do's.
Yep, good point, and I think that will be considered in the way it's being developed and going forwards. But
really
it's
great
important.
work.
It's an important point. Yeah. Anyone else? Karen.
I think I agree with Claire from an outward facing perspective, but having worked with people on the ground, sometimes people actually need to have it spelt out. So I think it's something that might be done more at a team level, or where people's performance or behaviour isn't right. But you might have to pick that up. I was just cautious, someone on one of the slides, it said maybe we could have the acronym CARE.
Yes.
And having been fallen foul of using the word green for an environmental charity. When it went to Welsh, it just didn't
No,
work.
right, yeah.
So whatever we choose, if we're going down the acronym route, it's got to work in both languages.
Well, yes, let's not rush too much to invent further acronyms for the health board when we've got thousands of them already, but yeah,
I think it's a case of get the words right.
Yeah.
If an acronym falls out of it, that's lovely. If it works in both languages, it has to, or you don't use it. I just want to say, I think it's in here somewhere. I can't get my head around all these different mountains. I found it so complicated. You know, would you introduce yourself and say, I'm a Moel Famau, or I'm a Glyder? I found, and I think that's something that the health board does. It likes its acronyms, that looks nice. It likes its mountains, and we're going to have something about lakes, or, you know, I wonder if that's quite the right approach.
Okay, I'm sure that'll be taken into consideration and working out what works, different things work with different people, I guess, but Carol, just to
yeah, we'll try to find a way on the positive negative. I think there is a way to overcome that. We were talking about a bit of a toolkit that sort of sits underneath this, and actually what I've said in some other settings is we're not looking for 20,000 saints. Some of us will be constantly trying to, you know, work often in challenging circumstances to be the very best that we can be. But we may need to be a bit more explicit about some of those behaviours that we won't tolerate, because that starts to change our culture. But it's about where that features really, and I completely agree, Claire. You know, let's be a positive, forward-looking organisation. And then on mountains, well, you've got mountains, lakes, and I'm not a fan of slogans. So, you know, we could take all of this into account. You know, practically it's about what works, what's needed and what works, isn't it? So, yeah.
Revisited then. Okay. Billy.
Sorry. Thank you. I would say that, you know, the behaviours that we don't want, that we won't tolerate, do have their place, especially to our new staff.
Yes.
Our current staff may be in the background, it could be there, but I think the behaviours that we don't want, we need to be blunt with our new starters.
That's a good point in terms of there's an opportunity with recruitment to, first of all, the way we recruit actually can influence what people interpret of us as a health board, and what we set out in terms of what is acceptable, what isn't acceptable. That's where we can have the greatest influence, probably, is in recruitment. So really important point to make. Reit, ti'n prof yn hapus I dderbyn yr adroddiad a gymeradwyo ar ddewis arweinyddiaeth drigarog yna gan Gwasanaeth Iechyd Cymru. Pawb yn hapus I wneud hynny. Diolch yn iawn am y gwaith pwysig yn edrych ymlaen at parhau I gefnogi a gweld y datblygiad maes o law. Diolch yn iawn. Ymlaen i'r eitem nesaf, eto sy'n cyplysu adroddiad cadeirydd y Pwyllgor Ansawdd Diogelwch a Profiad ac yn y adroddiad blynyddol. Di Caroline ddim yma heddiw oherwydd salwch, ond dych chi wedi gweld yr adroddiad. Os yna unrhyw un eisiau codi unrhyw beth o'r adroddiad yna, sgolch yn dda. Os nad oes symudwn ymlaen i'r adroddiad blynyddol, felly ansawdd, and I droi dwi'n meddwl at Angela ar gyfer yr eitem yma. Angela.
Diolch, Rhyfedd. So at the AGM yesterday, I identified that this was our first annual quality report, with the information being included normally in our annual report. So I want to present the annual quality report on behalf of Nick and Teresa and myself as the leads for clinical quality execs across the organisation. This is a new and evolving report, should we say. So the plan for next year will be for us to utilise the quality management system quadrants and have it very laid out in a different way, I guess, to make sure that we can show where we've been planning, where our improvements, where our assurance and where our controls have been. But this being the first time, we were given instructions to make sure that our duty of quality was included, our duty of candour, our PTR regulations, and it was identified that we needed to look back, we needed to include that things may not have gone well, look forward as an organisation, looking at our quality priorities, describe the key strategic decisions, look at how we've had our quality enablers, and part of the duty is to have a quality management system, so understand where we were going with that. And you know, obviously I articulated that previous boards and in the AGM yesterday. So I think I've taken this through to the Quality, Safety and Experience Committee on a couple of occasions. It's latterly gone through execs, and we've had some more feedback, and then welcome the feedback that I've had from colleagues around the board since the papers were published. I think there is a little bit of disjointedness that has been called out to us, because I think we've been trying to act on some of the feedback we had post the meetings and try to reshape it. The idea is for us to have a discussion, I guess, around the content and whether we've captured everything that we're expected to today. And then we'll do further refinement for it to go to the October Quality, Safety and Experience Committee for us to have a final look and approval on behalf of the board. If that's it, I'm happy to take any questions or any comments. Thank you.
Diolch yn iawn, and as Angela said, the Committee Quality and Safety will continue to receive this report and our request today is that we can delegate approval to that committee for final sign off. Ond unrhyw gwestiynau heddiw neu sylwadau? Gareth a wedyn Claire.
I would just say I think there's a lot of good content here. There's a question a bit about, you know, when there's a lot of the interesting stuff is in the appendix, which is not necessarily a problem, but perhaps just needs to be thought about. But I do welcome your comment, Angela. I think the question about, you know, the camel being a horse designed by a committee, I think no disrespect to my colleagues on the committee, but I think what's needed now is a step back and give it a single authorial voice. So I'm glad this is going back to committee, because I think, as I said, it's all there. Just needs a bit of stylistic tweaking. So I'm grateful. But as I said, I realise that it's sometimes quite painful when you take things through a committee and you do your level best to put it on, and then it starts to sort of work the original clear vision. So So I look forward to seeing the final version after it's gone to QAC and when it goes to the Welsh Government, so pretty much all the NHS executive.
Diolch yn iawn. Claire.
Thank you. I felt in the annual report there were things in it, particularly around that duty of candour, that I hadn't seen data reported in that way before. And it led me just to think whether or not it would be helpful, because some of it was really helpful and interesting and useful, whether it would be helpful in the future for the quality report to be following a similar format to what's going to end up in the annual report each year. So, because as I looked at that and then felt that there were things in there that we know we need to report publicly annually, but they're not things we've regularly been cited on so explicitly as they are in this paper. And actually that might help them with the reporting each year, mightn't it? Because it's a format the board sees regularly, and then we see the cumulative position when we're doing the final year-end report. So perhaps once it's finished, just having a look at ongoing reporting will be useful. And then some of the themes that identifies, perhaps I'll save my comments there for the next item, because that's the themes are the same themes, aren't they? Yeah. So I'll wait for the next one, if that's okay.
Thanks. Pam? Wedyn Mike.
Diolch, David. So I think it's really good to delegate approval to the Quality and Safety Committee, and then I think in terms of the next steps, it has to be published, I think, Angela, by the 31st of October, so we can just make sure the full board gets a copy of that in advance of that. I think it's really difficult because I think what's happened is we have the annual report and annual accounts, and this is a different timescale to report in. So lots of the information we will report as part of our annual accounts. So I think there is just something about this is the first year and the timescales haven't quite worked, and I'm just reflective for next year. What would be really good just to make sure our annual report and some of this is better aligned, and we don't duplicate some of the things. We can say that's either covered in some of that. So I think we can work on that, but I think it's just the way in which the timing has been done this year hasn't probably been helped. For us, so I just wanted to mention that, but we'll make sure the copy is once approved, circulate to board members.
Diolch yn iawn. Mike, wedyn Ria.
I'm not sure if I'm confused on this or I'm confusing you as well, but as regards duty of candour, are we talking about kind of practice with patients or? I've experienced it and I found it to be quite brutal. That's the best way I can describe it.
Okay.
Some bad news was delivered to an individual. The response was, does that mean I'm going to die? And there was no response. So I think there's lack of preparation, lack of training there by the professionals. Because, you know, it's the question that's going to come, isn't it, if you're doing that type of news. And so I've experienced it firsthand, and I found it very, very brutal.
Okay, we'll come back to that in a second. Ria?
Yeah, the duty of candour in here, it seems to be a process rather than a cultural thing, and I think it's the two things, isn't it? You know, this is talking about the process that has to be followed as opposed to the openness and honesty that all staff should be showing at all times anyway. So that was just one point. And I think the second one for me was when we're looking at some complaints and incidents and compliments, all of these things, is it physically possible to put it in a context of how many patient interactions we have over, be it a week, month, year, whatever, so we get a sense of the scale or how small it is. In fact, I would have thought, but this is just guessing, but a context would be good, I think.
No, good point. We can actually address those issues, but also share what's going to happen to the report. Whereas it's going to go to government, of course, but I wonder if it's the sort of report we should be sharing internally as well, making sure staff are aware of it. It's one of the things we picked some of the committees is we have all these detailed, in-depth conversations amongst ourselves, and then staff are not aware of some of the issues that are raised in some reports and so on, and that's something that we want to try and address in some shape or form. So just have a thought about those things.
Yeah,
I can ask you to.
If I say a couple of things and then come back to Ange, if that's okay. I think it's really helpful to have this discussion, and I was reminded that this is the time period of last year where the health board was escalated into special measures, with quality of services being one of the key things. So this has had a lot of scrutiny, a lot of airtime, a lot of contribution to recognise all the work on that. But I also think that if we are true about quality being at the heart of everything we want to achieve, it does feel quite difficult to get it all in one report. So Pam, you know, you're absolutely right about the annual report and seeing if we can get things aligned. We might need to feed back to Welsh Government about their timeframes and things. We used to have an annual quality statement. So, you know, I think we've already fed back about timeframes. What's interesting, just picking up Mike's comment really about duty of candour being brutal. I think there's two things here for me. One is the breaking of bad news should be a core skill of healthcare professionals. It's a very difficult thing to do and to land every single time in the right way. But that would be the sort of feedback we want as well about how to improve that. I've also had feedback from some of the families that I've met about where it's been done really, really well.
Yeah.
So we can share that. But I agree with Rhian about duty of candour, not just being about a process, but about a way of working. And I think as a board, we set out to be open and transparent, and that's really what it is. It's the proactive openness and transparency. So that's perhaps the test over time. Do we get to be known as a board that is open about its issues, isn't putting things, you know, under the carpet or hope nobody notices? And we do that by, you know, reporting things in a very open way. And I think we've done a lot of that this year, putting out really tricky things. Sometimes we've been challenged back on them, but you know, I think we're trying to set a new tone. Perhaps Ange could pick up the rest. Is that okay?
Yeah. If I just come back in the Breaking Bad News and the duty of candour. So it's very explicit within the duty of policy that we have to report how many duty of candour in sort of instances there are, and that is around harm to patients. So if somebody has had an infection which has caused them harm, or a fall which has caused them harm, then we have to formally contact and discuss that and write to the people involved. And that is the process, if you like. Having implemented duty of candour in a previous life, the process is the bit that getting people aware of, the culture then follows, because it's not then about a process, it's about making sure that any incident that is there, that people discuss it and have that openness and honesty, as Carol said. But we are doing some work around the communication, the Breaking Bad News, and identifying how we can support colleagues to have safe discussions with peers on how they would do that. As a student, and I'm sure Carol had the same, Breaking Bad News or being at a time of death, you were supported to enable you to gain those skills. We want to make sure that we're doing that going forward. From the point of view of the complaints and incidents, yes, we can provide how many out of the numbers that we've treated in that time frame. So we can work that in the background and give the context around that. Sharing will be as we are published on our website. It will be through board. We'll also be doing it internally to groups to identify the patient safety groups through the IHC's divisions, but from a corporate perspective, patient experience group. It will be discussed at the quality delivery group, the exec-led one that I chair. And we'll also be looking to share with partners externally as well. That open and honesty, and then to ask them to give us any questions or feedback about what their experience has been of what we think we've delivered compared to, you know, how they've received it, I guess.
Diolch yn iawn. Pawb yn hapus felly I dirprwyo y cymeradwyaeth yr adroddiad yna i'r pwyllgor fel da ni wedi dweud ac nodi adroddiad blynyddol. Pawb yn hapus? Gwelwch yn dda. Diolch yn iawn. Ymlaen y eitem nesaf sy'n parhau gyda'r un thema ond y tro yma, adroddiad sy'n dod I ni fel bwrdd am y cyfnod diweddar ar gwella ansawdd ag Angela unwaith eto.
Okay. So this is our improving quality report, our regular report that identifies the activity that has happened in between board meetings and the position that we're currently in. The key points I'd like to raise are the main themes of national reported incidents remain falls and healthcare acquired pressure ulcers. There is some work information in the report that identifies some of the work that is being undertaken. So we have a falls collaborative that meets across the health board. And I have a quarterly executive meeting with the teams around falls, and we've seen significant improvements around that, which we've had external comments around our improvements around falls, more confidence in the way we are assessing patients before they admitted to the hospital, and assessing patients if they've had a fall with multidisciplinary team reviews, and then making sure that our staff are fully trained. And we had just over 2 years ago, a new falls training that was put into place. We had a very, very good uptake, and then everybody sort of lapsed a little bit. So we've now captured back up again, and we're meeting the mandatory requirements for that level of training, which is really positive. But we have got, you know, still work to do. falls is an issue across the NHS, and it's something that, you know, we can learn from each other as well. So we're making sure we're networking across Wales and the UK on some of the developments that is happening around this. From a pressure ulcer perspective, I've just set up the exec meeting, quarterly meeting, and one of my new directors of nursing in the West is a tissue viability nurse by background. So she's now taking the lead for the organisation on pressure ulcers. We've also appointed a matron for patient safety who's working really, really closely with Vic over in the West. To try and make sure that our policy is aligned, that we're utilising best practice, that we're engaging with our medical and AHP colleagues to ensure that we've got that joined up understanding of what we need to do and how we need to improve. The number of overdue complaints remains high, but we have got a trajectory to meet by the 14th of October. And we are working really closely with the IHCs. Initially, we launched it with Carol and I meeting with the IHCs on a fortnightly basis. I'm meeting on a weekly basis, and I go through the top 20 overdue complaints and then the ones that are due to tip over the following week to identify if there is barriers, if they need support, what extra support the central team can give them. We're also, as part of the integrated concerns incident policy, identifying how we can refine what we're doing within complaints, how we can make sure that we're more timely, that we've got the oversight, that we've got the support available, and that we're learning lessons on the back of it as well. So that's working really well, and the complaints team are as part of that concerns hub that meets on a daily basis to show that we can do that cross understanding of where we've got the issues. We had 2 Regulation 28 prevention of future death notices from the coroner, and I can confirm both of those have been responded to with information to the coroner within the time frames identified, and we've got action plans. It was working around our ED mental health interface and how that works most effectively, and Teresa mentioned that earlier around the team's work that was actively happening. And then we've also got progressing the improvements around isbitiguanid fluid ED, where we've identified it's been stood down from a HIW perspective, but we're obviously got an action plan in the background to make sure we've got further improvements that are there. We've got audits in place, we've got meetings and escalation through to the regulation assurance group to make sure we're moving on that. But I'm happy to take any further questions.
Right. Diolch yn fawr iawn. Mae'r adroddiad yna ar gwaith sylweddol sy'n digwydd. Cwestiynau, a droi at Mike gynta, wedyn Rhea.
Thanks, it's a very comprehensive report. There's just one thing I wanted to highlight, and that is the End PJ Paralysis Programme.
That was my point.
Oh, do you want to speak to it?
No, Mike, go.
I've got family experience of this in a community hospital. I mean, I think we're all aware of the physiological benefits. It helps reduce venous thromboembolism, you know, lots of things like that. But I think I saw the psychological effect of it. It really does give people a boost to be able to wear their own clothes. And I love the way it was communicated to the older patients. Like, you know, if you wear your clothes, you're more likely to join the escape committee. And you know, it is easier just to lie in bed, I suppose. So I think it's a real success. Are there plans for it to go out to the community hospitals, where I sort of into our 3 hospitals? Just wondering.
Hold that for a minute. Letitia,
I'd not come across the term PJ paralysis, but it really leapt out and struck me. And thinking about my experience of visiting people in community hospitals and the acute sites, it's really significant, isn't it? It really is.
It's that mentality of understanding, you know, that this is the bed is a temporary measure, not semi-permanent, you know, so really good. Anyone arall? Os na, Claire.
I was gonna, there's clearly lots and lots of work going on around the areas that continue to be regular challenges around slips, trips and falls. So, you know, the things that we highlight each time, whether that's nationally reportable incidents or complaints we're investigating. I wanted to just ask Angela really, but on the basis of all the work that's underway, your confidence level around when we'll start to see the improvements that you're clearly working towards, and what for you good looks like, because I guess we have to also be realistic that some people will fall, some people will get a pressure ulcer. So it's just to get a sense from you really about where you think we are on that journey and what the timeline might be, where we get to a point where you're feeling you can give the level of assurance to the board that you'd want to.
Great. So if you can take that point and any others, and we'll wrap up.
So I think compared to when I arrived 2 years ago, I think the amount of work that's gone in by the teams and their ownership of the harms that are being caused on a daily basis is immense. The difference is immense. We are now seeing, we will always have falls. You know, it wasn't long ago that I fell down the stairs. You know, we will have those falls. But we need to make sure that when we're assessing those falls, we've had the appropriate risk assessment when the patients come in, that the drugs that they're on have been reviewed by the pharmacy and by the medics, that we have got the appropriate environment for them, that we are supporting them by the bedside if they need it. And those are the indicators, I guess, if there is a fall, that I'm more confident that all of those things have been done and they've still fallen. Yeah. Because, you know, you could ask somebody to stay in bed and ask for a nurse and then they climb over the cot sides. And that's a really difficult position, or they get up off the toilet when they've been asked for privacy and dignity. They want to be on their own, but they're outside the door, and then by the time you've opened it, that's the difficult one. But if we've done those assessments and we can articulate them, we've now got a falls dashboard, which the ward managers and the teams can actually look at when the most falls happen. So what day is it and what time is it? So is it at handover? So are we spreading the staff who are not in handover to the right places? And if they can articulate that, then I'm comfortable that I can assure you that we're doing everything. The same with pressure ulcers. You know, have we encouraged the patients to move? Have we put the right things into place? Is it everything that we've done? If the deterioration, is it due to nutrition, but have we made sure that we've been offering high calorie drinks? Is it, you know, that somebody doesn't want to move, so we've spoken to them and got some psychology support maybe to understand why they need to move? And if all of those assessments have been done and it still occurs, then it's sad, and we don't want that, but I'm assured that the teams are working together to make sure that doesn't happen. So I guess that's when I will be. Okay. But I don't think we'll stop seeing falls, and we might see, you know, reduced, and we also might see less harm. Yeah. So if I can just have less harm, so patients with no harm or low levels, and we're not seeing the catastrophic harm that potentially could happen, then I think that's when I'm more assured.
Yeah. So so thank you very much for those points on the report, and it will be good going forward if we can indicate progress. And I think that's what one of the points Claire was making, isn't it? Yeah. That where are we heading to? So that journey, Carol and I talk about this a lot, is the key thing for us in the health board is progress. So incremental, sustainable progress. So some of the data can perhaps be brought forward historic, and so that we can see that path, that journey. That'd be really useful.
Could I just put a note on that? I think that's exactly the same for some of the areas we're going to cover now as well, in terms of where have we been, where are we now, where are we heading? Yeah. So that's progression.
Yeah.
Can I just?
Yes, certainly. Yes.
As well?
Yes.
So NPJ classes is amazing, and it has been successful. Community hospital, we will be rolling it out the whole of the acute sites as well. We've got a patient deconditioning group that when Gareth was director of therapies, we joint launched it. And actually one of Teresa's deputies is now the chair of it. Trying to get some ideas and things that are working in different areas, and then scaling them up at pace to make sure that we are assessing patients when they come in as to what their level of activity is, what their level of conditioning is, and then be able to identify when they're discharged, where they are then, and making sure we've not had that dip. Also looking at hospital-acquired pneumonias. We've got a piece of work going on at the moment. There was an infection control report that's now been taken through that group to identify how we can reduce that happening in hospital, because it has some catastrophic outcomes if you have that. So we want to make sure that that's included. So in a future QSE or board, happy to bring back some of the outputs of that, because I'm really excited about fits into the 6 goals work within that, but really excited about some of the opportunities, and those initiatives are being developed from the ground. So people are seeing what they can do and they're making sure it's working.
Yeah, great. Diolch yn fawr iawn, and it's great to hear about the connection staff have with leading that and the difference it makes. So that's excellent. Pawb yn hapus i dderbyn yr adroddiad yna gyda diolch am y holl gwaith. Ie, diolch yn fawr iawn. Ac dyn ni wedi cyrraedd egwyl am ginio. Os ydy pawb yn dymuno cael cinio, nawn ni ail ymgynnull chwarter wedi 1. Ydy hynny'n iawn? 1:15. Pawb yn hapus? Reit, nawn ni gymryd toriad rwan am ginio ail ymgynnull chwarter wedi 1. So, use that 1:15 on the dot. Iawn. Iawn, a chroeso nôl i gyfarfod bwrdd iechyd Prifysgol Betsi Cadwaladr am ein sesiwn pnawn. Yr eitem gyntaf sydd gen ni ydy adroddiad gan Gadeirydd Pwyllgor Cyllid Perfformiad a Llywodraethu Gwybodaeth. Mae yna gopi'r adroddiad yna yn y papurau, ond na i ofyn i Gareth fel Cadeirydd os mae yw eisiau tanlinellu unrhyw beth o'r adroddiad. Diolch yn fawr iawn.
Diolch, Cadeirydd. No, I don't think there's anything particular I need to raise on the report, which we tried to keep mercifully short, and like the things that come next. But
Diolch yn fawr iawn. Ac yna, da ni'n gofyn unrhyw gwestiwn am y adroddiad yna. Os nad oes yna, nawn ni droi at yr adroddiad ei hun, adroddiad perfformiad integredig, a gofyn i Russ fel ein cyfarwyddwr sefydliadol cyllid dros dro. Russ, over to you for this report and the next one, please.
Diolch, Chair. So with the report, we'll go through colleagues and then come back to myself. I know we've discussed urgent emergency care and we've also discussed quality earlier, but in case anyone wishes to add something, then obviously we'll take on the urgent emergency care aspects, and then Georgia will just talk us through the people and performance. Come back to myself. I'll talk us through plan and care, if that's okay, Chair. Yep. And then we'll take the finance report as the next paper.
Great.
Yeah.
So from a course perspective, as Russ identifies, most of what was included has been discussed in previous reports. I would just want to put attention to the clinical code and compliance and the plan that we've got in place to improve that with recovery plan in recruiting more trainees and supporting the work. We've had a slight improvement in months. Obviously that isn't significant, but we will hope to see that progress as time goes on.
Yeah.
From urgent emergency care, we're pretty much covered in the earlier section. I mean, from performance point of view, obviously we're keeping a close eye on that. And as part of the 12-week focus, we'll also be ensuring that our trajectories that we've signed up to externally and internally are translated in terms of day-to-day position, what that means, and the allowance for breaches, so that we can then start aligning it much more to the board reports at the line.
Very much. Good.
So yeah, just a few points really. So sickness remains at fairly consistent levels, higher than we would want across the organisation. Obviously the culture, values and behaviours work will support the reduction of sickness going forward. We're also finding, like our population, that staff are often presenting with more complex health issues, and the discussion we had this morning about wellbeing will again support the reduction of supporting staff there. Turnover of staff who have been employed for less than a year is quite consistent, but is at 14%. So I think that's an area we might want to look at a bit closer to understand why that is. And you will see that there's been a great reduction in disciplinary cases since January this year, and focus remains on improving that position, but also the culture and behavioural work will support that, and also the work on just culture as well.
Thank you. And just briefly on plan care, if I may, Chair. So clearly, cancer performance really does impact in terms of short term where we find ourselves with plan care, because we are fighting those two really important agendas for us. The urgent emergency care aspects of crowding out essentially routine elective capacity. So there's a real alignment to the earlier agenda item to make sure we create capacity and then we treat in turn. But I have to say the operational teams through the delivery meetings are really engaged with this subject matter now. And they're creating some really good innovative solutions as to how we move forwards. We have eradicated the 208 weeks. They're all booked now, so we don't have any unbooked as of today, and if any do move into that unbooked arena, then we are urgently moving those into a completed pathway. The 156 weeks have significantly reduced as well, and you'll see that through the chart. So week on week, we are seeing improvements in performance around our extreme weight position. We have commissioned additional insourcing through the health board support as we had the discussion in detail in July's meeting. The endoscopy has already come online, so we're already seeing a circa 30 to 40% increase in endoscopy capacity. We're out to the market for dermatology as well, so that work is due to conclude, and we're looking to commission. That again will give us a massive improvement in terms of our performance. And both of those elements will drive improvements in our cancer performance in terms of the backlog, but they'll also drive improvements in terms of the 156 weeks and extreme weights. So we will see that move fairly quickly. The cancer performance, as we tackle the backlog, that's when those individuals become a breach. So we will see that performance reduce. We are profiling that performance so that we can share that through the next meeting. We will take that profile performance through people because, so we've got committee oversight. In terms of the 156 weeks, we'll continue to report those gains as well. Also, in addition to that, there's 104 weeks all Wales target, and I think we alluded earlier that that's a really important target for us and Wales position. We are and have done an awful lot of work. I'd say the operational teams and the IHC leadership. They've developed a grounds up forecast model in terms of patient weighting, and we've applied some metrics to that in terms of the insourcing capacity coming on stream. And that moves us into an outturn position of circa around 7,700 patients. We'll share those revised trajectories with people at its next meeting so we can interrogate those still further. There is an opportunity for us to improve performance down to the trajectories we put forward in May and slightly improved on those trajectories with additional investments, and that's being considered through Welsh Government channels as we speak. And again, we'll share that information back through PP. So I think it's certainly an improvement from where we were, significant change. I would say there's substantial buy-in through the operational and the IHC leadership teams, and we are seeing that sea change really, both in our extreme weights. It's still fragile. We still need to keep that focus. We're not delivering as we would like on treating turn, and we need to keep the pressure on to move that model. But once we treated our suspected cancers, we'll then be able to free up our internal premium working model, which is waiting list and and that will then support routine elective capacity delivery. So it is good progress, really good progress, but there's more work to do.
Great, thank you very much for that, Russ. Cwestiynau, unrhyw un isio holi cwestiwn? Mike gynta, wedyn Rhian, wedyn Gareth.
Could I ask in terms of general trends as regards cancer, are we saying, or are we predicting that the inevitable graph, it's been 1 in 8, 1 in 4, 1 in 2, are we going to get to 1 in 1? Because that's the direction of travel that has been for quite a few years now. So, and if that is if something tells me differently, I'm willing to listen.
Sure.
But I'm just wondering whether, as regards capacity for the future, it's something we've got to be open-minded about and possibly have to look at.
Okay, we'll come back to that. Rhian.
Thank you. It's good to see progress, obviously, and that the lists are coming down. But of course, it's all coming down at a cost, isn't it? And we're going to reach a point where that is not sustainable. And we've got to get our processes and streamlining and whatever in place so that we can then not spend so much on insourcing or premium working. So I just wondered what sort of timescale we've got for that sort of crossover from getting them down to being able to sort it ourselves so it doesn't go up at an extra cost.
Okay, good point. Gareth?
Yeah, well, I first want to say, I think PFIG's keen on trying to keep on top of this. I think there's a lot of really good work going on, but we keep on getting brought back to the fact that when you look at the figures, there's only 4 out of 34 of our access and activity measures in which we're on target, which is really still pretty depressing. I don't want to bring us all down, but it's true that we've got a really big challenge on. I did notice, to pick up Rhiann's point, that there's a statement, we've got two different sets of data in here, which is fine, because we've got the end of July data, and then we've got more update, which is, it's really good to have more update. And I would appreciate if you can just, if it's possible, Russ, if you can just give me the figures on where we are on 156 unbooked appointments. But I did notice that that at the end of July, one of the things that happened was that by doing the whack-a-mole on the 208 weeks, that the numbers from 156 and 104 had gone up, because so it's quite a long journey, I fear, but we are making progress. And my only real worry is about, you know, the sheer amount of effort that has to go in to sort of deliver it. It's obviously putting a strain on a lot of people, but we just have to do it. But yeah, I'd be interested in just the most recent figures, as I know you're updating every week. And the only other, it's a relatively small point, but I think it's the important one, and that one of the things that's attributed to the problem with therapy waits is not just staff capacity, which obviously is not something we can wave a magic wand on, but is the question about space. And that brings me back to my sort of probably boring point, but you know, about, can't we be more imaginative about following the example of audiology and moving things that are currently secondary care services into primary care? Now, obviously, on the primary care premises don't have the room either, but where they do, should we not just be holding clinics more out in primary care locations than saying, oh, well, we can't do enough clinics because there's no room in the hospital premises?
Good point. Claire.
Thanks, Rob. It's useful, I think, on the nursing and midwifery sickness, so stress and mental health being two key factors, and on the turnover figures of people leaving, within 14% of people leaving within the first year. I would really appreciate perhaps at the People and Culture Committee more of a deeper dive really about understanding what we're able to do and what we are doing to try to address those, because the one about the turnover in the first year is it's really really disappointing and quite scary to think that people join with good intent and stay less than a year. So there's got to be something about our recruitment processes, what people understand the job roles to be that they're turning up to do, or recruitment decisions. So it's just be good, I think, at People Committee to understand that in a bit more detail. And then on, it's probably the same point Gareth's just made, I think, but he was perhaps more eloquent. In terms of children and CAMS and mental health and ADHD and ASD assessments, we're doing quite well at assessing people, but we're doing terrible at starting treatment. Is that your point about premises? And then also,
I was looking more at the physiotherapists, like but there's an element, I think.
So my question is it not the same people with the same skill set that do the assessment and do the therapy, or is it different people? And if it's different people and different skill sets, what are the issues and how can we address them? Because those have been, again, underlying problems now for quite some time. And then the final question was, and it might be me and graph reading, Russ, but on the 104 weeks, my understanding of the graph on page 13 of the cover paper is that we're anticipating those to increase to 10,000 by the end of the year. So the trajectory is that they're currently at, what are they, about 7? So how are we going to, and then there's a little note that says we've asked Welsh Gov for more money. So are they going to get to 10 if we don't get any more money? Or
getting to 10
because we're supposed to get to 5, aren't we? I am understanding that right, I think.
We'll come back to that in a second. So the issues on the workforce that you've raised, the need for us to look in detail, and the People and Culture Committee can do that if that's okay. That piece of work I think will be quite useful. Some of the other questions though, I'm sort of seeing who wishes to take those, but Billy first of all, and then
really welcome the changes that we've got in workforce processes and the move to Just Culture. I think that will link very much with what we were discussing before lunch. With the duty of conduct.
Yes, good point. So can you coordinate who's going to field some of the answers?
Just on a deal.
Maybe Teresa has some responses in some, I don't know, but you can.
Yeah,
you can
so I want to
conduct the orchestra.
conduct the orchestra, sing a good tune. On cancer, you know, Mike, this is really important in terms of our forward planning for services, is what's going to be happening with cancer. And you're absolutely right. And some of those cancer rates going up, a couple of reasons. One is, on the whole, over the last century, we're living longer, so that's a good thing in a way. But the other thing is that we've also become more unhealthy, and we're not, as a society, taking all those steps regularly that we can do to prevent, so the exercise, the diet, or that sort of thing. But there are some good things in there as well, which is back in the day, if you had cancer, it was, likely to end in your premature death. People are living with cancer as a longer term condition now, and having many new therapies and that sort of thing. That said, if we were to compare cancer outcomes from Wales with Europe, we are way behind achieving the same sort of outcomes of the best in Europe. We're seeing an increase in about 9% over the last year of referrals coming through for cancer. That is probably not enough in order to pick up cancer at an earlier stage and to achieve the outcomes that are the best in Europe. The challenge I think we've got is, whilst we're trying to get earlier tests and more early intervention, we've not got the system, the NHS set up to cope with that. And if we think we need to come back to diagnostics, really think about what's the diagnostic strategy for the next 5-10 years, and what's the follow-on from that. So a lot of work needed on a longer-term cancer approach, so that we can plan for the future. Rhian, on planned care at a cost, and there's two things here, I think, Rhian. One is we've still got the bubble of the backlog around. So for some specialties, it is a backlog only issue, really. For other specialties, so if I take dermatology, a lot of referrals coming on skin for the suspected cancer pathway, and we'll put a footnote on that. So different specialties have different issues, if you like. What we really want to do is to move that investment that we've had from the government, £34 million for planned care, into more sustainable solutions for the longer term. With some of that work is happening. Not quite quick enough, but we've got some sessions coming up on specialty basis on orthopedics. I think we're going to have one on ophthalmology. I'm chatting to the dermatology community this week, one on dermatology, so that we can start to bring in those different ways of working. So it will go as you it'll go like that. Physio in the East in particular, I know that the therapies, I know maybe Teresa will want to comment. We discussed this at IQPD this week, and then I'll leave Russ to do the 156 unbooked numbers, if that's okay. Russ? And then we go to Teresa.
No, that's brilliant, thank you. So really, I guess to also give my spin, I suppose, in terms of where we're using the resource. So absolutely, we are at the moment really focused in on using essentially premium working in order to correct what is a gap within our service demand versus what we're currently seeing as patients through our in-house capacity. I think there's a dual approach based on specialty, and there'll be a different outcome for each specialty based on where they sit. But essentially, what is our capacity? And that's against what we are currently seeing and what we have as potential to see. So that's about benchmarking, making sure we're productive and efficient within that model as well as an overlay before we look to how we invest, because we want our services to be productive before we start assessing that we're going to invest back within them. And then there's demand as well, which really links into the earlier agenda around where we go with prevention, because demand could be what's currently effectively coming through the referral patterns, or that may or may not be appropriate. And actually, we might be able to avert some of that demand through investment into that front loading of the prevention, which again is a really good agenda item for us to discuss. So I've seen that happen before, and people that have growth funds into primary care on the basis that manages future demands coming through what would have been through the hospital accommodation, and we don't have the infrastructure to service. So there's quite a bit of work on that, both demand and capacity modelling by specialty that's currently in train and working, but we've got this backlog and we're not going to get that work concluded in a timely manner for us to be able to take a substantive judgment on investment. And then we move those resources substantively into our in-house capacity and start investing in our services, which is absolutely what we want to do. That's the best bang for our buck, isn't it, for the 34 million that Wales Government offered and we've taken. In terms of where we find ourselves today, we've got 156 weeks, we've got 1,264, I believe, unbooked. That was the information that was provided for me yesterday after the escalation meeting through the planning care session. We've got 40 patients currently waiting within 208 weeks, which have booked appointments. There's this strange model where some of those revert back out and then revert back in, but essentially they are all being taken care of. So the national reported metric will suggest around 40 patients will also close of the calendar month, but they all have slots to be treated. It's just about building that capacity.
Great.
And we've already mentioned physio, haven't we? So yes.
Teresa, dwi'n meddwl, ie.
Diolch am llawer i ddweud, mae'n cafodd i ddeud ei hyd i gwir. Ond o ran y therapyddion, mae'r ystadau, dwi'n meddwl, yn her go iawn erbyn hyn. Mae'n dod yn ôl i be mae'r ysgol newydd bod yn trafod rwan. Dwi'n meddwl bod ni rioed wedi gwneud gwaith rhyw soffistigedig iawn ar galw a capacity o fewn y therapyddion. Mae'n ydy rhyw dod mewn ffordd allan o'r bliw fel problem, ac wrth gwrs da ni yn ddibynnol ar yr cynllun strategol sgynnon ni stada ar hyn o bryd. Da ni gyd yn gwybod bod yna gwaith o yna, dwi'n aml yn siarad efo Mike di bod ynglyn â heriau yn iechyd meddwl. Wel, mae'r heriau yr un math yn y maes therapyddion, ond dwi yn hapus iawn i weithio efo'r ysgol ag ati ar y gwaith stada, ac wrth gwrs hefo aelodau newydd sy'n ddod ymlaen. Dwi yn meddwl bod Gareth yn iawn, mae rhaid ni edrych allan o'r bocs ac edrych i'n cymunedau a gweld lle ydym ni'n defnyddio. A dwi'n meddwl, mae dyna di'r her i'r therapyddion, ond mae yna heriau eraill fel da chi'n deud fel staffio ag ati. Ac wrth gwrs mae yna cynnydd, da ni'n gweithio wahanol, mae'r cynnydd yn wahanol, ond da ni ddim bob amser di edrych ar y modelu capacity yna yn y meysydd yna, oherwydd da ni fel arfer yn draddodiadol yn edrych ar y meysydd eraill gyntaf.
Shall we just pick up the final point that Claire made, which was, what's the numbers? So the 10,000, the 5,000 and the 7,000.
Yes, sorry, apologies. I did have trajectory written down. I was wondering, oh, what So yes, so when this paper went forward, we hadn't concluded the work with the IHC. So our trajectory was to move towards a 10,000, which gave us that 5,000 gap. And current performance suggests that 31st of March, that's where we were heading. We've done that work with IHC colleagues, and they've submitted their detailed plans reverse up. We've overlaid those with now when we believe the insourcing contracts will take place, because they didn't include the benefits. So endoscopy already happening, dermatology, we're going to conclude that tender process in a matter of weeks. Once you put some of those overlays with validation as well, so there's a piece of work on validation, it moves us back to about that 7,700, but it's just a timing issue that this report went through. That report's been sent back through as well and shared, and Wales Government colleagues are supporting us with the profiling of delivery of that activity as well. And then there's additional opportunities for us to seek additional resources, which would then bring it down below the 7,800. And that's when we hit the 5,000. And the dotted yellow line, that's our May plan submission. Clearly, we'd be sort of hovering at delivery of that based on an additional allocation of resource, which technically wasn't the basis for the May submission, but the numbers would equate back around that value.
But we just need to remember, don't we, that the target, the Welsh Government target was, although I think they recognise we're not going to reach it, was 0, wasn't it?
Yes, absolutely. 0 for stage 400, stage 104 weeks stages.
Okay, iawn, diolch yn iawn. Pawb yn hapus i dderbyn yr adroddiad. Yna, gawn ni ddiolch i'r ysgol a pawb arall am y gwaith gwych iawn sy'n digwydd, lot fawr o waith. Diolch fawr iawn, ysgol. Next item Russell, is yours to the finance report. If you can just give us some highlights on that, please. Thank you.
Yeah, thank you, Chair. Just really quickly, the highlights through the finance report. So as you're aware, signed up for a 19.8 million deficit plan, just below the £20 million or 20 million control target that was set by Welsh Government. To do that, we need to hit a £48 million savings ask. And in addition to that, we have included the £82 million that we were in receipt of again for the 24-25 financial year. We had that for 3 years previously. It was due to come to a close on the 23-24 years. So our 24-25 plan effectively has £82 million of one-off funding and a 19.8 million deficit with a £48 million savings ask. How we're performing at the moment. So in August, we had about a 1.6 million adverse reported performance to plan. So we had a 3 million in month deficit position. We've gone to a 16.8 million deficit year to date. So we're £8.6 million adverse to plan. And clearly we're seeing some capacity issue costs. We're seeing continuing healthcare increasing costs. We've still got out of area mental health costs. So there's a lot of work going in the background to try and reduce the cost exposures, and savings again has slightly contributed. Although savings, we've moved now to 42 million, just over, of the 48, and the majority of that as well on a full year effect would be recurrent. So a 38 million pound recurrent savings to performance. So that's really good progress from where we were. We're pushing the savings to get to the 48, and then we're going to continue on that drive with savings delivery, because we don't want to start next year from a standing start. We need to build for what we're going to have as a savings programme as we go into 25-26. So what we're doing, we're meeting through essentially escalation forums with our IHC leadership teams and other areas that are experiencing financial difficulty to understand how we can move those costs down. And those meetings are happening this month. We do forecast every month, which is why we know we have a 20-25 million pound risk to delivery, but we're now homing in on those forecasts. And we are seeing that some areas are expecting to recruit current vacant roles, which haven't been able to be recruited to previously. So there is some challenge going into those forecasts as we speak. And clearly we're having conversations about how we live within our means, so we can give ourselves assurance as a board as we go forward that we can deliver the plan. And we will take that back through P figures of reforecast. The overall climate in Welsh Government is one of challenge financially. There's a lot of health boards experiencing significant financial difficulty. And so there is a real focus back on financial performance again. Some of that delivery and assurance through those meetings that are going to be held will determine as to whether there is available resource to support further movements within plan care, as we've discussed earlier. So there is a lot riding on this. And just to give you, because that seems a little bit down, doesn't it? So to give, because I believe someone told me this, it's International Week of Happiness. You're experiencing that through the board, I'm sure. So to give a bit of light on the end of the tunnel here, so we need to save about 1.6 million a month. We're spending 1.6 million a month more than we should, but we spend 190 million plus every month. So it's 0.8, 0.7% reduction in month. So it's tantalisingly within our grasp. And of course, the 82 million pounds becoming a recurrent allocation for us going forwards is a really good driver for us to try and find that small percentage improvement as we go forward. So there is an opportunity. Clearly, there's opportunity for us to get there. We're doing a lot of work in the background to make sure we can assure ourselves that we have a route to delivery. And clearly, from Welsh Government perspective, there's a lot of focus back on the money.
Diolch yn iawn, ac mae Gareth yn cadeirio yn edrych ar y gwaith yn fanwl iawn ac yn monitro'r cynnydd, ac mae'n adroddiadau cyson hefyd yn dod ar y perfformiad fel da ni wedi gweld heddiw.
Gareth? Well, first of all, I do want to say I think that that we are doing really quite well at the savings, and I think I do want to pay tribute to Russ and the team for the work that's going in there. You know, obviously nice to get to the 48 quicker rather than not, but 42 is pretty good at this stage of the financial year, I think. So, and you know, I think you're right, Russ, aren't you? That it is sort of tantalisingly close to get to an outturn that will give, if not the week of happiness, the year of happiness to the Welsh Government. I've got to say, despite the fact that I'm normally fairly good with numbers, I'd just like to unpack a little bit what happened between July and August, because it looks as if it got a lot worse. On the other hand, in July, we had a big one-off accountancy gains, but we had some accountancy gains in August. So actually, was August slightly worse than July, but not a lot? And do we know why that was, or would that be normal? Whatever normal is. And then the other question I got was completely separate, and I seem to remember we had this last year, but it may be it's like Groundhog Day. But I was intrigued with the expenditure pay line, not about the pay, but the fact that there's been an increase in the budgeted full-time equivalents from 19,130 in April to 19,789 in August, which is a 3.5% increase in the number of approved budgeted staff. And I'm not sure how that's, it may be that it's specific posts that have been funded that are short term, but I wonder whether somebody can reassure me that, you know, for all the good work that's going in, that our staff always seem to be growing, you know.
Yes. Just before you come in, Russ, just check. Mike, Claire. Mike?
No, you go first.
Mike.
Okay.
I got too much.
Want to know what? This arrangement that we've heard in the media about cross-border, we could call it that, provision, is that something that we need to take into account? I'm guessing it could increase our costs. Presumably these things don't come for free. Is that something that's been taken account of, or is it impossible to know because we don't have the details yet? Just wondering.
Yeah, I think your last sentence sums up, we don't have the details yet, and when we have details, if we have details, then we can build that into our trajectories or whatever. But I'm not sure how it's going to impact on our financial performance actually. But yeah, we'll wait for details.
Thank you,
Claire.
So my question is lots of them are exactly the same as Gareth. So I guess just a summary around your confidence level, Russ, that we're going to be able to find that additional shortfall, because we've got to get to a place where that 82 million becomes recurrent.
Yes.
So just your confidence level, because obviously there's been accountancy gains that have helped, some savings, and even if all of those pipelines were delivered, we're still short. Where's the rest can come from? And then just one on capital, and this is a bit of a pedantic point, but we say in the paper you always spend less in the first part of the year. Well, I'd argue if once you know what your budget is, you can start your procurement straight away, so that shouldn't be an issue. But if we do know that, let's profile it different, so we're not reporting that we're not performing against.
Yeah.
We don't have to take the number and divide by 12, do we? If we know that
No.
we always spend it all. So it is a pedantic point, but it would mean we wouldn't have to discuss it then, because it would be like, actually, we're on target.
Yeah.
Thank you.
Okay, Russ, any thoughts on some of those issues, please?
Yeah, so the capital one, we'll look at the profiling. Absolutely, we do profile, so it's not an equal to health model, so we are behind on what we classified as our profile. So there is something for us to push on with that, and clearly for me, I think there's a risk to us actually being at this level of the year. And you, as you quite rightly suggest, you know, the reality is, whilst we can't push ahead and spend on what are major capital works and capital projects, and so, for example, a big part of our project or our programme this year is the Llandudno development.
Yes.
That will be as it progresses through the year, and building infrastructures, once they're approved, they do take time to come on stream. We've got medical equipment, we've got diagnostic kit, we've got effectively IM&T projects. So we can be committing that resources in advance, and whilst we've profiled it, we are slightly behind the profile. So I want to push that if I can, but we will go back and have a look and take the opportunity to make sure that the profiles are robust, and if we need to reprofile those for future reporting. So they are a realistic signal of where we're moving behind on plan. Because we do have to spend within £500,000 of our allocation in year, so it is a key performance metric for us to deliver. So quite focused on that one.
Okay, diolch yn fawr iawn.
No, I was going to come in after you finished.
Oh, okay, okay.
What we agreed with.
I mean, the expenditure from July to August, we have seen increase in costs. We've seen those in non-pay. Continuing healthcare has gone up.
Yeah.
We've also seen some cross-border transfer of patients, which has effectively seen an increase in cost as well. So we have seen that cost creep. It's extenuated a little bit because we did have that one-off accounting gain, which was quite significant in July. So we had a £3 million one-off benefit in July. So I think what we're seeing is a consistent cost exposure, but they're not having the benefit of our one-off accounting gain. And then CHC is driving additional non-pay costs, unfortunately. So there is a trend where we need to reverse that.
Okay, Carol?
So can I just clarify one thing, because there is a reference in the covering paper to fortuitous accountancy gains in month. So is that referring to August or July? Because I knew about the July one, but
there are some
in August,
yeah,
but they're less than.
But they're a lot less than.
Okay.
3 million a month would be
welcome. Don't get too excited by the prospect.
No. It's I wasn't trying to unpeg.
Sorry.
Just on the whole-time equivalent shift.
Yes.
So that's around where we have allocated resources, and then that resource is coming out of the reserve. But I think for a comprehensive answer, we'll include a reconciliation of that and we can share that around the board. But it just reflects the developments that we're
recruitment. Dylan.
You should just ychwanegu un beth. Dwi'n gwybod mae Russell yn boen mawr I fi. Ond mae gen I ni cyfarwyr cyllid sydd yn da iawn. A dyna'r peth. A dwi'n gobeithio bod gyda hwnna I feddwl amdan. Dwi'n gobeithio bod y poen am fod yn llai yn y dyfodol. And this is the key thing really, because there's a lot of, Russell's doing a great job and the team, but it's painful.
Well, I think that's really.
It's not the job of a director.
I think that's really well put. There's something about short-term pain for long-term gain, but the associated thing is the way we approach finances in the organisation. That's the big gain to make, actually, the way we invest, what we're doing with our money. That is equally as important as creating savings of the millions we're doing. And it's that sort of discipline and understanding that we're developing as well, hopefully. So we know exactly what we're getting for the money we invest. But final thoughts from Carol.
I thought Dylan was going to ask for more capital investment. I'm sure he is.
From the underspend.
Great. So I think Claire asked about confidence, really. So I was just trying to think where we were this time last year, and we had to really put the brakes on really quite heavily in sort of August, September last year. And it talks to your point there, David, about trying to move the organisation to one that is financially disciplined, focuses on how we invest and the value we get from that. And I'm sure we've still got quite a lot of work to do on that. I guess, Russ and I had the conversation the other day that day 5 in October is going to be really important. So where will we be in October? So that's only 10 days or so's time, isn't it? And I think we may have to come back and think about some of the choices that we might need to make, because we really do need the £82 million to be secured for us. We know we're not delivering the performance requirements that the Welsh Government set out in other areas. And we're so, as Russ has said, so tantalisingly close on the finance. And when we start to think about annual plan, 3-year plan, some of the things that really get plans over the line of whether we've got a financial governance and performance regime, and whether we're improving performance in other areas. and whether we're becoming, you know, an effective organisation. So these things matter to us. So if we're that close, but we could be losing it for being that close, I think we need another conversation about what more we should do.
Gret, diolch yn iawn. Pam yn hapus I dderbyn y adroddiad a diolch yn iawn am y gwaith sylweddol sy'n digwydd a'r cynnydd a dyn ni'n edrych mlaen at barhau. A diolch am bod yna gyfarwyddwr cyllid sydd yn flin iawn, ond sydd yn gwneud gwaith ardderchog. Great description by Dylan. Da iawn. Ymlaen, dyn ni'n rhedeg ar ôl amser rhywfaint, felly gobeithio gallwn ni bwyso dal I fyny. Yr eitem nesa ydy datblygu canolfan iechyd a lles integredig Caergybi, ac dyn ni'n awyddus I gael hwn ar yr agenda bod ni'n cael trafodaeth yn y rhan breifat oherwydd ystyriaethau masnachol. Mae yna gyfle I ni dim ond nodi beth yw ein bwriad ni yn y maes hwn, ac yn absenoldeb Chris, dwi'n meddwl dwi am droi at Carol jyst I ddeud gair byr ysgolch yn dda.
Diolch, thanks ever so much. It's a pleasure to bring forward the strategic outline case for an integrated health and wellbeing hub in Holyhead. It's been a little while coming, is what local people in Holyhead and elected members would be saying. And you know, I was across there a good few months ago now in the current premises of the GP practice, one of the practices there, and could see at first hand the difficulties of that provision, but also hearing the real potential that there is to develop a more integrated approach to health and wellbeing in Holyhead. Just a reminder of the needs of the people of Holyhead are particular and specific, and we've been having discussions, just linking the item earlier, around health and wellbeing more generally, but about children and young people, and really providing a different environment and opportunity for folks. To specifically mention the work of the IHC in the West, and Chris Rudgley, in particular, Chris Couchman and colleagues. So there's been a lot of work going on there, and the cluster, in particular, and the cluster leads have been key to this. As you say, David, there is a separate part in private because of the commercial confidence here, but what we're asking is the endorsement. At this stage, it's a strategic outline case. There are a number of steps, so you know this isn't going to be built next week, but it's the first really concrete step in moving forward on a new development. And when we talk about primary and community care, as we did earlier, it is these sorts of investments that start to make the shift a reality for people. So we're asking a couple of things, and we'll obviously want to consider the commercials later, but we are going to be looking for support, particularly in the partnership space, the integrated funds that come through the Regional Partnership Board and the Transforming Towns. So I'll just stop there.
Diolch yn iawn, Carol, ac mae'n werth nodi y gwaith ar y cyd gyda Cyngor Sir Ynys Môn ar y prosiect yma, allweddol bwysig ar gefnogaeth dyn ni yn derbyn gan y Cyngor Sir ac eraill I geisio gwireddu prosiect pwysig yma. Unrhyw gwestiynau neu sylwadau gan gymryd, gan gofio byddwn ni'n trafod yr achos yn llawn mewn sesiwn breifat. Pawb yn hapus I gymrydwyo. Diolch fawr iawn, a diolch I bawb sy'n gysylltiedig ar gwaith pwysig yna, edrych ymlaen at weld am ein nesa. Ymlaen i'r eitem nesa, sef diweddariad ar gyfraddau ffïoedd blynyddol gofod iechyd parhaus, ac eto yn absenoldeb Chris, dwi am droi at Carol, if that's okay, Carol, for landing you with this
Yeah.
item as well,
No,
please.
no,
Thank you.
and Russ may want to come in because Russ has been helping with this. So hopefully the paper's reasonably self-explanatory. We took a decision as a board in May in relation to setting the fee rates. We alerted the board in July that there were some discussions underway, and those discussions have now happened, and we've really talked about two key strands of work. One is in year, in terms of the fees that would be, I was to say agreeable, clearly, negotiable. Yeah, that's the right word. But really importantly, sitting down and doing some strategic work on how we commission differently. We've talked about this earlier in terms of community care and those sorts of aspects. And the private sector are actually very important players in this, but they're not the only colleagues as well that offer support in the community. So being able to sit down and get a strategic approach is really important. So the outputs of those conversations are suggesting that we look to revise the CHC fee based on largely the issue relating to the real living wage and the impact of that to a percentage of 6%. So just to be aware that we have been funded only 3.7%. So just on the back of the last conversation, it is money we need to take from elsewhere to support this. And we have been, straight with colleagues in the sector that is the impact of what would need to happen to achieve this. So perhaps I'll just bring Russ in for any additional comments.
Yeah, only to say the initial allocation was based on the inflation allocation. Obviously, we had 3.67%, less than 2% savings request. So clearly this offer goes way beyond the allocation we've received to support this nature of business. And as Carol suggests, we'll need to find that resource within the wider health board's modelling. So inflationary pressures will have to be contained in other areas in order to be able to facilitate us being able to offer this level of increase. And this inflationary calculation is based on real living wage plus the recent announcement of the additional inflation for pay award for general or agenda for change. So essentially, it's now a real composite for inflation, and clearly officers through discussions are looking for this to, if in effect, supplant a discussion on fee structure, whereas this is purely for an inflation allocation. And those further conversations will allude to what the fee structure should look like as we go forward and give us a more concrete platform to understand what we're thinking.
Grêt, diolch yn iawn. Cwestiynau wrtha gynta.
Obviously, this is a really important aspect of the service that we offer, really important, and generally across Wales, across the UK. The number of complex cases are increasing, so we can look to CHC costs continuing to increase. Obviously, we've also got these questions coming forward, as we know from the letter from Care Forum Wales, which is obviously again asking for more than we've allocated. But there's a lack of control for us in that arena. That's what I see, and I remember we had a previous discussion this year when we were talking about maybe other ways of finding other ways to provide. So I have a memory that it was suggested that we could provide this ourselves more efficiently, more in control. So I'm just wondering, one, have we started to model that? Can we model that? Can we look at, is that a viable thing for us to consider seriously? It will increase our control. It may still be expensive, but we will have more control.
Good point. Anyone else? So the two aspects to this is that there's the short term, which have been presented today, which is addressing the level of fee for the current cohort, if you like. And then the other question, which Eartha suggested, and you have as well, what does the future look like? What do we need to do to prepare for future provision and model and who are our potential partners in that space. So we're not going to answer that one all today, but it's on our radar, and it's really important as mentioned. So,
and that will kick off in the autumn. We've agreed that thinking through and start in earnest later in the autumn.
I think that's really important, but I just very small point, which was, and I know this is happening because it's all happening in real time, but what's the position in the other health boards in terms of their uplift? Because they all have the same issue, that 3.7% is what they're being given for compensation. So do we know, or is it, or are they taking them to the boards on the same day? Because I know that
No, they're all in different places. So I think we're more in line with Swansea Bay. I think they're about 5.something%. Some health boards are a little more than us as well. And it's really difficult because it's not a blanket. Costs are different in different places and different types of homes and all of that sort of thing. So we like to try to keep an eye on where everybody else is as well.
Yeah, absolutely. Okay, diolch yn iawn. So, ydyn ni gyd hapus I gadarnhau gyfradau sydd wedi gosod I ni. Dyn ni nodi hefyd y trafodaethau sy'n digwydd ar y fforwm gofal Cymru, a dwi'n siŵr bydd rhain parhau, ond dyn ni hefyd yn nodi yr awydd I edrych i'r dyfodol ac ystyried sut dyn ni'n llunio yr ddarpariaeth yma i'r dyfodol fel mae Eartha wedi awgrymu yn ogystal a mae trafodaethau yn mynd I ddigwydd yn yr Hydref. Di pawb yn hapus I gymeradwyo felly beth sydd wedi nodi o ran y gyfradd y ffi a'r codio I 6% yn y bôn. Pawb yn hapus I wneud hynny. Pawb yn gytuno, diolch yn iawn am hynny ac edrych ymlaen at trafodaethau pellach, dwi'n siŵr maes y law. Ymlaen at yr adroddiad nesaf, felly adroddiad blynyddol y Gymraeg tro hwn, ac dwi am wahodd Teresa I gyflwyno, a gafon ni gyflwyniad da iawn ddoe yn cyfarfod blynyddol, just lawr y corridor, oedd yn gynwysfawr iawn, felly yn werth cadw hynny mewn pob Teresa, ond cyfle I syllu ambell I beth hefyd. Diolch yn iawn.
Diolch Cadeirydd, a mi byddai'n gryno. Dwi'n meddwl bod yr adroddiad yn hunan esboniadwyd fel y gymau o. Mae'n llawn wybodaeth, a wedyn mi ddeud o'r dechrau, mae wedi bod yn flwyddyn eitha llwyddiannus, swn i'n deud, i'r tîm y Gymraeg, a Gymraeg o fewn y bwrdd iechyd. Ond mae'r adroddiad yma'n bwysig oherwydd mae yna ddyletswydd arno ni I baratoi hwn ar gyfer Comisiynydd y Gymraeg. Ond da chi'n lwcus heddiw, mae gennych chi ddau adroddiad am bris un, oherwydd ar gefn yr adroddiad mae yna adran ynglyn â mwy na geiriau a'r gwaith ar ddwyieithrwydd fel petai. Mi fyswn i'n deud, dylen ni wedi bod yn llwyddiannus, mae'r tîm wedi cael ei cydnabod ar lefel genedlaethol ynglyn â ddau award fel petai, dwi'n meddwl am y Gymraeg cofia. Tlws na fo, maen nhw wedi cael plysa arbennig a maen nhw wedi cael ei enwebu ar gyfer yr Blobra Gig Cymru. Wedyn dwi'n croesi bysedd a dwi'n gobeithio newch chi groesi bysedd. Ond o ran yr uchafbwyntiau, swn i'n deud hyfforddiant yn gyntaf, mae hwnna ar ei anterth, a fel mae'r adroddiad dwi'n meddwl sôn, mae gynnon ni giw erbyn hyn, mae gynnon ni rhestr aros ar gyfer y hyfforddiant, ond mae hynna'n deud rhywbeth, a dwi'n diolchgar I bob un dysgwr a bob un aelod o staff sy'n helpu'n dysgwyr ni hefyd. So i'n hoffi diolch i'r bwrdd oherwydd o fewn yr adroddiad, da ni'n sôn am noson dysgwr y flwyddyn, a dwi'n diolchgar iawn I Helen, ac i'r is-gydeirydd am fod hefo ni ar y noson yna, nes I orfod methu hwnna am y tro gyntaf. Ond oedd hi'n noson llwyddiannus, a mae pawb dal I sôn am hwnna, ac wrth gwrs mi fyddwn ni'n paratoi am y nesaf ym mhen amser. Ac o ran yr mwy na geiriau, mi welwch chi o ran ystadegau ESR, a dwi'n ddiolchgar I Criw Ward sydd wedi gwneud gymaint o gwaith hefo ni erbyn hyn, I wneud yn siŵr bod ni'n gallu dangos y cynnydd o fewn y niferoedd o bobl sydd wedi o lia rhoi gwybodaeth ynglyn beth ydi lefel y Gymraeg, a da ni'n wedi gweld cynnydd y fanna unwaith eto. Wedyn, dwi'n meddwl na I adael I fanna bron cadeirydd, ond I ddeud bod fi wedi bod yn myfyrio ar y flwyddyn sydd wedi mynd a wedi bod yn gwrando ddoe ar Alaw yn cyflwyno mor dda ac ar y manylder. Ma' 'na fwy o waith i ni wneud ar y safona. Fwy o waith, swn i'n deud, o ran cysondeb, ma' hwnna'n stori ni ar draws y bwrdd iechyd ydi. Cysondeb o ran yr cynnig sgynnon ni ar draws y bwrdd iechyd. Ond dwi'n meddwl bod 'na flwyddyn cyffroes arall o'n blaena ni, a dwi'n ddiolchgar i pawb am eu cefnogaeth. A wna i stopio fan'na cymryd cwestiynau.
Diolch yn fawr iawn. Teresa, unrhyw sylw neu gwestiwn gen unrhyw un, ysgwch yn dda. Billy, Claire, Rhea.
Yeah. Sorry if it's a silly question, but do we streamline our Welsh-speaking patients to Welsh-speaking clinicians where possible?
Na i atab yn Gymraeg os gael, ar eitem Gymraeg. Da ni yn trio, mae llawer o waith yn digwydd ar y wardia ac ati i wneud yn siŵr bod ni'n trio matcho, ac wrth gwrs mae gynnon ni'r cynnig gweithredol a fath o dyna oren, dwi'n siŵr bod chdi gweld nhw ar y wardia, weithiau maen nhw erbyn hyn yn cael ei dangos ar yr byrddau electroneg o fewn yn y wardia, da chi'n gweld nhw ar byrddau wrth i chi'n mynd i fewn i'r wardia. Dwi'n gwybod, da ni'n trio wneud hynna, ac yn arbennig yn y meysydd pobl hŷn, pobl iechyd meddwl, y plant yn arbennig iawn. Dyna di'r fath o blaenoriaetha. Ond wrth gwrs, dim yn hawdd bob amser, oherwydd dyda ni ddim bob amser yn dal y wybodaeth fel bod pobl yn gallu wneud y gwaith matcho na. Wedyn, mae o'r her, ond dwi'n gwybod yna waith da'n digwydd, ond ni da lle gellir gwell, mae angen wneud mwy. Wneud o'n hawdd i bawb.
Diolch yn iawn. Claire, wedyn Rhea.
Diolch, dwi'n siarad yn Saesneg. And through Gunny.
Ti'n neud yn dda
Great
iawn.
report, it's really good to see. I think Betsy is quite an exemplar really around promotion and use of the Welsh language. And so two things, the only area I could see in the paper that identifies that we have more work to do is around internal meetings. So I don't really understand what the standard says about that, so it'd be helpful, Teresa, if we could understand that and know how we might address that or what we could do to address that. And then I think secondly, there's probably some really good learning for other organisations in North Wales. So housing associations, as an example, will need to meet the requirements of the Welsh language standards from the spring next year. And I think it would be really great for the journey that the health board's been on to be shared more broadly with other organisations across the region. I can perhaps pick that up with you separately outside. Diolch.
Diolch yn iawn, cyn dod yn ôl, neu dod â chi yn mewn. A wedyn Mike. A wedyn Yrtha.
Diolch. Dwi'n gwybod o brofiad personol yn y teulu faint mor bwysig ydy cael y cyfle i siarad yn eich iaith eich hun ar draws amrediad y gwasanaethau dyn ni'n cynnig. O'n i just question really, o ran faint o'r staff sydd yn deud bod gynnu nhw ddim sgiliau yn y Gymraeg. Mae bron i hanner, 46.25 yn y tabl yma. Ydy rheina ar draws y gwahanol gweithgareddau bod, neu os yna ganran uwch o enghraifft meddygon, neu beth bynnag, syrthio o ran y gallu?
Dadansoddiad. Ie. Fawr iawn. Mike, wedyn Yrtha.
Iawn. Cymwysterau, gael ei ddeud, wel, ni gadeirydd o a gyngor dosbarthwyddol, oedd yr unig gyngor yn Nghymru oedd yn gwneud popeth trwy gyfrwng y Gymraeg. Byddwn ni'n gwrthod, byddwn ni'n gytuno fo dro i dro, ond mi fyddan ni'n gwrthod wneud i ddyn nhw, ta waith yma ni. Gofyn y cwestiwn ydw i, mewn o bosib o brwdfedredd pobl yn y maes, sut ydyn ni'n gwarchod bod ni yn addysgu ac yn dysgu bobl mewn modd bod ni ddim yn rhithro i Gymraeg yr ysgol haig. Achos dwi wedi bod mewn cyfarfodydd pobl ar y stryd sydd yn gwrando. Mae'n gofyn mi, be'n ei gwyddo'n lle basio, gallu, dwi'n yn fyw i hynny. Dwi eisiau pobl sydd ar y stryd, dyna'r math o Gymraeg ac yn y gweithlu hefyd wedyn. Jyst i fod yn gwarchod ac hynny.
Pwynt da iawn. Wrtha?
Ie, jyst pwynt fi, a dwi'n meddwl jyst i cefnogi be oedd yn dweud, mae'n rili bwysig i ni rhannu be da ni wedi bod yn dweud, cos mae o'n llwyddiannus iawn, yn diolch yn fawr iawn i Awel Roy a'r gwaith ti'n wneud hefyd. Ond dwi'n meddwl mae'n bwysig i ni rhannu'r costau hefyd, so pa fath o costau sydd yn cefnogi yr egni sydd wedi bod o dan y datblygiad yma, so mae hynny'n bwysig hefyd. Dyna.
Diolch iawn. Teresa, sylwadau ar rhai o'r pwyntiau yna, plis.
Diolch i bawb. David Clare gynta. Mae yna grŵp cenedlu, rhanbarthol o ran y Gymraeg, mwy na geiriau, mi fedrwn ni rhoi eich tîm chi mewn cysylltiad. Ond fysa ni wrth yn boddau dod i sôn am ein hanes ni a'r siwrne, da ni dal arno wedi fod yn cael Clare, dyn diolch i chi am y cynnig. O ran y safona, mae yna disgwyl ar byddai i chi wedi bod yn neud, da ni'n wahanol iawn i ma'n Gogledd Cymru, da ni yn cynnal y bwrdd yma yn ddwyieithog a dwi'n ddiolchgar iawn bod gynnon ni gyfieithydd yma heddiw, fel bod ni yn cynnal pethau yn naturiol, a diolch i chi cadeirydd am cynnal y bwrdd yn ddwyieithog. Mae yna disgwyl bod ni yn cynnal math yma o gyfarfodydd fewnol fel petai yn ddwyieithog os yn bosib. Ond wrth gwrs, dim ond ni fel bwrdd iechyd sydd yn neud o fel hyn ar hyn o bryd, ond mae yna disgwyl i eraill i'w ddyn. Da ni wedi sôn hefo Pam ynglyn â wneud rei o'r pwyllgorau yn ddwyieithog hefyd, wedyn mae hynny'n opsiwn a da ni wedi rhoi cynnig ar hynny yn y gorffennol. Ond ar y cyfan, rei o'r meysydd lle mae yna angen mewnbwn clinicol ydy lle mae'r safona yn gweithio ar fewn. Wedyn, os gai cadeirydd, oherwydd mae'r safona fel bingo go iawn yn mynd o 100 i 157, mi na i wneud yn siŵr bod fi'n cael y geiriau i Clare ac i'r bwrdd a rhannu fo pawb. Be ydy'r disgwyl? A mae'r geiriau yn bwysig oherwydd dyna lle mae'r gofyn o ran y comisiynydd. Mae rhian yn iawn, yn berffaith iawn. Mae canlyniadau i'r claf mor bwysig a gymaint yn gwell os ydy'r gwaith a'r triniaeth yn cael ei wneud yn iaith y person fel petai. Hunan asesiad ydy'r gwybodaeth sydd yn y ddogfen sgynnon ni, ond da chi yn iawn, da ni yn gweld gwahaniaeth ar daws y proffesiynau. Sgynnau mor manylion yno ymlaen, mi o'n meddwl fynd i dyrchu dipyn os da chi isio. Ond be da ni'n neud ydy trio neud yn siŵr fod teleffoni a dydwch y derbyn yn weithio. Da ni yn trio neud gwaith targedu a mae'n dod i swyddi hanfodol a swyddi lle mae'r Gymraeg yn dderbynio ac yn ddymunol. Da chi'n iawn. Dwi'n sy'n rhaid i pobl fod yn academig. Dwi ddim yn academig. Fedra i ddim siarad cystal â chi, dyfe. A fedra i'n siarad cystal â'r cyfieithydd. Ond desol, dwi'n rhoi cynnig arni, a dyna sy'n angen. Ond o ran yn staff ni, da ni wrth gwrs yn cael wthnos y Gymraeg. A be da ni'n deud ydy, defnyddiwch eich Cymraeg. Wedyn, fel ddynsoch chi ddoed, Deirydd. Defnyddiwch y mymryn sgynnoch chi. Bore da, pnawn da, diolch. Dwi'n clywed pawb yn rhoi cynnig arni. A wedyn, cwestiwn yrtha, mae yna bost i hyn, a mae'r bwrdd iechyd a'r byrdda iechyd a'r grwpiau iechyd yn hanesyddol yn Ogledd Cymru. Wedi blaenoriaethu rhywfaint o hyn, wedyn, a gynno ni dîm chwarae teg. Derbyn hyn, mae'r gofyn, dwi'n mynd yn fwy na'r tîm. Ond ar ôl deud hynny, dwi'n meddwl bod ni'n gweld buddiannau gwaith hynny yn yr adroddiad yma, yn y gwaith sy'n digwydd ar yng Nghordia ni ac i mae'n cymorth i'n staff, ond dwi'n siŵr sy'n ni'n gallu rhannu rhywfaint o hynny os oes diddordeb.
Gweithio. Ac gai yna hefyd ddiolch i'r tîm sydd wedi bod yn gweithio mor galed ac sydd yn helpu creu llwyddiant. Y newyddion da ydy, mae gen i hyd yn oed mwy o uchelgais i ni fel bwrdd. Dwi'n credu gallwn ni gyflawni mwy yn y gystal. Ac yn hynny, dwi'n awyddus i pwyllgor pobl a diwylliant gael cyfle i drafod, wel, be'n union dyn ni eisiau cyflawni fel bwrdd. Mae rhaid i ni gydymffurfio gyda mesur y Gymraeg ac yn y blaen, wrth gwrs bod rhaid i ni. Ond dwi'n meddwl bod o'n amserol i ni gael amser i feddwl fel bwrdd o'r gored. Dyn ni wedi cyrraedd lle dyn ni wedi cyrraedd, lle dyn ni eisiau mynd nesaf. A sut mae'r dyfodol na'n mynd i edrych o ran y Gymraeg ac defnydd o ieithoedd o fewn y bwrdd iechyd. Felly dwi'n gobeithio bydd y pwyllgor yn gallu cael y drafodaeth yna yn fuan. Ond eto, diolch yn fawr iawn I bawb am y gwaith a diolch am yr adroddiad ddoe hefyd. Pawb yn hapus I ni dderbyn ac I gymrydwyo, diolch am yr adroddiad yna. Diolch yn fawr iawn. Ac ymlaen i'r adroddiad nesa, adroddiad blynyddol lefel staff nyrsio. Ydy hwn, a dwi am throi at Angela ar gyfer y adroddiad, please.
Diolch, Chair. So the report in front of you is the 3-yearly assurance report on compliance with nurse staffing levels as part of the Act. We received this report in its first stages in March with information up to the 31st of January, with the expectation that the extra information would be included, and then we submit it to Welsh Government in October. This is on a template developed by the All Wales Nurse Staffing Group, so we're obliged to use this template, and when we do our 6-monthly reviews again, we're obliged to use the template that's provided. It gives information around all of the improvements around Nurse Staffing Act. So with support of finance since I've arrived, we are now compliant and meeting with the Nurse Staffing Act requirements, which is articulated within the report. Out with that, we're also working around the wards that are not part of the Nurse Staffing Act. So just recently, the finance team and the HR team have been supporting me to do the reviews for our emergency quadrant, our mental health learning disabilities division, and our community hospitals. And Russ and I have been meeting to discuss how we align where we are from a support and budgeting point of view and the improvements that we actually need to make. So I'm happy to take any comments, but to note that it's just an add-on to what we've had previously.
Diolch yn iawn. Unrhyw sylw neu gwestiwn? Gareth?
Just very briefly, I mean, thank you very much for this report, and thank you particularly for highlighting where the changes have been. I was about to write a note when I was doing my notes saying, couldn't you just point out that I got to the bit where you said yes, so thank you, that was really helpful. I mean, just to sort of like dog that just
heard you.
Yeah, dog that doesn't bark is I mean, I think it's really useful to have it, but I think it's section 25E about trying to see whether there's any link between patient harm incidents and this never something, and basically it suggests there isn't, which at one level is positive. Another level it shows that the challenges are more about, I mean, obviously sometimes there will always be some incidents, as we talked earlier, but it suggests that the issues are more about culture than number of people. So as I said, in a way that's encouraging because the culture is something we're already really working on. But yeah, thank you for the report, and that it's ready to go now.
Billy?
Diolch, Doctor. I've got three points from the report, but looking at the data in these assurance reports, where plan rosters are not met and not appropriate, the mitigations always seem to be the same. We ask ward managers to work clinically. We ask staff to work extra hours and shifts, and of course bank usage. And yeah, I'm just concerned that we burn our staff out doing that. My second question is that we've just had the Welsh Government pay circular, and that doesn't mention bank. So the award won't be applied to bank unless we decide it's going to be. And I worry that bank will vote with their feet, especially where they have choices and further challenge the nurse staffing levels. And finally, we are facing a cliff edge in nurse recruitment, recruitment and retention, and lots of nurses are going to be retiring soon. Applications for nurse training are tailing off. For me, there's certainly ethical implications in international recruitment. So we've got more challenges in the future to nurse staffing. What are we doing to encourage young people in North Wales who enter the profession.
Okay.
Angela?
Yeah, no problem. So thanks for the questions, Billy. From your first question around the planned rosters and the mitigations that we put into place. So Band 7s, as you understand, are completely supernumerary within the health board, which is obviously really good practice and allows us to support the staff on the wards and do development. We do utilise Band 7s coming into the numbers should we have short-term sickness and we have areas that have got increased acuity and we need to have that support. That is balanced with making sure that the matrons are supporting and the heads of nursing are supporting those areas and trying to release those Band 7s as soon as we possibly can to do that. I meet with the Band 7s on a monthly basis and have conversations around the amount of time they're spending clinically and what I can do to support and what we can do as an organisation to support. We have reduced our vacancies from in the last probably 15 months from 14.5% to 8.5%. So we have seen an increase in substantive staff on those wards. So the opportunity for us to not have to use those Band 7s on a regular basis should actually be there. We're also utilising agency and bank in a much more effective way and doing planning around that. We've seen a reduction in our use of agency because we have got reduced vacancies and because we are planning on what the staffing models are going to be and completing our rosters in a more effective way. So we do have roster management meetings on a Wednesday morning with the heads, the directors of nursing and associates to look at what that compliance is. And now we've got a dashboard that actually went live last week where Carol can drill down into where our wards are applying their rosters and making sure that allocation of annual leave or study leave, etc., doesn't actually deplete the wards. So we're making sure that it's appropriately utilised. Okay, we do offer staff extra work if they've got vacancies, as well as applying bank. We do have substantive sort of bank staff who only work bank and don't work on the other wards, but the ward managers and the matrons are very clear to watch how much extra the staff on the wards are doing to support them not to be burnt out and that we maintain their health and well-being, and that is an offer, obviously some of the resources that HR provide to enable us to do that. So obviously it's something we're mindful of, but from I'm 37 years like Carol, and there has been agency use and bank use over that time, and we need to make sure that we are supporting people who need to do extra work as well because of financial climates and things like that. On the second one around the bank and the pay circular, there hasn't been an identification yet, but as Exec Director of Nursing and as the EDONS group, we will be highlighting that to NHS employers to identify whether that will be something that's taken into consideration. If not, as in previous rises that we've had around bank, we will take a paper to execs for discussion around that. We had one fairly recently, and that will be taken forward. So we don't want our bank staff to be disadvantaged and lose them because they are really supportive in delivery of our care. And we have a lot of staff who are utilising bank for flexibility. Said that, because of the increase within our vacancy, opportunities now, we've got those less vacancies. We are encouraging our bank staff to become permanent with us, and we're actually asking agency staff to convert to bank and then move over to be permanent. And that's been really successful in the last 6 months. We've seen a number of areas. We don't actually use bank or agency anymore. We don't need to because we're fully staffed, which is an amazing position to be in currently in the current climate. And then from the perspective of nurse recruitment, so we are looking at opportunities of how we can make sure that we've got the nurses where they need to be. So we're looking at care around the bedside, so utilising multidisciplinary teams to look at that care delivery. And we've got a workforce planning team that are going to be joining us and supporting us to be able to do that, to identify the right patient at the bedside or within the community, providing the care where it's needed. I'm leading on the parameters of practice work for the nursing associates we're introducing in Wales. So that will enable us to do that wraparound care as well. We're also looking at school visits and work experience. So HR colleagues are supporting us going out to local schools and colleges to identify what opportunities there, not just for nursing, but for AHPs, for admin, clerical, finance, etc. And we do have a cadet scheme
that has commenced looking at bringing students from 16 to 18-year-olds into the organisation and giving that succession to allow them to progress into nursing. We've got progression of healthcare support workers. So we've got Band 4 support workers who are being sponsored to go on to do their nurse training. They live locally, they're committed to the health board, and they will come back and work for us. And then we're looking at graduate training as well. There are a number of universities offering graduates from different areas to come and top up to become a nurse. So I think although it does feel a little bit daunting going into it, I think we do have a number of opportunities. And if we can get the culture right and we can get where we need to be right, then we'll attract people to come and work with us and we'll be okay.
Great, diolch yn iawn. And it just struck me, Billy, I'm just checking, as our trade union representative and as our CN rep, are you plugged into where you need to be to raise these questions and get information elsewhere? And if not, maybe, Angela, you can have a discussion with Billy to make sure that happens, not just at board meetings, but elsewhere, and make sure you have that engagement. I think that would be a positive thing to do.
That'd be helpful.
Great, diolch yn iawn. Pawb yn hapus i dderbyn yr adroddiad yna, felly, Mike?
Could I just ask a question in regards to what Billy was asking really, is that do we have, as an organisation, some kind of graphic or a projection of where there's going to be a drop off because of the demographic and age profile of staff?
Yeah.
Do we have future projections of where it's likely to dip?
I'm really hoping that all our workforce planning and what we discussed yesterday, I think in our discussions around planning and strategic look to the future, we'll be able to capture that. But also the People and Culture Committee, I think that's something they could look at, future needs and the pipeline that serves it, and are they in sync, and what do we need to do? So hopefully that we'll be able to address that. Pawb yn hapus i dderbyn y adroddiad? Gwych iawn, diolch yn fawr iawn i bawb, a diolch am y gwaith yna. Nesa yw adroddiad ar yr ymchwiliad Covid, roi diweddariad i ni mewn gwirionedd o'r sefyllfa, a dwi'n meddwl dwi'n mynd i droi at Jane ar gyfer eitem yma. Diolch, Jane.
It's a joint.
Right, okay. Over to you then, Pam.
I'll kick off and then Jay might want to come in on the, because it links to the next item, David, as well. So, this paper the paper's hopefully is self-explanatory, but it gives an update to the board in terms of the recommendations that have been published from the Module 1 inquiry, which are covered in the report. I suppose we've also tried to give an update of as other progress in terms of other modules into the inquiry, so we can make sure the board is fully cited. As you'll appreciate, it's a moving beast, and Glesney in my team plays a very active role in managing not just this, but we heard about the Thirlwall inquiry earlier, and there's been some work in terms of the infected blood. So there's a lot of public inquiries where we need to distill the recommendations, opportunities for learning, and how we can reflect those in the health board. So you'll probably get a sense there's quite a piece of work around distilling some of that. So in terms of this report, it aligns back to our annual delivery plan, where sort of commitments that we would take on board in terms of any learning lessons and actions we needed to take as a health board. Obviously in section 4 of the report details the findings and from the published report in terms of module 1. What Leslie and Sharon in Jane's team have done, they've mapped the sort of recommendations to what we call the current health board state and potential future requirements. I think it's just important to recognise some of this. There will be a national piece of work, because obviously this is not just local health board, it's at a Wales and a UK wide basis. So there will be some national groups and national frameworks or information or recommendations that are likely to be coming out to health organisations. But this report is that we're starting to look at what the recommendations are, starting to make sure where we need to make local actions and local changes, we're building those into our plans. It should give the board a level of assurance just in terms of how we're dealing with some of those. And I think Jane will probably come on in perhaps in the next paper around the work in terms of it's, you know, emergency preparedness, resilience and response, just in case it rolls off the tongue, in terms of some of the work that is going on across the organisation, and it's through the PPE committee. I think the last thing just really to say, David, we've taken this through our executive team. We've agreed to set up a steering group which will start to look at not just this inquiry but other inquiries. We'll need to have a wide membership in terms of that group and draw people in as necessary. So it's an active piece of work, ongoing piece of work. Just wanted to bring this to the board to give them the opportunity for sightedness, and I think I'll probably take it through your committee, Claire, just in terms of regular updates on progress. Yeah, I didn't know whether you wanted to add anything.
On the forward inquiry work in particular, before we go to the next item.
So, this is module 1, so it was about the preparedness. So a lot of the headlines were about how government was not prepared for this. The implications of this, though, do apply to us as a health board, because it will have some significant changes to what is expected in terms of being prepared for future events, and the degree of oversight that we will need to put around that sort of civil contingencies. So we will be working with the national around what that means in terms of the standards and what is expected as a health board that we will be needed to deliver. We are also looking, and this is from the health protection as well as an EPR, what everybody is saying is the next pandemic will not look like the last one, which didn't look like the last one. So it is about that planning for how do you manage a significant outbreak at a population level. So there will be a separate piece of work which is really looking at how do we get a single outbreak and highly contagious infectious disease plan that we can monitor, because what we have already seen in post-COVID, we've had COVID, we've had Mpox, we've had measles, and we've had a couple of other things, all of which show that actually we need a core plan that can be acted against any of these, and that people do know what to do, because each time the evidence has been we've had to relearn things. So all of this will be being built in as part of this, and there's going to be a lot more learning to come from future models, but this one really focuses much more around the emergency planning that we're going to need to do.
Great. Diolch yn iawn. Unrhyw cwestiwn? Mike.
I've asked it before in other kind of forums, but is it a default kind of position that when we're designing, particularly new buildings, that this is taken into consideration, whether it's with flows in and out of the building, but the practicality of a building that might potentially need?
Yeah, I'm just keen that we concentrate on the COVID report first before going on to the emergency preparedness, resilience, EPPR, and that is an issue which I'll ask you to address afterwards. But on the COVID, any questions, please? Gareth, within that.
Well, just a comment, which is about I'm glad in a way you've addressed it, but I think it is sensible to have the steering group, but you will need to be flexible in the membership because it'll cover quite a wide range of different things, won't it? Yeah. But the question was just, I noticed that module 3, which is probably the one that's most directly relevant to NHS bodies, so it's what happened in these areas of treatment during COVID, is now underway. And I noticed they only seem to be taking evidence in London, and like with the previous where they moved around. So has there been any request for input from this health board or Welsh health boards in general about these issues, or are we off the hook, if I can put it that way, in terms of giving evidence?
Before you respond, I'll bring Ursula in any other question, and then I'll ask Pam and Carol to respond.
Thank you. Obviously, this report confirms lots of discussion we've all heard in the media about the preparedness and perhaps lack of honesty as well going on in certain quarters. And I know that module 6, module 7, they're going to be happening quite a way down the line. So I'm just wondering what the timescale is to feel that we would have our systems in place if an emergency did happen. When would, we have any idea of what this timescales might look like? When might be ready to, yes, it would be 2026, if an emergency happened, we could respond. Just a question. I might do something.
Any responses, Pam and Carol? Any?
I'm happy to pick up. So module 3 is
Yes.
underway. I know that colleagues from Wales have been to London, and so that will take a Wales look as well, not specifically, but and we did submit a information into module 3 as well. Just as a footnote, module 10 has now been announced, which is going to look at the impact on society. So that's quite good. Yeah, not quite sure.
Yes.
But we'll get to that one. I think Eartha's question about are we ready for an emergency really comes into, this is why we've linked civil contingencies and this, because we can get all sorts of emergencies. And I recall very early on in the pandemic, before we really knew it was a pandemic, about whether this was a rising tide civil emergency or what lane it would be in. Ultimately, we need to think about any emergency, national power outage, floods, all of those sorts of things, as well as infection.
Diolch yn iawn. Felly, nawn ni at y droliad nesaf mewn munud, ond ydym ni'n hapus I nodi y papur yma ysgol yr argymellion o modiwl 1, a nodi hefyd yr pwyllgor yna, grŵp lliwio sydd wedi cael ei sefydlu gen ni fel bwr iechyd I barhau ar gwaith. Pawb yn hapus efo'r argymellion. Diolch yn iawn. Ymlaen i'r eitem nesaf sy'n sôn am yr Rodryd am argyfwng yr EPPR neu EPRR yn hytrach. And you've talked a little bit about this already, Jane, but if you want to add anything else, and some people have already raised questions around it, so if you could address those at the same time, that would be great. Diolch.
So I'm not going to go through the project, it's fairly clear. What I will say is this is a work in progress. So we do have plans. We have and we do have business continuity and civil contingency. So all of those, what there are is issues about how up to date those plans are and how much they reflect the sort of current understanding of what we would need to deliver as a health board. And that sort of slightly answers Eartha's, because one of the things is we are not going to wait to 2026 when some of these things. So we are already using some of the best practice, such as the standards that England uses around assessing itself against its plans, because they are much more detailed and much more specific than the Welsh ones. And we are already planning on the learning from some of these things about making sure we're ahead of the curve in terms of the things we know we need to be prepared for better. That's come out of not just this, but some of our looking at where we are and where we are with partners in North Wales, also planning for the environment in North Wales in terms of the possible things that could happen given the nature of the industry and other elements that we have within the North Wales environment. And that also leads to the final point I want to make. What we are also looking at is how we actually work better with our partners around that civil contingency. And actually, there was another final point I'll forget, which is the other thing that we probably have not been good at is testing and exercising.
Yeah.
And that links to the partners, because actually, so one of the first things we're doing is on call is to make sure everybody has had some basic on call training.
Yeah.
That actually means that everybody is clear about what they should be doing at bronze, silver, and gold level. Partly because my view is that nobody should be doing on call unless they've had some basic training.
Absolutely. No, and the matter that Micro's preparedness of the estate, if I could describe it like that, is our state in a
It is.
condition?
So one of the things we are looking at is things like evacuation and isolation, partly because of a couple of issues we've had around infectious diseases, actually.
Yes.
So all of those are all part of this, and but we're having to do this in a sort of staged way. So because there's quite a lot of work across the board, so we are trying to pick out the things we need to do first, and then sort of get a line of sort of planned work over the next 18 months or so.
Yeah, just a very brief one on the estate, and I think we need to think very, very differently. So the whole climate change issue, extreme weather, adapting our buildings to what the future is going to look like. So I think that's in that lane as well, in terms of preparing for hotter periods and how we wetter, yes, how we adapt to that.
Great.
Floodings.
Yes. Reit, pawb yn hapus I dderbyn y adroddiad yna, a diolch yn fawr iawn am y gwaith pwysig iawn. Mae'r adroddiad blynyddol yna yn rhoi cipolwg I ni yn dydi ar yr holl waith sy'n digwydd. Pawb yn hapus, diolch yn fawr iawn I chi ymlaen. Adroddiad nesaf sef adroddiad Llywodraethu Corfforaethol, a Pam troi at Pam ar gyfer y adroddiad yma, please. Diolch yn fawr iawn, Pam.
Diolch yn fawr. I'll take the report as read. Just a couple of approvals from the board today to ratify the chair's action on the 13th of September, which we agreed to do because that's a matter reserved for the board in terms of the legal proceedings in relation to emerts. Other matters are for information other than to ratify joint committee governance arrangement, so that is included in a separate pack. And that's helpful. It has been through we had the board, remember, I think it was probably March meeting, we had the initial documentation. Work has been ongoing in relation to that. It's been through the joint commissioning committee, which Carol is a member, earlier this month, so just asking the board to ratify the governance documentation. That becomes part of the health board standing orders. So what we will do is, following the ratification, we will update our standing orders so they become as part of. And then finally is just to ratify the approved commissions. Doctors, as we're required to do, and again, that's included in the supporting pack. Happy to take any questions. David.
Diolch yn fawr iawn, Pam. Unrhyw gwestiwn? Na, ydy pawb yn hapus felly I gadarnhau to ratify, as Pam said, the chair's action, also ratify the Joint Commissioning Committee governance.
Which we have no options to change anyway.
And ratify the commission's section and doctors across Wales, and that's the role we play for all Wales, of course, in that. Pawb yn hapus I wneud hynny? Iawn, diolch yn fawr iawn, diolch yn fawr iawn am y gwaith. Yna, mae hynna'n dod â ni at adran gwybodaeth, ac mae gennym ni adroddiadau cadeiraddio yn y pwyllgorau a'r grwpiau cynghori, yn y restr ohonyn nhw yna. Gwybodaeth, ond os oes yna rhywun eisiau holi cwestiwn, dwi am roi cyfle. Unrhyw un eisiau holi rhywbeth? Na. Wel, gored, diolch yn fawr iawn i'r holl bwyllgorau am eu gwaith nhw. Gowch chi flas o'r gwaith sy'n digwydd yn y papurau yna, a mae yna waith mawr a manwl yn digwydd. Diolchgar I bawb sy'n rhan o'r gwaith yna ac sy'n ymroi'r gwaith, gwaith pwysig iawn. Mae Terry'n ei gloi, felly dyn ni'n dod at derbyn y cyfarfod ac un eitem dyn ni'n trafod ac yn ceisio trafod bob amser ydy effeithiolrwydd y cyfarfod. Unrhyw un efo sylwadau? Any thoughts about how the meeting has gone today and how we can improve things in particular? Certainly point out things that aren't good, but also if we can think of the future and how we can improve our meetings as well. Claire, you've got some thoughts.
I wanted to thank Pam and the team. I think there's been quite a lot of change in these papers today to reflect feedback from the board. So I think it was great to have some of the clunky information in as a separate pack for us to review separately. I think the recommendations in the papers are much clearer now. So I think we're moving really positively forward in terms of the quality of the papers. So thanks for your leadership, Pam, but to everybody else who's obviously responding well to that. If I had one thing I'd ask, it'd be that the meeting didn't need to last 5.5 hours, Chair.
Yeah.
But we have a lot of business to get through, and it's hard to give the items the time they deserve and make the meeting much shorter, really.
Yeah.
Other than meeting every month, but I think I'd rather have every 2 months than a longer meeting.
Yeah, no, good point. And the litmus test for me will always be, are we spending the time on the items that we need to? Obviously, everything deserves our attention, but there are some things that we really need to ensure we're spending time on. So that's a good test. Gareth?
Yeah, I just echo that, but also say I think that the order of the papers, I mean, with no disrespect to things like EPR, which are really important, but they're effectively telling us what is and isn't working so that we know.
Yes.
But I think generally the orders work much better, that we've actually had the time that we needed for the things that we needed to give real input on. So, you know, I agree.
And I think we're developing a series of discussions around key areas, aren't we? We've had planned care, we've had urgent and emergency care today, and I think those discussions have gone well from what I've seen, but you may have some thoughts as well. Billy?
Yeah.
Bring in there.
I know that we've had board meetings in the West. We've had quite a few board meetings here. We ever had board meetings in the East?
I think in the past that has been the case. What we're trying to do is, for board meetings, we're trying to identify this place, this venue, as the ideal place for a whole host of reasons, mainly around the technology and our ability to broadcast and get all the tech correct and the type of room. At the same time, we are holding meetings across the health board area, for instance, as Mike referred to the one in Mouldy the other week. So we're not too concerned the fact that we have to move the formal board meeting around from one area to the next. We're more concerned about getting in a good place where everything works for us, quite frankly. And Linus is with us. Linus and others did, and Diane did a huge search about 12 months ago to look for appropriate venues, and there's a shortage that can take us all as well, and appropriate space. So we're more concerned about the right venue to get the meeting running successfully, but we use other meetings to reach out to communities and engagement events in particular. So yeah. Unrhyw arall efo rywbeth I ddweud before just bringing Pam, who will have some comments, I'm sure, as someone who's been in the heart of getting all this running like clockwork, and Diane and the team and Linus and Philippa and others, and Laura, really grateful for all the efforts putting this together. It's always, we always seem to be really fighting to get things done around the meeting, and really grateful for everybody's efforts. And Diane has gone more than the extra mile. Diolch o galon I ti, Diane, am fynd yr ail ar dryder i'r mewn gwirionedd. Diolch o galon. Pam, some thoughts about helping us in the future with the meetings?
Just really, I suppose, thanks to the board, thanks to everyone for giving us really helpful comments as we go on this journey. As I say to Gareth, we're on the journey. Just reflecting, it's my third board meeting. I might feel like it's meeting.
She's not one of the 14% who leave in the first year.
Don't worry. I suppose it's just really, I thought it's always good to just check in where we are, and I think having really good there's a good chunk of time focusing some on big strategic issues today. So I felt that we gave that the time it deserved. I'm starting to see a really good flow between the board and committees. So we get the item and then scheduled care, for example, now take that back through the committee. So I think that feels
and flow in the other direction as well.
yeah, so I think we're I think hopefully going back to Claire's point, really great. We've got a minute left and we will have bang on time, so great to chair, David. And I just really want to say thanks to the team actually, because people might not always realise the preparation, getting us to this is actually really quite hard. But actually, if you try to just do a bit of work on the timing of the agenda, so I think that's worked well. So I just wanted to share those observations and thanks to the team that do the hard work for us.
Diolch yn fawr iawn. Unrhyw un arall rhywbeth i ddweud? Na. Gai ddiolch felly i bawb am y cyfarfod heddiw. Diolch am eich cyfraniadau a diolch am bawb sydd bod yn rhan o'r gwaith paratoi fel arfer. Unrhyw un efo rhywbeth i ddweud o ran ein cyfarfodydd bwrdd, mae croeso unrhyw un gysylltu efo ni unrhyw amser wrth gwrs, yn arbennig os ydych chi'n teimlo bod angen i ni ddatblygu rhywbeth ymhellach, croesawu unrhyw awgrymiadau cadarnhaol bob amser. Dyna ni rwan yn cadarnhau cyfarfod nesaf sydd 8:20 o Dachwedd mewn 2 fis, ac rwan dyna ni'n symud i sesiwn breifat, ac felly dwi'n cynnig i wahardd y wasg a'r cyhoedd yn unol ac adran 1 Deddf Cyrff Cyhoeddus 1960 a bod ni'n symud i sesiwn breifat oherwydd natur gyfrinachol a masnachol y busnes. Ydy pawb yn cytuno i ni wneud hynny?